1, 2. Check. Hey. 1, 2.
Gentlemen, I wish you all a very happy and morning evening. We welcome you all to the day 2 of BRONCHUS to our very own city, Hyderabad. We now quickly begin with our morning didactics with session 1 on airways tenting and suturing by Harvey Dattao. It will be a Zoom online lecture. Thank you.
Hi, everybody. It's always a great pleasure to be in contact with my Indian colleagues, above all the guys from Yashoda Hospitals, Hari and Visves. So Hari Kishan invited me to speak, to give a lecture about airway stenting and lessons learned from the beginning. Because the beginning, maybe you don't know, that the cradle of airway stenting is Marseille. This is Marseille, France. This is why I'm invited to speak about this topic. My conflict of interest slide. Most important is that I am consultant for Novotel. Novotel is a French-German company now, which is producing silicone and metallic stents. This is the timeline of interventional pulmonology, and you see that in the red square, that airway stenting started in the 80s, previous centuries, with my mentor, Dr. Dumont. Indeed, he placed the first silicone stent in a patient suffering from benign tracheal stenosis in 1987, and the first publication was issued in Chest Journal in 1990. So the idea at the beginning was quite simple, just silicone tube with threads around to prevent migration. Simple idea, and it finally proved to be, as I will see, efficient in certain conditions, certain indications. So let's make a short panorama overview of existing stents. So these are the original silicone stent manufactured by Novotel and designed by Dr. Dumont. So on the top of the slide, the Dumont stent with also the hourglass stent. And rapidly, other companies started to produce their own silicone stent, like the Wood company, Polyflex stent, Nova stent, Nopen, and rapidly, silicone stent came into bifurcated stent, white stent, for the treatment of condition at the level of the carina. So Dumont white stent and also the dynamic stent, which is not strictly fully only silicone, but you have also metallic rings inside. In the same time, in parallel, some metallic stents were already existing, but they were mainly placed in vascular disease, coronary disease, but some colleagues tried them in the airway of patients, and unfortunately, mainly in kids, in pediatric indications. So the third generation were not self-expandable, but balloon expandable metallic stents. So you had brands like Gianturco, Palmas, Strecker. Given that they produce a lot of complications, high morbidity and even high mortality, even in kids, I do believe that they are no longer placed in the world now. Then the second generation arrived in the market, the self-expandable metallic stent with as the leader stent, which is the Ultraflex. Ultraflex that comes with two kinds, uncovered, as you can see, and the covered stent. But even the covered stent is not covered at the two extremities, at the two tips. But they are quite easy to place, even with a flexible bronchoscope, even if in this picture it's with metallic rigid bronchoscope, and they became very popular as well as the Dumont stent. So when I was waiting at Belgrade Airport in 2007 with a very famous Indian-American interventional pulmonologist, Atul Mehta. Atul Mehta was editor-in-chief of Journal of Bronchology and Interventional Pulmonology at that time, and he said, well, Hervé, maybe it's time because 2007, 1987 is the 30th birthday of airway stenting. You should write an editorial with Dr. Dumont. This is what we've done. I think editorial is not very science, but for me, it's one of the most important paper I wrote, and above all, the only one with my mentor, Jean-François Dumont. And I will show you some messages in the next slides. Just, I wanted to show you this slide with the evolution of airway stenting in Marseille according to three periods. Period 1, 1987-1997, period 2, 1997 to 2007, and 2007 to 2017, date of the publication of our idea to treat malignant obstruction or compression, benign tracheal stenosis, benign bronchial stenosis, airway fistulas, tracheal bronchomalacia, and even indication like tracheal bronchial amyloidosis, tracheal bronchopathia chondroplastica, and some rare disease. And I have here listed publications from our centers on our experience with these indications. So at the second period, we started to learn from our first period. If we look only at malignant obstruction, clearly the best indication for airway stenting is external compression, because you have nothing to core out, you have nothing to debulk, you just can put a stent to relieve the compression, so it's still a perfect indication. And at that time, in interesting obstruction, the rule was to, after, of course, successful tumoral debulking, was to place a removable stent in order to prevent recurrence in case of failure of oncologic treatment. For benign tracheal stenosis, because of the first period, even our surgeons, thoracic surgeons, lost their skills in operating the patient. But we found out that it was better to operate patients if they could be operated. Even though stenting, if patient is not operable, stenting can be curative in about 70% of the cases, but the problem of stenting in this indication is that it requires long-term care. So you need to make nebulization every day as long as the stent is in place. You can also have rare but potentially life-threatening complications. So clearly we learn from this benign tracheostenosis, benign tracheal disease, that if surgery could be performed, it had to be performed, and stent was only reserved to non-operable patients. This is very important if we look at the history of our stenting, is a warning from FDA issued in 2005, and briefly it says that in case of benign tracheostenosis you should avoid placing metallic stents, and you should consider surgery, of course, as I mentioned, and silicone stent placement. So, but this recommendation was mainly focused on the ultraflex, so the non-fully covered metallic stent. But it was very important because at that time we received in Marseille a lot of requests for training from our American colleagues to place silicone stents. But despite this warning in 2005, I was asked in 2011, to review a paper from a Greek group about their experience with the ultraflex in 11 cases. So my first reaction was to consider this paper to be just delayed, refused. But the editor-in-chief said, okay, maybe we could accept and you will write an editorial. And so I wrote it. I was stenting for benign tracheostenosis. What is really behind the choice of the stent? And the answer is quite easy. The answer is the skills in real bronchoscopy. Because if you are not skilled in real bronchoscopy, you cannot place silicone stent, so you have no choice. You have no choice. If you know how to perform real bronchoscopy, you can choose whatever stent you want, silicone and even metallic. And above all, I will show you that we have now convenient metallic stent, fully covered metallic stent. So the key for any kind of airway stenting is rigid bronchoscopy, in my opinion. So now, this is algorithm that we learn from first experience in benign tracheostenosis, is that for simple tracheostenosis without cartilaginous damages, most of the cases you can manage them with only endoscopically, without surgery. It's a very famous technique described by Atumeta first, when you make incision and you dilate, and most of the time you treat this patient. But in complex tracheostenosis, meaning damages of the cartilaginous ring, if you dilate, you will have a recurrence in about 70% of the cases. So the algorithm is to dilate first. If the patient is operable, it goes to surgery. If the patient is non-operable, then you place a removable stent. And removable, in my opinion, is either silicone stent or fully covered metallic stent. And and as I mentioned, if you let a stent in place close to 18 months, in the literature you will find a 70% rate of cure of the disease. So it's the actual algorithm that we use for benign stenosis. Other lessons, another indication, tracheal bronchomalacia. Tracheal bronchomalacia look like a possible indication, but finally it proved to be a very bad indication for stenting. It can provide short-term improvement in symptoms, as it has been stated in two publications listed below, Armin Ernst and Tim Morgu. So you have a short-term improvement, but rapidly you have a lot of complications, like about 80% of complication leading to stent removal, mainly because you have choke points migrating at each edges of the stent with granulomas and progressive malacia. So now, stenting in bronchomalacia is not a good indication, but it can be used as a stent, as a trial to select patients that could be operated. And this operation that can be offered to this patient is a tracheobronchoplasty, which means that you have to suture meshes of Marlex on the posterior wall of the airway, which is rare surgery, but again, stenting is not a good indication. And when you look at this picture, you can easily understand why it's not a good indication. This is a patient from a colleague from Toulouse, and you see the largest commercially standard wide stent floating in the airway. So you can hardly imagine that this wide stent will improve the symptoms of the patients. I mentioned that now we have a new generation of metallic stent. It's a fully covered metallic stent, and you have different brands, but I know that there are more and more placed in the world, at least in France, at least in Europe. So, but I don't know the proportion now. So, if you wonder, is silicone, what is the best optimal stent? Is it silicone or metallic? I have no objective answer to give you, because there is no available scientific data, no comparative studies, well, at least maybe one in malignancy. My message is that there is no ideal stent, but there is an ideal stent for each condition, for each patient. But it would be too long to address that now. Just as an example, we have published recently, I'm part of the author, the World Association for Bronchology and Interventional Pulmonology guideline on airway stenting for malignant central airway obstruction. I advise you to read it, but I can give you a short conclusion, is that there is no difference. No difference in malignancy if you place silicone stent, if you place metallic stent, mainly because most of the patients die before significant stent-related complications. There is no more complication in as a stent, so in malignancy there is not big problem for the choice of the stent. Soon we will publish the same guidelines for benign, and in benign it's clearly different, but it's still not published. What I can tell you again is that optimal stent is the one you don't place. This is clearly the best one because you found another solution. It can be endoscopic, medical, surgical, to avoid stent placement. But if you place a stent, you have to understand that it's a compromise. It's a compromise between the symptoms you will bring with the stent, because the stent can bring symptoms, and the symptoms you will relieve thanks to the stent. Post-placement, one should be able to remove the stent even in malignant condition. And stent placement and removal using rigid bronchoscopy is safer and quicker, irrespective of the stent type you place. This is clearly my belief. What is new in airway stenting? So I just placed this slide to show you improvement, innovation in metallic stenting. This is called the TTS stent, through the scope stent, so it means metallic stent that can be inserted through a working channel of a therapeutic flexible bronchoscope. So that means that if you can insert the delivery catheter inside of the working channel of a flexible bronchoscope, that means that the wire, a metallic wire, is very thin, very small. That means that the stent is probably not very strong to relieve a strong compression, for instance. But I think that it can be interesting in some selected indications. Otherwise, the three ways to improve airway stenting, of research in airway stenting, is a 3D printed stent, the stent that can be produced according a long time, and probably vanish when it's no longer needed. The problem is that on the market there is one stent. So the one you see is an ELA stent, which is produced by a Czech society, so in Europe. It is made with polydioxanone. Polydioxanone, the problem is that it degrades in 3 months, and 3 months is probably too short to relieve and to treat benign conditions that will require generally longer stent placement. So we probably have to find another polymer that could degrade, that would have a degradation time longer than the polydioxanone. If you're interested in airway stenting and about the new ways, the individualized stent, I recommend these 2 reviews that I'm part of, the authors. One with Lutz Freitag, published in 2017, very interesting. Lutz Freitag is a German colleague who has worked a lot on airway stenting. He has a lot of experience. And the last one, 2020, with Nicolas Guibert. Nicolas Guibert is a French young professor working in Toulouse, and he's an expert in 3D printed stent and also in degradable stent. So I think it's my last slide. Again, I want to thank Hari Kishan because he contacted me for this talk. I wish you, to all my Indian colleagues, a very nice meeting, BRONCHUS 2025, and hopefully we'll meet in the future in IP meetings if you attend this. Thank you very much.
Once again, a very warm welcome everyone to the Day-2 of BRONCHUS. Without further delay, we will continue with our next session on the lecture, Tracheal Suturing for TEF by Dr. Galicio G. It's an online session.
Well, my presentation is about the advanced techniques in the treatment of tracheoesophageal fistulas. Tracheoesophageal fistula is an abnormal connection between the trachea or the airways and the esophagus. We can recognize 2 different kinds of fistulas, the congenital ones and the acquired fistulas. And the acquired may be neoplastic or non-neoplastic. The congenital fistulas are common in the newborn when the esophageal atresia is present. And the atresia may be very important, and in some babies it will be necessary to operate them immediately after the delivery when the atresia is complete. But if the atresia is not complete and is smaller, it may develop also later and in the following months, and it appears like coughing in recurrent pneumonias in the babies. This is a typical aspect of congenital fistula. In the posterior wall of the trachea, you can find a funnel-like fistula, a small one that is connected to the esophagus. The acquired neoplastic fistulas are more common in the esophagus cancer rather than in tracheal one. You can see in this case, this was a patient with a tracheal neoplasm which was treated by radiotherapy, and in the following months after the radiotherapy, an enormous fistula appeared. And this is the typical acquired fistula, non-neoplastic one. We may have fistulas after trauma, infections, ingestion of caustic substances, iron pill inhalation, surgery, complications of endoscopic procedures, especially in the esophagus, transesophageal echocardiography, prolonged intubation, which is the most common one, and the prolonged tracheostomy in the patients who stays in the intensive care units. This is the typical aspect of a fistula we developed in a patient after prolonged tracheostomy. This is the cuff of the cannula may compress the posterior wall of the trachea, and the ischemic necrosis of the wall may induce a fistula. The diagnosis is commonly made by clinical symptoms. The patient begins to have mucus, recurrent pneumonias, coughing. The endoscopy and radiology may clearly show the presence of the fistula. Which is the therapy in the congenital fistulas? The classical therapy is made by thoracoscopy. There's the surgeon makes a ligature of the fistula with clips or suture, and then an esophageal anastomosis is performed. It's not very simple, but in smaller fistulas of the newborn, an endoscopic treatment is possible. You see, this is a typical treatment in these patients. You see there's a drop of sanacrolate is put in from the tracheal side of the fistula, while a clip is put in the esophageal side in order to retain the glue. It's very effective, it's very simple to do. The clips go down in a few days, and generally these babies heal very well in the following weeks. In neoplastic fistulas, unfortunately, we have no defined therapy, and only temporary palliation is possible. Generally, it is done by positioning a stent in the esophagus for the first time, and if necessary, a tracheal Ipsen stent is put in the trachea just later in order to avoid the passage of fluid from esophagus or the digestive ways into the trachea. Generally is possible, but this is only palliation because in months the fistula begins enormous and there is no more but the possible therapy. Which is the surgical approach of the non-neoplastic tracheoesophageal fistula. This is very important because the classical treatment is clearly surgical. A resection anastomosis of the trachea is performed, and later the esophagus is sutured, and vascularized, the muscle flap is interposed between trachea and esophagus. It's not a simple surgical treatment because it needs the competence in the esophageal surgery, in tracheal resection. Is a very important therapy. It may be difficult, may need different equips, and not always possible in all the hospitals, which are able only to perform normal thoracic surgery. When an endoscopic treatment is possible in non-neoplastic tracheoesophageal fistula, it should be considered as bridge to surgery or as palliation. There are patients in which the surgical treatment is not simple or is not possible. I think especially to the patients that underwent cardiac transplant, is very difficult to reopen the thorax, or maybe complex the anesthesiological management of this patient. This is why in this situation sometimes there is no space for classical surgery, and endoscopic treatment may be considered. This is the two papers that we published in last years regarding a complete endoscopic treatment of tracheoesophageal fistulas. What we did is to treat them by suturing the tracheal wall. When there is a clear indication to this treatment, when the surgery is impossible for severe comorbidities, or risk factors, or short expectancy of life, in patients in poor conditions, ventilated, with neurological damage, and recent major surgery. All these conditions may contraindicate the surgery, and we have to evaluate these patients for an endoscopic treatment. It depends also on the dimensions and the characteristics of the fistula. We need to have some space on the borders of the fistulas in order to make the suture. When the fistula is complete, the ischias of the tracheal wall generally is not possible, and only standing is possible. We have to suture the wall, but which kind of suture we have to use? And the problems that we had to afford when we began to treat this pathology were absorbable or non-absorbable, synthetic, natural, monofilament, multifilament, size of the needle, size of the wire. We see that absorbable sutures may be break in time, and this is maybe a good thing if you want temporarily closing of the wound. But if we need a more prolonged, stable suture, it may be contraindications. they are the absorbable sutures are degraded enzymatically, and we have a time. It is not constant, so we are not sure that the absorbable sutures will be resorbed in determinate time. Sometimes the body is able to reabsorb them in a shorter time or longer time. So this kind of sutures that we used in the beginning of our experience are generally used only in patients in which we need a very short time before healing of the suture. Not absorbable and not designed to be broken from the body and may require removal after a period. They can remain in the tissue while during months and years. And these types of cures are generally used for long-term cure. This is the kind of fusers that we are actually using more because they're very simple for us to cut them and remove after the time that we need. But we can hold them inside for all the time that we need. And then we decided to use monofilament or multifilament. The monofilament sutures, fusion is single thread. This type of sutures pass through tissues smoothly and is more simple to make them pass to make the suture, and does not harbour microorganisms easily. While multifilament sutures are more simple because they're very flexible, it's more easy to make the knots, easy to handle, but it's more possible for the microorganisms to colonize the wire, and sometimes they be coated to pass through the tissue. This is the classical types of wires that we use. Vicryl is the reabsorbable wire that filament that is reabsorbed generally in about 2-3 months, while prolene is monofilament, not reabsorbable sutures that will be inside all along the life of the patients or will be removed in time. How can we sutures tracheal wall? We do it by a long needle holder that is inserted through a large tracheal tube. We have many tracheal tubes that are adapted to this, usable for this, especially the big tracheal tubes from Carol Dumont bronchoscope, or this we use the rather knot. This is the preparation of the needle, the preparation of the knot. And then the running knot is brought down along the tracheal tube. The wire is put on traction. The traction is applied to the running, and you see the borders of the fistula are tightened this way. Then with a laser fiber, the knot is cut. The patient is in the deep sedation, but in spontaneous ventilation. No need for major relaxing drugs like curarus and so on. This is the second knot. This is passed through the borders of the fistula, and it's made exactly the same thing. We treated with in our experience 10 patients with 17 procedures that has been published recently, and it's very interesting to see that we have a complete healing of the fistula in some patients. A long relapse for months, and the interesting thing that this is very simple procedure, no need for open surgery. It may be repeated in time. In some patients we made this procedure 2 or 3 times, and so we consider the technique also like a palliation in patients as more effective than standing. No risk of the essence of the tracheal wall by the compression of the stent. not difficult technically. The time that the mean time of the procedure was about 25 minutes. This is the final result. You see, this is the result of the completed suture. And in the next image, you can see a long-term control made by the fiber optic bronchoscopy in the other center. You see which is the result, and you also can see the prolena not inside of the mucosa in the site where the fistula was treated. Well, I think that this is an innovative process, may be very useful because it doesn't needs in a general, difficult anesthesia in complex patients may be adopted also in patients with bad conditions and poor clinical situations after major surgery. We have to say that surgery is the definite therapy of a tracheoesophageal fistula if possible, but in situations in which the surgery is not possible, a tracheal endoscopic approach by suture may be simple, useful, and repeatable. This is our experience about this. Thank you so much.
Moving on to our next session, lung cancer and interventional pulmonology. I'd like to invite Dr. Bharat Vaswani for his lecture on immunotherapy in lung cancer. Please, sir. Just a quick announcement, I'd like to request the speakers for this session to hand over the PowerPoints at the AV. Bharat sir, yeah, we're waiting for you. A reminder again, I would ask the speakers to deposit their slides at the AV, please, for this session on lung cancer interventional pulmonology. Welcome, sir.
Good morning, everyone. Let me welcome you on behalf of our Yashoda organization. The topic that I am discussing in the next 15 minutes has been sponsored by MSD, so they have given me some slides, but I'll try to present what is relevant and in context with our country, India. So this is the MSD-sponsored symposium. Now, just do I am telling, type the word on computer, top 5 innovation in cancer treatment. And what you will give the first 5, what are the top 5 innovation. But the most important thing which you will get in everything, in the top 5 in any management of lung cancer or any cancer otherwise is immunotherapy. So has something changed in the management of lung cancer? The answer is there is a dramatic change in the management of lung cancer. Pre-2010, I can tell, before the era of precision medicine in India and now, there is a dramatic improvement in the management, or I can say prognosis and the overall survival. And the main contributing factor is immunotherapy. So 1980s, 1990s, lung cancer was considered as a single disease. And then it became adenocarcinoma and squamous. But remember, this is not the way we treat it now. The lung cancer now is divided into oncogene-driven lung cancer and a non-oncogene-driven lung cancer. So it is mandatory on day 1 to get a next-generation sequencing and get a driver mutation done. That is mandatory. You can't start a chemotherapy on day 1 without doing the NGS testing. The first question, why should every doctor know about lung cancer? So all of us know the highest mortality among all cancers in the world is lung cancer. It is the second most common cancer behind prostate cancer, and the alarming thing is even in female, it is the second most common cancer all over the world. 90% of lung, these are the traditional thing, 90% are due to tobacco, but recent years have seen a lot more cancers in women and non-smoker, and here there are probably what we call as driver mutation leading to that. Overall lung cancer, 84% are non-small cell lung cancer. Why you should worry? If you talk about the cancer with a worse prognosis, it is pancreas, brain, liver, and lung. So if a cancer in an advanced stage, the worst prognosis among all is lung cancer, and hence we need to treat it more aggressively. In fact, when you see the era of before the precision medicine, the 5-year survival in advanced cancer was less than 10%. And then came the game changer, what we all talk about, and that has changed the way we look at lung cancer. Tashaku Honjo, James Allison, Sir James, they got the Nobel Prize for this seminal discovery of immunotherapy in the management of cancer. It has been mentioned time and again in Times. There are a lot of articles. And now we are looking at what we call as a chronic disease called as lung cancer, rather than a disease which the survival was very low. When we talk about country, India, it is 4th common cancer. So probably head and neck, breast, oral cavity cancer, cervix are more commoner. But when you look into, I have not been given the permission to put in Hyderabad, when I talk about, the most common cancer is lung cancer among males. So yes, metropolitan city, big city, the commonest cancer in India is in fact a lung cancer. The problem with lung cancer comes when, because most of the lung cancer are diagnosed in advanced diseases, and when you know the prognosis is not good when the disease is stage 4, before the era of precision medicine. When do you give immunotherapy in lung cancer, and what are the suitable patients for immunotherapy? So the most important thing before you decide to give immunotherapy is that should be non-onco-driven lung cancer. So if you have a EGFR, ALK, and ROS, don't think of giving immuno in the first line. Subsequent line, yes, you can give it along with lot of regime, but it has to be non-driver. So for a normal pulmonologist, how do you decide which patients are suitable for treatment with immunotherapy? So a simple immunohistochemistry, which we do it on a lung cancer tissue. So what we call as PD-L1 done on a lung cancer tissue. Does PD-L1 make a difference? So if you have a high PD-L1, day 1 only, it is a prognostic thing because it tells you that your survival will be better among those who are non-PD-L1 positive. So indirectly you can predict your response to immunotherapy, but more importantly, you can tell probably this will have a better or a longer survival when you give your treatment. What exactly do you understand? So in lung cancer, we have two scores that we use, tumor proportionate score and combined positive score. So in lung cancer, as unlike other cancer, it is what we call as TPS. So number of cancer cells which are positive for that upon the total number of viable cells. And if you have a higher TPS score, you are more likely to respond to immunotherapy, and that is the most important thing. Is TPS, how do you do? So minimum less than 1% probably immunotherapy, you may still use it, but the responses are not as good. But if it is more than 1, the prevalence is around 52%, and if you are more than 50, so the cutoff is more than 1, more than 50. More than 50, yes, a high likelihood that you will respond to immunotherapy. Now, when we talk about it, there are a lot of new drugs coming up, but I'm trying to talk about MSD's product, which is pembrolizumab. In fact, if there are people who are treating lung cancer, most of us in the first line are using pembrolizumab along with chemo or as a single agent. So these drugs, basically anti-PD-1, started in second line over a period of time, then subsequently moved to the first line, and probably if you have any of the TPS more than 1, we give it with or without chemotherapy. That is what most of us in India are following that protocol. So the topic of interest is 2 pivotal studies as a single agent Keynote 024 or along with chemotherapy in non-squamous type Keynote 189. What I will like you to concentrate is a 5-year survival. Now for the first time we are now looking at a 5-year survival in a metastatic CA lung, which was never a case when we were discussing in the previous time, so when I started. Let us start with the indication. So can I use a single agent immunotherapy? So if your PD-L1 score is more than 50, you are non-driver mutant, you can use single agent immunotherapy. What about second line? So I end my time by giving you a smile on your face. If you have time, watch this movie, Kantara. Basically, Kantara means curse. Cancer is not now a curse now. With the new drugs, with precision medicine available, the survival in the lung cancer is improving. If you have time, watch one of the most famous movies, probably the best movie of, I can say in terms of revenue, that is film Pushpa. What does Pushpa tell you? Main jhukega nahi sala. That means we should never bow down to cancer. I thank you all for a patient hearing with the famous quote of Socrates. The secret of change is to focus all your energies, not on fighting the old, but on building the new. I thank you again for a patient hearing. If you have any doubt, we can always discuss downstairs. Thank you.
Thank you, sir, for an excellent talk. I'd now like to invite Dr. Titiwat Siriprasad for lung cancer screening in Asia. Welcome, sir.
So thank you, thank you very much, the organizing committee for giving me this topic. I would like to talk about the lung cancer screening and mainly in Asia. As you know that the lung cancer is a main problem, health problem worldwide, but there is a difference between the developed countries and developing countries in terms of the population and the patient's history. If we look at the Asia snapshot, you can see that across the country in Asia, we have a lot of lung cancer problems, including China, Singapore, South Korea, and Thailand, that we illustrate here. It is a common cancer death in Asia, whether it's a first, number 1, number 2, or number 3. And if you look at this graph, you can see that the survival rate of lung cancer is 5-year survival is quite low. The highest is in Japan, and that 5-year survival is 36.7%. And the reason behind that is because in Japan, they can diagnose lung cancer 36% in stage 1, meaning that the patient has access or the population has somehow has screened and can get diagnosis in stage 1 disease compared to other countries. And we all know that if we diagnose a patient in stage 1, the chance of having 5-year survival is 90% or more, or can be 100%. But if we diagnose a patient in stage 4, then the survival rate is around 10%. So that comes to the value of lung cancer screening. In Asia, we talk about the population, the pollution, and we all know that the air pollution, especially PM 2.5, that induce the EGFR mutation in the alveolar epithelium cell, and that can promote the lung cancer, especially adenocarcinoma. We have seen this across the country in a patient who's non-smoker. In this slide, in Thailand, we basically just lost a doctor who basically just finished the residency 3 years ago, and he was diagnosed with stage 4 lung cancer. And before he died, he actually the one who basically promote the lung cancer screening. This is a study mainly from Taiwan that illustrates the difference between the lung cancer patients in Caucasian and Asian. In Caucasian, the underlying mutation is KRAS, and EGFR is around only 15 to 25%, and 80% of the patients are smokers. But in Asian, the KRAS mutation is lower, account for only 8 to 10%, and a very high EGFR mutation, 55 to 60%, and most of the patients are non-smoker female patients. And the reason behind that is because of the pollution that change the mutation in the alveolar epithelium cell and make it susceptible to develop the cancer, especially adenocarcinoma. There are multiple studies that can explain the pathophysiology of this mutation in non-smoker patients. Very first study about national lung cancer screening trial showed that the lung cancer, a low-dose CT scan can detect early lung cancer and provide 20% mortality reduction compared to the chest radiograph. And since then, there are multiple studies that support the intervention to diagnose that positive results. It makes this LDCT become more difficult to implement. Okay. And the further procedures which already required after a positive result of LDCT, and as we all know that the procedures and the intervention to diagnose that in positive result is limited in the area. And the adherence of lung cancer screening from the patient is also poor. Okay. In conclusion, lung cancer is prevalent in Asia, in non-smoker, and it is the leading cause of death. LDCT is useful and is proved to detect lung cancer patient in non-smoker who has risk of having lung cancer. The LDCT benefit both smoker and non-smoker, and the current guideline need to change to include the patient who is non-smoker but with risk of having lung cancer. We need to improve the poor adherence and perception of the patient to get more LDCT. Thank you very much.
Thank you, sir. I'd now like to invite Dr. Jovin Gunong for his next lecture on intratumoral therapies for endobronchial tumors. We welcome you, sir.
Good morning. My topic is bronchoscopic intratumoral chemotherapy. And the following objectives are to discuss the utility of bronchoscopic intratumoral chemo as an adjunct to other modalities like thermic therapy, radiotherapy, and systemic chemo for malignant central airway obstruction affecting the carina and the major bronchi. And to discuss the principles of bronchoscopic intratumoral chemotherapy. And later on, I will present some of the cases we have in the lung center of the Philippines. So, the history of intratumoral injection started in 1893 when Dr. Cooley injected strep pyogenes directly into the lesion. And then in 1958, some investigators used iotepa. In 1976 and 1980, the use of the BCG as an immunotherapy was also used. And then later on, BCG was injected directly into endobronchial extension. The son and father, Dr. used 5-FU in August 1992 and August 2001, so before the advent of the EBUS. And then in January 2009 and September 2014, cisplatin was used by Dr. Mehta in the University of Florida. And then in 2016, paratoluene was used in China by Dr. Xiyu Li. And lately, there are some precision biomarkers driven intratumoral therapy for non-small cell carcinoma. So who may be considered for the intratumoral chemotherapy? So patients with malignancy, associated airway obstruction from lung cancer recurrence, it's not a candidate for resection. Patients with recurrent early stage non-small cell CA that have not responded even after second line of chemo, deemed unfit for surgical resection due to airway involvement of their lung mass. And patients with isolated mediastinal recurrence of lung cancer after RT. So what are the criteria? Radiographically, you should have a re-expansion of collapsed lung. And bronchoscopically, a good response is more than 50% increase in the diameter of the airway lumen. A moderate response is between 25 to 50% increase in the diameter of the lumen. And a small response is less than 25 increase in the diameter of the lumen. So, talk about the pharmacodynamics of cisplatin, tumor cell that occurs when the intracellular concentration of cisplatin reaches a lethal threshold level. And usually, the nominal value used is 0.5 milligrams per ml of tumor. Like if you have a volume of 80 ml, then that is equivalent to a total dose of 40 milligrams. And to successfully treat the tumor, it would be nice to be guided with the EBUS TBNI so that you're able to flood the tumor with the drug. So it would be better to divide the dose into 4 doses, the total dose into 4 doses, and inject it into the 4 different places guided by the EBUS. And if you look at the cisplatin, first, it goes into the extracellular space, and then eventually to the intracellular space, binds irreversibly to the DNA to kill the cells, and the extra cisplatin will eventually find its way to the fluid space and be cleared by the kidneys. So the dose of cisplatin required to kill a given fraction of tumor cells using 4 or 5 injections can be 3 orders of magnitude. So meaning to say, if you look at number 1, or the first dose, if you have that volume of 10 times 10 to the 12, you have a 3 logarithmic kill. So the next time around, it will be 10 to the 9, 10 to the 6 on the third dose, and 10 to the 3, and eventually you're able to kill all of the cells in your targeted lesion. So let me just show to you a 62-year-old male presented with severe dyspnea and was admitted in our center. He was recently diagnosed then with stage 4 lung cancer and with a very poor performance. And if you look at the left side of the lung, it's completely atelectatic. And this is the result during bronchoscopy. We have a carina that is fully infiltrated and a left main bronchus that's fully infiltrated too. And you have that fungating friable mass extending to the orifice of the right main bronchus. So initially we did thermic therapy with cryo and electrocautery, and after 3 weeks, we started our series of injection. So this is just how we did it. We tried to identify through endobronchial ultrasound the area where it's safe and to inject it. And as we inject the cisplatin, you could see the Doppler flow. So we used a 40 milligrams for this total dose and divided it into 4 and selected 4 injection sites. We usually start at the bottom and then withdraw. Since it was 10 milligram per ml per dose, or 10 ml, we were instilling 2.5 ml each time as we withdraw the. And through time, from baseline to the follow-up, I did not expect the left main bronchus to open up, but it actually did. And look at the chest X-ray 54 days after the last dose. So the CT scan showed interval decrease in the size, re-expansion of the left lung, and interval decrease in the size of the lytic expansile lesion. And on follow-up PET CT scan 10 months post-treatment or initiation of treatment, there was no evidence of hypermetabolic local tumor recurrence in the left lung. However, since he was not able to follow up on time, the left main stenosed, and again, there was a collapse of the left lung. I wanted to canalize it again, but upon checking up on EBUS, you have that big vessel just below the pathway of the stenotic lesion. So I decided not to manipulate that area since he was really doing well. There's an intensely hypermetabolic expansile lytic lesion on the right rib, but this was easily covered with radiation therapy. So these are our case series of malignant central airway obstruction affecting the carina and the major bronchi treated with intralesional cisplatin with or without thermic therapy when we started this program in 2023. So we have 9 subjects in our first cohort. There were 4 adenocarcinoma type, 1 squamous, and 1 neuroendocrine. And most completed 3 or 4 treatment of intralesional cisplatin. We have 2 mortalities in this cohort. 1 died due to COPD exacerbation, and the patient refused treatment for her husband, and so we were not able to continue the treatment. And then there's 1 older female, an 84-year-old patient who developed severe pneumonia while in the hospital after the initial treatment, and she died of ARDS. But if you look at the bronchoscopic finding of these patients, most of these patients were actually referred by our TCVS colleagues because they're no longer candidates for surgery or even stenting. And if you look at the pre-treatment imaging and the post-treatment imaging, you could see an improvement in the collapsed lung. For patient number 6, there's a progression, but this is just due to pneumonia, which eventually resolved with antibiotics. And if you look at the pre-treatment FOB, compared it with the post-treatment FOB, notice that most of the patients really responded to the treatment. So I just separated the cases of adenocarcinoma from the squamous cell carcinoma type. And I just want to emphasize that we should, I think, be very careful with the elderly patients because they're prone to develop infection. For the squamous cell type, the oldest patient in this group was the one died, but not due to the treatment, but due to a severe exacerbation of COPD. And if you look at the post-treatment, the first dose, he responded during the follow-up or surveillance bronchoscopy. So in summary, intralesional chemo is an additional treatment modality that may be considered for patients with malignant central area obstruction. Increased precision in the local delivery of chemo drugs to directly target the tumor microenvironment, and you should be able to perfuse the lesion so that your drug will be able to target most of the cancer cells. And we know that if given locally, you can have higher concentrations compared to your systemic treatment with possible fewer systemic side effects. So thank you, Hyderabad, India, for having us. Thanks to Hari for inviting my entire team from the Philippines. Namaste.
Thank you, sir, for an informative talk. I'd now like to invite Dr. Kelvin Lau for his next session on update on bronchoscopic ablation of lung nodules. We welcome you, sir.
Good morning, everyone. Thank you very much to Harry and the organizing team for inviting me to talk about ablation today. So, we talked about ablation. So let's see where we were last time. So I guess one of the holy grails of bronchoscopy is to be able to reach tumors and treat them as a definitive treatment. And what we show, there's a lot of interest in this area. You can see the number of publications just shot up over the last few years and will continue to grow. And what I showed you last year is our early experience. So this is the first 100-odd nodules that we did. And you see we do quite a lot of oligometastasis because it's a bit easier to prove efficacy in patients where you're not trying to cure the stage 4 cancer. It shows quite versatility because you can do multiple nodules using an endobronchial approach. You can combine ablation with surgery depending on the suitability of each nodule, and you can do bilateral nodules. We show that it's safe. The grade 3 or above complication rate is less than 10%, significantly better than surgery or radiotherapy. We did have one death in a patient with an infected ablation zone and had massive hemoptysis. Pneumothorax, as you know from an endobronchial approach, is quite rare. One had a pleural effusion, 3 had pleural infected cavities, but you can also damage central structures like the phrenic nerve when you go for central tumors. But overall, a 8.5% rate is respectable. We also showed that local control is not bad. So this is the 5-year follow-up of these 100-odd patients, and we had a Kaplan-Meier local control rate of 82%, and this is not bad compared to radiotherapy. It's also interesting if you separate the colorectal cancer, the lung cancer, you see that the recurrence rate is the same but the metastasis occurs more quickly, and that's to do with the growth rate. So some people say, oh, okay, so tumors that are more aggressive shouldn't be treated, but actually the local control is the same, it's just how rapidly they reappear as a local recurrence. And we've seen many other series, especially from Calvin, from Michael Pritchett. We got the same kind of ballpark figures in terms of the efficacy of the treatment and the safety of the treatment. So that evidence is being built up as we go along. This is also a very versatile tool. So there are situations where nothing else works, that this is actually a remarkably useful tool. So patients who've had reduced surgery and they have a subpleural nodule, you can easily reach the pleura and ablate it. You can take advantage of the fact that there's a forward throw in the ablation zone and you can capture the nodule despite the fact that you're hitting the chest wall. Pulmonary fibrosis patients, these patients are nightmare. They can't have radiotherapy because it exacerbates their fibrosis. You can't have surgery because the lung function is so poor. And yet here, this is a patient who lives 4 years after ablation of an adenocarcinoma at the base of the lung, and you can see the ablation zone over 4 years gradually disappearing. Patients who've had radiotherapy, they can't have more radiotherapy. They're a nightmare to go in for surgery. Here you can see a recurrence within the radiotherapy field. We can go in and ablate it. We got a cavity, but that rapidly disappears, and the patient had control. Surgical recurrent patients, surgeons don't like to go, I am a surgeon, I don't like to go back to my patients after I've done a resection. You can see there's a nodule on the. We went back, we biopsied it, we ablated it, and there you can see the ablation zone with a bit of reactive pleural effusion next to it. Even the patient you ablated who recurred, they can be ablated. So this is a colorectal metastasis. You can see the ablation zone. As the ablation zone was shrinking, a little bit of it starts growing. So it looks like it's growing in air, and that's PET avid. You can use your bronchoscopy. You can reach that little point pretty accurately, biopsy it, and re-ablate it. And here you can see the ablation zone after the ablation, that halo, and then it consolidates and then shrinks and no longer avid. Bilateral nodules, they're neither good for radiotherapy and not good which will need double the number of sessions because they move separately, but they can be reached bilaterally on the bronchoscopic approach in one session, and in one treatment, in one night, it's gone, they go home. There you go, 2 ablation zones from one day. So far, so good. So that's where we left it last time, but it is not quite there. There are some challenges. So the first thing is, this procedure is a little bit clumsy at the moment. The navigation piece takes a bit of time. You try to position yourself. The ablation takes 10 minutes, so the procedure time takes over 2 hours. And most surgeons would tell you, I can do 5 wedge resections. I can do 5 wedge resections in the same time. So why would a procedure that is supposed to be minimally invasive take about 5 times as long? The other thing is that why it takes so long is because you're trying to position yourself in the center of the nodule. It's a bit like you won't want to cook something if what you're trying to cook, chicken, is not touching the frying pan. So a lot of the time is spent to maneuver a catheter to throw this dart at this tiny bullseye. You can, if you're lucky, you may get into this position where you have an ideal position of your catheter through the center of the tumor, but more often than not, you're sitting paranodular because your nodule is small and you can't get through a tunnel through the middle of it. Sometimes you just have to hope that you're throwing this microwave field out and it captures your nodule from a distance. But it does make a difference how you position yourself. If you are right in the center of the nodule, you need to burn a much smaller area and protect the parenchyma. If you can see here, if you're just 0.5 millimeter off, your volume more than doubles that you need the parenchyma that you need to destroy. And if you're off center, you can go up to 4 times the volume of parenchyma that you need to destroy. This, of course, is assuming that the ablation zone stays that way when you have, when your nodule is not in the center. But of course it doesn't, because that nodule casts a shadow on the energy from the catheter, and so the side that is facing, the side of the moon that's facing away from Earth, as it were, does not get as much thermal damage, and you risk recurrence. So this is where the last few years' innovation in robotic bronchoscopy makes a big difference. Because rather than a passive catheter, you're hoping you can throw this rope and hit a snooker ball, you now have a directional control. You have a great range, but at the same time, great stability. We talked a lot about this yesterday. Tool in lesion versus diagnostic yield. Tool in lesion, but lesion not in tool. There's a lot of about whether this is a good technology for biopsy. But actually, what matters in ablation, not the diagnostic yield. All you care about is tool in lesion. And the tool in lesion is nearly 100%. And that's even in novices who use it. So this is a trial me and Palaf did together. We did 200 nodules as novice users of ion. We got tool in lesion 99% of the time. We checked where we were in the lesion, not just in the lesion, and we were in the central third 88% of the time. So in a way, this tool is very, very powerful for positioning for ablation. So I'll give you an example. So this is a melanoma metastasis in the medial segment of the lower lobe. If you look carefully, you see that there's a bronchus to the side of the lesion, and that bronchus goes round the tumor. So what you need to do is you need to somehow exit the airway and point through the center of the lesion. But when I use my navigation system, I think the best view is the bottom left. You see that however hard you try, it's very difficult to point at the side of the bronchus and exit. And all that happens is every time you put a needle in, it straightens out and it falls down the lumen and you go round the nodule. And that's not ideal to biopsy, to position it. And I tried for a long time, and in this case, I actually gave up because I didn't think I could get a good ablation. So I brought the patient back a couple of weeks later when we got the ion, and there you see I can position it and point it stably at the center of the nodule, and I can pass a catheter through the center of it. There is a bit of hemorrhage from the puncture, but I'm through the center of it, and this is the setup. My usual imprint system from Medtronic that I just did a bit of a Heath Robinson and plugged it in with a drip stand into my ion bronchoscope. And there you go, it's centrally placed, and then this is the ablation. So you can see the halo of the ablation with the nodule in the middle of the halo of the ablation zone. He's 6 months, and he's got a very good ablation zone at 6 months. So we've done 10 cases of this, and the positioning, 90% of the time the needle was within the nodule, and 70% of the time within the center of the nodule. And of course, this is just the beginning of the experience of this. There were no deaths, no pneumothorax or any grade 3 complications, and the procedure time dropped from 120 minutes to 93 because I can position so quickly. I can point at the center and just shoot, whereas before I'm waving this floppy catheter in the hope that I'd hit it. The problem is the imprint catheter is now being withdrawn from the market, so we have to look for a different solution. Unfortunately, there was one in the, standing at the side of the stage ready to come on, and that's the Creo catheter, and you can see it comes with an adapter ready for deployment on the robot bronchoscope without my drip stand Heath Robinson setup. The difference is this ablation catheter is a higher frequency, and so the ablation zone is much smaller. So A is the diameter of the ablation zone. You can see it's just under 2 centimeters, so we tend to prefer to use this for very small nodules like this one. So this is a gentleman with a lung cancer metastasis that came back several years later, solitary. So we put our needle through it. See the power of the robot bronchoscope. I can be so precise and put the needle through the center of a 5mm nodule and drive an ablation catheter through the center of it. I couldn't do that before. You remember how it tends to swing to the side of it and push the nodule to one side. And then we ablate it, and there's the ablation zone. So you can see the halo of the ablation zone with the nodule in the middle of it. And on the right, you can see the track of the ablation zone with the nodule surrounded by this egg appearance. So with all the debate about the economic value of robotic bronchoscopy, I want to go back as a surgeon to this. So this is our Da Vinci robot that we do our thoracic surgery operations on. And actually, the Da Vinci robot was first invented for open cardiac surgery to improve the magnification. It's like a surgical microscope. It failed abysmally, and the company nearly went bankrupt until it discovered that actually it's better as a intracavitary device. So the power of it is that I can now zoom in and do segmental resections and dissect really small vessels and segmental vessels with a lot of precision. That spatula is 1 millimeter. So this vessel is about 2 to 3 millimeter and is zoomed to such precision this is where it adds value to operation. So I wouldn't use that for an appendix, but there are surgery like complex segmentectomy that it really does add value. So the question is, this robot bronchoscopy, which is very, very expensive, is it a tool for biopsy? There are many ways of doing the biopsy. Does it really add value? That debate may not be so relevant if we think we are using this device to treatment, a whole different proposal. If you could get into the center of the nodule most of the time, you can do such precise surgery better than segmentectomy. Now, just in the last few minutes, microwave is not the only energy. So over the last few years, the number of publications that come on look at many other options as well, because there are problems with microwave. It's not very easy to see the ablation zone and assess your procedure. So there are a range of other energies already used for ablating different tumors, liver tumors, kidney tumors. RFA has a much longer history than microwave, but the conduction, you need to have tines to bring the energy out. It's not easy to put these tines in, and it looks a bit violent to deploy them in the lung. But so you might have been to the bronchus stand, and you can see the bronchus catheter, where rather than using tines, it diffuses saline out, and it uses the heated saline to help improve the conductivity to expand the ablation zone. So that is available in Asia. So this is the bronchus, the RF2 study with Felix Hirth and in China, and 130 nodules which were ablated in 16 centers. It's proved itself to be pretty safe. Mortality, one was from the procedure, one was from disease progression, and there were 5 pneumothorax. Of interest, this is a very interesting slide for me. If you stratify the nodule according to its size, you see that it is very, very effective for lesions under 2 centimeters. That is actually the same similar information as there is for percutaneous data. And look at the solid versus the subsolid lesions. The subsolid lesions don't recur. And this is very important when you look at papers of people ablating ground glass lesions. They will report very effective control, but that's just because this time scale is much shorter than the time scale of recurrence of this disease. So these are 2 important things to look out for when you want to separate the context of the effectiveness. Other treatments involve, well, photodynamic therapy. We do that a lot in the central airways. And if you could deliver light to the periphery, you can just give the same systemic treatment and just deliver it with a light catheter. So this group in the US tried to do it and with 10 patients. A bit disappointing, so the 5 treat and resect patients, only 1 had complete response, and otherwise it is well tolerated. Freezing. Cryo is quite established for percutaneous. It has certain advantages compared to thermal cooking. Most importantly, you don't destroy the tissue. So you don't destroy the blood vessels, and you may not get the massive hemoptysis that we've seen, say with my case and with the patient who with the new wave catheter. It's also analgesic, so it's great for lesions against the chest wall because you don't get the chest wall pleuritic chest pain, and there's some theoretical benefits in terms of immune stimulation. You all stick cryoprobes down the bronchoscope. So the ERBI catheter has been, they tried to work an ERBI catheter that would give you the liver and ablation zone, but just using carbon dioxide just doesn't work because the temperature doesn't much further than 20 degrees, so it doesn't really work. But China last year came up with this nitrogen-cooled catheter, and it's very, very powerful because it can get down to minus 150 degrees very quickly, and they've done their first series of 10 patients. You can see the other advantage of cryo is you can see the ice ball forming, so you can much better see an ablation zone than you could with microwave or thermal ablation. And that is very important because you want to know you've captured that nodule in the procedure. You don't want to need 2-3 years of follow-up before you know whether you've done your job or not. So they've also showed that it is safe. There's no deaths and no pneumothorax in the 10 patients they did. And, but they 2 patients that developed recurrence, but the caveat is those were the patients they delivered the lower energy dose when they were doing the dose escalation. So, in summary, bronchoscopic microwave ablation we've shown is feasible, but we do need a lot more data. We need a lot more people doing it. At the moment, it seems to have taken quite a long time. We've done it for 7 years, but the volume of cases is just not big enough to establish whether it can or cannot become mainstream. Challenges of ablation we do at the moment is positioning and causing a long length of procedure and the ablation zone uncertainty. But robotic bronchoscopy promises much more effectiveness in delivering the catheter position in a short time. Alternative energies are available, but every one of them produces a short study, and so we need more efficacy and safety data. So I'll finish with this one. I'm a surgeon, but I'm going to say that ablation, we know from percutaneous data, works best for lesions under 2 centimeters. So segmentectomies are difficult. Who needs a segment if you could ablate these less than 2 centimeter lesions? Thank you.
Thank you, sir. Our next lecture is by Dr. Hasnain S. Bawada. It's on 9 TNM staging update. Welcome you, sir.
Good morning, everybody. Myself, Hasnain Bawada, I'm one of the interventional pulmonologists based out of the northern suburbs of Chicago with the Advocate Health System. I trained interventional and robotics at University of California, San Francisco, came back home, which is Midwest and Chicago, to set up the practice there. I'm here to talk on TNM9 because this recent survey showed that the international nomenclature for TNM9 was still not adapted since it's released in mid-2024 and hoping to have adaptability by early 2025. My initial talk was on lung cancer screening and staging updates, but we had several eminent speakers speak a lot about lung cancer screening, especially in the Asian subcontinent, which is more relevant here to you all. So I decided to trim my talk from the lung cancer screening standpoint, still speaking about lung cancer screening, but focusing mainly on staging and the TNM9 classification that was just released by the ISLC. So learning objectives to inclusion-exclusion criteria for lung cancer screening may not entirely be relevant for this subcontinent, but it's important to know how we all started and what can be done to have the stage shift and move malignancies from stage 3s and 4s to stage 1s and 2s. Of course, prevention is the key strategy and most effective one to reduce the burden of lung cancer. And promotion of smoking cessation is essential. Cigarette smoking is causal in 85 to 90% of all lung tumors. And progress in smoking cessation is now reflected in the lung cancer declining rates and mortality in the US. You look at those curves there, and you've seen lung cancer significantly come down. That's all due to the efforts made on smoking cessation behalf. The ideal screening test, and I know screening is not that rampant and acceptable in this part of the world yet, but that's where we need to forge ahead. I urge every one of you in this room to in some way have a low screening threshold for the susceptible population. A screening test should be highly sensitive and specific, should be performed prior to development of symptoms and advanced disease, not after. Target a high-risk population, easy to administer, inexpensive, reliable, high validity, and focus on cancer mortality, not survival. And how do you screen? Most of the patients would have generally had a chest x-ray before they come and see you, or even a CT scan. But a low-dose CT, so the multi-detector CT screening, generates these high-resolution, non-contrast imaging with significantly less radiation exposure, and generates high resolution at 1 to 2 millimeter cuts. The landmark study was the NLST that came out in the New England Journal in 2011. Large multi-center randomized study comparing annual low-dose CT versus chest x-rays, and followed them for 3 years. The inclusion criteria was 55 to 74 years, 30-pack years smoking history, current smokers or quit in the last 15 years. And the primary endpoint was lung cancer mortality, not survival, to avoid a lead time and length time and an overdiagnosis bias. What did they find out? 24% nodule detection rate in the low-dose CT group, but 96% of them were false positives. And 11% of them had some kind of invasiveness leading to some kind of a biopsy, a staging, a surgery inadvertently. But even then, with the 96% false positive rate and 11% false invasiveness, you had a 20% relative reduction in deaths from the low-dose CT screening attributable to lung cancer, and 6.7% reduction in overall mortality, with the number needed to screen as 320. That's amazing. 320 screens to save one life. Then was a very similar Nelson trial with low-dose CT versus no screening. What did they find? Lung cancer mortality benefit there, no change in all-cause mortality, and the nodule volume had a higher discriminative power, 27 to the cubic of m. The current screening guidelines now, in the US at least, based on NLST, are 55 to 74, current smokers or have quit in the last 15 years and smoked at least 30 pack years. But the US PSTF guidelines in 2023 are a little bit more liberal with age and pack years to expand it to 50 to 80 with coverage available and 20 pack years smoking history. And people had a lot of difficulty in calculating pack years, and now the Cancer Action Network group is trying to get rid of this calculation of how many packs, how many pack years. Make it straight. You qualify for age and you current smoker or quit smoking, period. The benefits of lung cancer screening, of course, is the leading cause of cancer-related deaths and enrollment in lung cancer screening program. Look at the numbers here. Look at the color numbers here. There's a precipitous fall in the survival when you go from 1A1 to 1A2 to 1A3, which is 0 to 10 millimeters, 10 to 20, 20 to 30, based on the T, the size. Significant drop, 92 to 83, 77, 68 to 1B, all within stage 1s. That's not acceptable here in this era, where we're trying to achieve a stage shift by earlier cancer diagnosis. I want to stress this out, and giving you something which is not on the slide, is my own community hospital setting at Advocate Health in Kenosha, Wisconsin. In Wisconsin, we screen about 15,000 patients a year for low-dose CT screenings. And we have a referral to clinic time of 7 days and a referral to biopsy time of about 10 to 12 days. And a biopsy to referral to surgery, med-onc or rad-onc, whatever it may be, less than 10 days. I'm not yet at UCLA or Mayo level, but I strive to do that at a community hospital setting. I want to tell you all here, not everybody is academic or semi-academic. Even in my own hospital, which is a 74-bed hospital in the northern suburbs of Chicago, and we have 69 subspecialties in the 70-bed hospital. How many hospitals do you guys know in the world that have the same specialties as the number of beds? Probably not. So who should be screened? History of lung cancer, CT chest within the 12 months, hemoptysis, unexplained weight loss, and a condition that substantially limits life. You should not be screened. With the potential harms of screening, as I said, 11% false positive, radiation exposure. And lung cancer screening summary is very standardized here. Tobacco cessation, preach, 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 cessation more than anything else. Let me now move to the most important part, which is TNM9. When someone comes to you, probably had a chest X-ray or CT scan already done, and then you have your pretest likelihood with biomarkers, your risk models, your Mayo, your Brock, or whatever model you use, and the CT feature sizes. We know very clearly that it ranges, your probability of malignancy ranges from a 8 millimeter nodule having malignancy at about 1 to 5% to a 20 millimeter nodule having a probability of malignancy of more than 50%. In suspected lung cancer, you have your PET scan for staging and nodule assessment, and several speakers have talked about EBUS staging. Let me move on to staging now. Everyone's familiar with the 8th TNM staging, which has T validation, N, and M. This did not change with the 9th. So who gets, before I move on to 9, and I stress the importance of 9, and I urge you all to use 9, who gets invasive mediastinal staging? In patients with discrete mediastinal lymph node enlargement and no distant metastasis, with or without PET uptake in mediastinal nodes, invasive staging of the mediastinum is recommended over staging by imaging alone, grade 1C. Evidence, in patients with PET activity in a mediastinal lymph node by CT, no distant mets, invasive staging of the mediastinum is recommended over staging by imaging alone. And how should we perform this? We're all pulmonologists here. Gone are the days of referring them to interventional radiology. You diagnose and you stage them in the same setting. Again, you diagnose and you stage them in the same setting if you want to achieve stage shift. In patients with high suspicion of N2 and 3 disease, either by mediastinal lymph node enlargement or PET uptake and no distant mets, a needle technique is recommended over surgical staging as best first grade. In patients with intermediate suspicion for N2 or N3, either by mediastinal lymph node enlargement or PET uptake, no distant mets, a needle technique is recommended again over surgical staging, grade 1C. And again, Dr. Rakesh Panchal talked about this. Who should get EBUS staging? Absolutely. Central tumor, suspicion for N1 disease, and large tumor size. The NCCN guidelines are updated almost every year, and you can put your name and your email address on the NCCN website. It'll send you these reminders whenever there's an update there as to, hey, this has changed. So you don't even have to follow them. And the ACCP guidelines will be revised soon. Let me now move on to restaging within T and 9, the 8 and 9. What is the difference between 8 and 9? As of January 2025, we urge everyone to start using the TNM9. The N2 has now been split into N2A and N2B to better differentiate survival. And the M1C is now gone into M1C1 and M1C2. What was M1C originally? M1C was just multiple lesions, correct? M1A was pleural effusion, pericardial effusion, pleural nodules, pericardial nodules, or a nodule in a contralateral lobe. M1C was multiple lesions. What do we move on to TNM9? M1C1 is multiple lesions, one organ system. M1C2 is multiple lesions, more than one organ system. How does this affect and manifest into clinical? Giving an example here. A T3, same lobe satellite lesion. If you were to do an N2 station, an N2 station would be 2R and 4R and 7. If you only did one lymph node and you stopped, and 4R was positive, and M0, that would be a T3, N2, M0. TNM8 would be 3B, likely a non-surgical candidate. Move now to TNM9, T3, N2. I urge you all to do a 4-hour, systematically 2-hour, and 7. Because if you have N2A, which is single nodal, 4-hour only, 2-hour and 7 are still negative. Now, mind you, all of these are N2, but each lymph node station needs to be assessed. And if you have N2B, which is multiple lymph nodes, 4-hour and 2-hour positive, even if subcarinal is negative, you have M0, that becomes a 3A and 3B here. The N2 is split into N2A and N2B. The M1C category is split into single organ, multi-organ system. The T component remains the same, and introduced the 8th is now affirmatively validated. And the TNM groups included in stage groups are reordered, primarily involving stage groups 2A, 2B, 3A, and 3B. The benefits: for global application, an international nomenclature accepted globally, a framework for future incorporation of non-anatomical factors for further staging and sub-staging, better distinguishing ability than the 8th staging, and a better predictive power and accuracy for the overall survival of small cell lung cancers. How do you use it? Clinically and pathologically. Clinical staging data from imaging studies and tests, and your pathological once you get the tissue to affirmatively stage it as a PTNM staging. Again, last before I end, the biopsy suggested for solid indeterminate nodules more than 8 millimeters, clear evidence of malignant growth in serial imaging. If you have a clinical pretest findings on PET are discordant, probability of malignancy is low, 10 to 16%, and a fully informed patient, biopsy is suggested of those more than 8 millimeter nodules. What about the part solid 8 millimeters, the GGOs? If part solid more than 8 millimeters found and persistent grows, recommend possibly PET, non-surgical biopsy, or surgical resection. And in patients with solid indeterminate nodule, more than 8 surgical diagnoses suggested, if clinical probability is high, nodule is intensely hypermetabolic, and when non-surgical biopsy is suspicious for malignancy still, and when fully informed patient undergoing definitive diagnostic procedure, that's when you go for surgical biopsy section. That's the standard approach. A multidisciplinary approach is most important for anything having an MDC or MDT, where you have representation from your pulmonary, your thoracic, radiology, your med-onc, your radon groups, and everybody else. The summary and key takeaway points here: suspicious lung nodules, consider likelihood of malignancy. Regarding the next steps, staging is key to prognosis and management. Understanding who is recommended for mediastinal staging, negative in the mediastinum. Endoscopic needle techniques like EBUS should be first line for invasive mediastinal staging. Multimodal diagnosis and treatment strategies for patients are best considered in a multidisciplinary format, and we have that every Friday morning. And an interventionist should have a general concept of treatment based on stage for lung cancer. Thank you, everybody, for listening.
Thank you, sir. It was an amazing lecture. We now move on to the next session on malignant airway obstruction. I'd like to call on Dr. Melvin Tate to come on the stage, please.
All right. Good morning, everybody. It's good to see all of you here. So I'm going to spend the next 20 to 30 minutes just bringing you through a rapid review on malignant central airway obstruction, in short, CAO. So today's agenda, first of all, I'm going to give you some background, and then after that, we'll move on to some pre-procedural considerations in terms of assessment and planning, followed by some management strategies in terms of therapeutic bronchoscopy, and then also to try to answer the question to stand or not to stand, and finally finish up with post-stand care. So as we all know, central airway disorders can be classified very simply into malignant and non-malignant causes. And for malignant causes, central airway disorders, they can be either obstruction or some form of fistula. And obviously, we know that the most common cause of is primary lung cancer, and then other possible causes include esophageal cancer, airway metastases, and sometimes primary tracheal cancer. And today we're just going to focus on malignant CAO. So what's the clinical impact of malignant CAO? So we know from data, existing data, previously it was thought that about 30% of lung cancer patients present with some form of malignant CAO, but we know from emerging data or more recent data that this is only about 13% at diagnosis. And on follow-up, about 5% of them will develop signs and symptoms of malignant CAO. And so what are the implications of malignant CAO? So obviously patients have lower survival, they have poorer quality of life, performance status, and also very importantly may jeopardize the potential for the patient to undergo systemic treatment by compromising either lung function or getting them prone to getting infections. So mechanistically speaking, I think it's very simple. Malignant CAO can be either intrinsic, intraluminal, or extrinsic from external compression, or a combination of both, which is mixed. So another way to classify malignant CAO will be anatomically. So we'll like to know the extent, the location, as well as the severity. And usually severity is a visual estimate of the cross-sectional area involved. So, as an interventional pulmonologist, we always wonder what are the benefits of bronchoscopy in malignant CAO. So, and what's the data, right? So, in patients undergoing systemic treatment, therapeutic bronchoscopy likely improves symptoms, survival, and spirometry, which is not so important, the last one, because it's not really patient-centric. But the caveats are that in terms of survival, it appears that purely intrinsic patients, obstruction, these patients actually have better survival outcomes as compared to extrinsic or mixed. And bear in mind that these treatments must be given in combination with cancer-specific treatment. So coming to pre-procedural considerations, I cannot stress enough the importance of selecting your patients well. So patient selection is key. CAO, the patient must have CAO, but the symptoms must be largely attributable to the CAO. As we all know, patients with lung cancer have many reasons for shortness of breath, whether it's a lymphangitis, pulmonary embolism, SVCO, etc. Right? And anatomy, and that's physiologic. And anatomically, it must have more than 50% narrowing, and there must be distal airway patency beyond the obstruction, and we also have to look at the pulmonary artery function, and the patient must have some acceptable performance status at baseline. There is an important caveat why patient selection is key. And this is because there is a discrepancy between technical success and symptom improvement. So for example, a registry from the United States, 93% of patients were deemed to have a very technically successful procedure, but only about half of them actually experienced improvement in terms of symptoms, right? So I think we really have to bear in mind that we do not overdo, right, therapeutic procedures in this group of patients. And moving on to a more detailed pre-procedural considerations, obviously informed consent is pivotal, and then followed by a history, whether it's acute, subacute onset of breathing, acute onset of shortness of breath, consider the comorbid conditions, C-spine involvement, antiplatelets, anticoagulants, as well as the oncologic therapies that have been given. And physical exam, basically, we just have to make sure that the patient doesn't have a difficult airway, or if patient is a potentially difficult airway, we have to make some preparation. Third will be imaging. Basically, normally it would just be chest imaging, chest radiograph, as well as a CT thorax. it's important to just make sure on the CD thorax, you would like to evaluate like tumor anatomy, distal airway patency. You can also look at the PA, and also, and as mentioned earlier, to look for other causes of shortness of breath. Reviewing recent studies is important because it sort of gives us a timing of the duration of the atelectasis. And also important thing is the caveat is determination of distal airway patency may not always be very reliable on CT. And therefore, ideally, if possible, a bronchoscopic visualization with or without contrast would be ideal. If not, then at least sometimes a PET scan can help to differentiate between collapsed lung as well as tumor. And finally, logistics, I think that is a no-brainer. So we have to consider the situation under which therapeutic bronchoscopy is going to be performed, whether you're going to use a flax or rigid bronch, the sedation, the anesthetic strategies, the type of artificial airway, if you are using, if you are going for GA, and then the ventilation strategies, hemostatic therapies, and even consideration of preemptive ECMO if needed. So the ACCP, so this is just in accordance to the ACCP Clinical Practice Guidelines, Management of CAO 2025. So for patients with suspected CAO, we recommend a comprehensive history and physical examination with a focus on the respiratory system, CT scan of the chest, and preoperative assessment. So next, we're going to talk about the therapeutic bronchoscopy in CAO. What are the procedural safety and steps? So how safe or how risky is therapeutic bronchoscopy? From the acquired registry, the mortality from complications is very low. Actually, it's only 0.5%. Complication rates are not, overall, are only about 4%, and 2/3 of them actually required some escalation. And in the CPG as well, rigid bronchoscopy is preferred, and general anesthesia, deep sedation preferred over moderate sedation. But just bear in mind, these are all conditional recommendations with very low certainty of evidence. So the management of CAO is quite basic. I mean, in terms of the steps, right? Number one, you need to secure the airway as appropriate. Number two, you need to establish the airway patency of the involved airway. And a few strategies, you can either recanalize, you ablate the tumor base and plus minus stenting, or if it's purely extrinsic, you just need to put in a stent. And third, after finishing the procedure, so if you have put the patient, on GA, under GA, and you can either extubate on table or you can keep the patient intubated and admit to the ICU. So these are the broad management principles. So I'd like to emphasize the importance of having a protocol. So this protocol is what we do in SGH because there was a case of a malignant central airway obstruction that was acute. The patient presented with stridor, but it was intrathoracic. So there was some confusion about at ER about who to call. So now we have a protocol designed at ER so that the ER physician knows what to do. So either they call ENT, airway team, or if the patient has got a known tracheal bronchial pathology or suspected to have, then it will be a stat IP consult as well as anesthesia. So what are the recanalization techniques that are available? So the factors affecting the choice would be the technical demands, how urgent the central airway obstruction needs to be treated, as well as the airway anatomy. And then also you need to consider the logistic demands, resource availability. For example, sometimes even in my emergency OR, if they don't have a theater with a laser port, then I will have to use APC. Right? So the recanalization techniques can be nicely summarized, either mechanical debulking, or bronchoscopic ablative therapies. So mechanical debulking, my favorite is mechanical coring because it's fast, swift, and decisive. In terms of bronchoscopic ablative therapies, they can be either immediate, have immediate effects, or delayed. And the immediate effects, the therapies can be classified either into hot or cold therapies. So the hot ones are the ones highlighted in red, right? And then cryorecanalization is the one in blue. So in terms of the delayed ones, I think some of the previous speakers have already talked a little bit about ablation as well as intratumoral chemotherapy. So I'm just going to move on. So the contraindications of bronchoscopic ablative therapies, absolute would be if it's a purely extrinsic airway compression, which is quite rare. And relative contraindications would include dystonia, atelectasis more than 4 weeks, and cannot tolerate low FiO2, especially when using hot therapies. And then if the patient is expected to pass quite soon. So this is just a summary table of the available bronchoscopic ablative therapies that we have. Right? So the hot ones are shaded in orange, and the cold ones are in blue. So there is, just want to make a distinction between cryorecanalization and cryoablation. So these are all cryo techniques, right? But cryoablation means that you just treat the tumor with series of freeze-thaw cycles, right? And then you don't really do any immediate debulking. You have to do a clean-up bronchoscopy a few days after. So the treatment is not immediate. And now moving on, talking about indications for airway stenting in central airway disorders. So in general, there are only 5 indications for airway stent in central airway disorders, right? So, and the 2 that affect malignant central airway obstruction would be for extrinsic compression from tumor or nodal metastasis, prolonged airway patency after bronchoscopic ablative therapy, and also stents can be used to treat malignant aerodigestive tract fistulas, non-malignant strictures, and also to stabilize collapsing airways, although it's not so ideal most of the time. So comparing the stents, so how do they compare in terms of silicone and metallic stents? Make it very simple, if you read the literature, they call it hybrid stents, whatever, but I think I'll just simplify it, silicone and metallic. And most of the time, we don't usually use purely metallic. That means purely uncovered stents. So it's either partially or completely covered metallic stents, and the material can be silicone, PDFE, etc. So in terms of affordability, I still think the stents are expensive. And in terms of ease of deployment, I think both are easy, but the metallic is obviously easier. And in terms of removal, metallic stents are harder, although obviously the manufacturers of the covered metallic stents will tell you that, oh, actually it's pretty easy as compared to the partially covered stents, where there's an ingrowth of tissue, mucosa, and epithelialization. And in terms of complication rates, in the literature, the most common complications would include migration, granulation, mucostasis, and infection. And I'll discuss later, in the literature, the complication rates are similar. And also in terms of versatility and usage and customization, I think, in my opinion, at least, silicone is a bit more versatile in terms of customization, because we can do it on the spot by suturing, and obviously just customizing it ourselves, DIY. So the question is, does stent choice impact outcome? So there is some discrepancy a bit between the WABIP guidelines as well as ACCP guidelines, which I'll talk about later. So, but in terms of benefits, we know at least that stenting may lead to improve quality of life, performance status, improve survival, and early liberation from mechanical ventilation for respiratory failure. And therefore, in the WABIP guidelines suggest airway stenting. However, the ACCP guidelines suggest stenting only after the initial treatment has failed. So either the first bronchoscopic therapy, systemic treatment has failed, then you consider stenting. But I think it's a very complex question. So it takes into account a lot of factors. So it's a case-by-case basis, in my opinion. All right. And in terms of risk, the incidence of stent complications appear to be similar from the literature, although we know that the wide stent appears to migrate less than the straight ones, but because of the greater area of coverage, they may have more mucostasis. So the stent choice in terms of material and shape really depends on the provider factors, the operator experience, the availability of the stents, as well as patient factors like their cough strength, CAO anatomy, etc. So this is the stent armamentarium that we have in SGH. So initially, for metallic, we only had Ultraflex from Boston Scientific. And that more recently, after one of my colleagues came back from the United States, we got in the Bonner stent from Thoracen, which is nifty. Because of the hook and cross design, its conformity is it appears to be better, in my opinion. And then we have the Leuven metallic Y stand, and obviously the traditional good old straight and Y silicone Dumont stands. And obviously, like I said, this is an angulated stand, which my mentor and I wrote a paper on. So most recently, we put in an angulated stent in a 13-year-old girl with very bad TB stenosis. So I'm just going to show you a video. So this was a lady with a locally advanced esophageal CA, underwent definitive concurrent chemo RT, and then initially presented with central airway obstruction affecting the left main. So put in a straight stent, silicone stent in the left main. And after that, she was doing well for about a year, actually. Yeah, and then she started having complications, and there was like some distal airway obstruction, right? It didn't look really like granulation tissue. And obviously I had to exclude tumor. And therefore, just now earlier, what I did was that I went in with a cryoprobe to make sure that there was no tumor, and then just balloon dilate the distal stenosis, and you could see actually, let me show you. So, and then a bit of, sorry. Yeah, a bit of laser as well. So it's actually very close to the secondary, very distal left main, almost abutting the secondary carina, right? But the issue was the PET scan and everything actually didn't show that there was tumor, and it was confirmed on histology too. So it wasn't really. Our suspicion eventually was some form of post-RT kind of stenosis, and therefore the Bonner stent was very helpful in conforming to that very tight space, and so I just managed to just interlock it with the straight silicone stent, and she's doing well. Okay, and finally, we're going to finish up with post-stent care. And once again, there's some discrepancy. So how do you manage patients after they have been stented, right? So the WABIP guidelines suggest surveillance bronchoscopies 4 to 6 weeks after stenting to detect stent-related complications even if they are asymptomatic. But ACCP CPG suggests either, right? But in my clinical practice, actually, I'm more symptom-driven. Yeah, and most of the time, I realize that after I've stented the patient, a lot of times they would have some form of imaging done by our oncology colleagues anyway. So I don't routinely do it at 4 to 6 weeks. I just go by symptoms. Yeah. And then also, the WABIB guideline also recommends or suggests the use of routine use of pulmonary hygiene measures. And actually, in the statement, the experts consulted in a guideline use nebulized saline, which I don't use. I usually ask, after the procedure, I always get the physio and the chest physio to really just move the patient and then teach them some breathing exercises, and then to try to get them to cough. And also, sometimes, if needed, then they might need some mechanical device, such as the a cappella device. And in terms of follow-up care and education, ideally, the patients should have ready access to care, and this is not just in terms of when they develop symptoms, but sometimes they may have like questions. It would be good to have a nurse to manage outpatient symptoms and queries. And the interventional pulmonologist, like once you put in the stent, like one of my mentors told me, you're married to the patient in a sense, So you have to be readily available to manage any complications from the stenting. Patients should have a stent card, especially if they come into an ER. So sometimes you'll be good. So at least if they are in extremis and they need to secure the airway with ETT, at least the ER physician would know where the stent is so that they don't worry about dislodging or causing stent migration. And finally, obviously, patient education is very important. And so this is just sort of like a summary table to tell you the difference between the WABIB guidelines for airway stenting as well as the ACCP CPG. So just importantly, in terms of the WABIB guideline, use routine surveillance bronchoscopy at 4 to 6 weeks, but ACCP is, you can do either approach, okay? And then post-stenting, there is also a suggestion to use pulmonary hygiene measures to reduce stent complications, but the ACCP did not make any comments on that point. Okay, and thank you very much for your time. Yeah, thank you.
Thank you, sir, for an extremely informative lecture. I'd now like to invite Dr. Daniela for her next talk on airway stenting in 2025. We welcome you, ma'am.
Hello, everyone. Thank you very much for the invitation. I'm very excited to share with you my experience and also the future developments for our patients. I don't have any conflict of interest. If we are speaking about history, we should talk about Gustav Kilian, because we are here because he wants to remove foreign bodies, even if it was ear, nose, throat doctors. He wants to go far away and to remove them, and he developed the bronchoscopy. I steal this photo for Professor Gasparini from yesterday's topic, because we can see in here that rigid bronchoscopy was developed in 1997, but 100 years after, the stents are coming. All starts with a Montgomery tube. Everybody knows it. And extendable metal stents, the surgeons are developed then. You can see it now. And the GI doctors, Jan Torino stents in here. You can see it at the right. Like my colleague said, the metallic stents have some complications. That's why at the beginning they were using it, but nowadays we know better. You can see in here some complications after putting metal stents. They can destroy the trachea, the mucosis. They advance and they make it, like Melvin said, the covered stent, metal stent. They try to cover it with combined metal and silicone. After days, the bioabsorbable stents offer a temporary solution. They are at the beginning for the pediatric patients, but afterward, for the adults also we are using it. And nowadays also with 3D print stents. My colleagues also showed these stents to you, and in my opinion, self-extended stents, I'm using it for the malignant situation. They are easy to install. When you have some bleedings, you don't see very well, you can put it quite. They are most commonly can expand to fit the diameter that you need. But they can migrate, they can cause damage, and if you leave them a couple of months, they are difficult to remove. The silicone stents are custom cuts. This is the benefit. You can cut it in your way, and what do you need? It's a long-term tolerance. They are flexible. And nowadays, the biodegradable stents, drug-eluting stents, radioactive stents, and the 3D stents. This is how we are putting a silicone stent for the tracheal stenosis. For the self-extended stent, you already saw with Melvin, I think. They are already in the device, and you are only put them in the bronchial where the stenosis and where you're needed. And I tell you, they can expand in the bronchial. This is collapsus. You can see a collapse at the left, now at the right, and you can see it after in the trachea also. And we decided to put a silicone stent for tracheobronchial malacia. You can view in here. Put a lot of videos because yesterday everybody told me, how are you putting the stent? What is your, did you see that Melvin is putting in his way with the balloon? We are putting with the bronchoscope. You can use everything to open up your stent. The forceps you can see in here, and the bronchoscope also. This is the part of the trachea, and after you will see at the main bronchial also. You would see that the tracheobronchial malacia, you are dilated, but after the bronchial will, the stenosis will come back. This is a stent for a fistula. You know, not every time you can put a stent because there is tissue is very fragilized, and with the silicone stent you can increase the fistula. That's why you have to be careful. But you can see in here the tracheal fistula. You can see that the stent is a little bit far away when we deployed it. And now with the forceps, we'll put it in the trachea. And after we will open the stent to fit the measurements. if you don't achieve it, you can put it with a forceps, you can open it. After a while, this is the results. For the after tuberculosis, I think Melvin already showed to you. We can put, we are using the silicone stand. Maybe some of you can use the extendable ones. In here we have post-intubation tracheal necrosis. This, I think, is an old case because nowadays we don't see it anymore. You know, with the pressure, with the balloon, make this necrosis. Nowadays we measure all the time the pressure in the balloon of the intubation tube, and we don't have anymore these cases. But you can have some damage of the trachea in an intubated case. You can see the cartilage, everything is damaged. And we need to cover this. Like this, the secretariation will do it behind the stand. Yes. Okay. This is for relapse polychondritis stand. I'm sorry. You can see everything is and you can see a silicone stand. Put it. A T stand, a Diabolo stand, double-shaped. For the lung transplantation, sometimes we have some difficulty with only one, but Melvin also showed a lot of stand. This is an HICC stand at the right and at the left. You also can put an HICC stand, but this time the angle wasn't matched. That's why we put extendable stand. This is the area of the action, and if we want for the little bronchial, we should think about a biodegradable stand also. This is my patient that after a surgery has a collapse. You can see it in here in the bronchial treatment. You can see a collapse of her lower left lobe that required daily bronchoscopic toilet for aspiration. And we decided to put a biodegradable stand for her. You can see it at the right. And you can see at the chest rate that the atelectasis at the lower left lobe after the stand was released. After total degradation, the initial collapse was reduced. There were no recurrent infections episodes, and since there, she was very good and didn't need another stand placement. This is the stand that we put for her. And you can see in here, because it's polyadenoid biodegradable polymer, for surgery and suture, and you can see in the picture the degradation of the stand. And what else? We can do some custom-made stand. You can see in here, after a lung transplantation, a patient loses his upper lobe, and we needed a stand, a trifurcate stand, and with a CT scan and bronchoscopy, we designed this stand and put it for him. These stands are unique for each patient. The design is very important. You should talk a lot with the industry. The quality of silicone is important. Effectiveness of the stand and the risk of complication and migration. This is another stand at the left, also custom made. They can reduce the number required of stand changing. They improve durability, doesn't deform because it's made for the patient. It's held well in place and doesn't migrate. At the present, there are two societies. In US, you can have visionary air solution with the stand. I don't have any experience. I work with anatomic modeling, and you can design the stand that you want. These are the costs. I will not speak about the recommendation. Melvin already did it. And what is the future? We can have 3D stand bioresorbable. we can have a drug-eluting stent with anti-inflammatory, anti-prophylactic, antimicrobial, personal therapy delivering chemotherapy. The smart stents, they can measure airway pressure, airflow, or other physiological parameters. And some other tent would respond to changes in the airway environment, such as temperature or pH. We have a lot of choice for our patients. We should think of your indication for your patient. You should think of design also, the quality, our expertise, a good collaboration, and don't forget, it's still a foreign body. Thank you very much. Nothing will be possible. I'm not alone. I have a team that I work with. And I would like to thank you very much to Preeti and Harry for inviting me. It was a great congress. And if you have any question, this is my email address. Don't hesitate. If you have some questions.
Thank you, Dr. Daniela. Ladies and gentlemen, gone are the days when India was simply known for delivering reasonably quality care to our patients. Events like the BRONCHUS is our answer to the world that not only are we excelling in patient care, but we are literally the pioneers of research and innovation. We are also essential contributors to the global community of healthcare providers. We have set the standard for pursuing knowledge and staying dedicated to the mastering of newer technologies and avenues of clinical practice for a singular purpose. We want to translate all of the knowledge of the world, the information and expertise that all of the faculty have to offer for one simple goal: excellence in real-time patient care and innovation and research. We are quite literally putting India and Hyderabad on the global map. It gives me great pleasure and honor to move forward to invite the people who have made the event like the BRONCHUS possible to the stage. I now hand over the stage to Dr. Vishnu Reddy, sir, for opening the inauguration of BRONCHUS 2025.
A very good morning to all the ladies and gentlemen. It's indeed a great honor and a pleasure to stand in front of you and welcome all of you on behalf of Yashoda family for this fantastic conference, BRONCHUS 2025. I'm sure over the last 1.5 days you had a great program and you're looking forward to more academic fees to come through. We are just going to have a brief academic inaugural session which is going to be slightly different from the routine. We wanted to make it more experiential for all of you and showcase that Yashoda Hospital is not only a hospital, but we do much beyond the hospital. Yashoda Hospital lung transplant. We'd be honored to have you on the stage, sir. Professor Shaf Keshavji. We'd like to invite Professor Robin Voss from Belgium. He's a transplant pulmonologist from Belgium. I'd like to take this opportunity to invite my Managing Director, Dr. G.S. Rao, sir, to kindly come onto the dais, accompanied by Dr. Harikishan Gongutla, who is the Senior Consultant Pulmonologist in Yashoda Hospital. We will proceed with the lamp lighting ceremony. That is there's a culture of our country wherein we believe that the light is what will dispel darkness, and this is the light of knowledge. So I request all the delegates on the dais to kindly proceed to the Dr. Harikishan. Dr. Harikishan, kindly come onto the dais, please. Dr. Harikishan is going to address the gathering and is going to tell this whole idea behind this conference.
Yeah, first of all, I would like to thank Yashoda Hospitals, our directors, Dr. G.S. Rao Garu and Dr. Pawan, for encouraging me in every aspect. Whenever I have some idea or I have some new thought process, they always encourage me in every aspect, and they always discuss things how we promote pulmonology. So the whole conference of BRONCHUS is showing what pulmonologists can do to the whole medical community. And this is the fourth annual conference, and I'm really happy that a lot of you have come to support bronchoscopy and share your ideas and thoughts with us. I particularly thank the international faculty for coming from across the countries. With one single call, they all came here and then graced this occasion. And also the national and all the delegates and national faculties also. I thank you all for coming for this bronchoscopy conference. So when we talk on pulmonology conferences, bronchoscopy seems to be a small part of pulmonary medicine. But this Congress shows how big our community of bronchoscopy. And that's the whole idea, that we promote interventional pulmonary medicine and bronchoscopy practice. So I will not take much time, and then I invite the next speaker to give their ideas. Thank you.
Thank you very much, Dr. Hari. Now I request, I know everybody is more interested in having the conference going forward, but I would take this opportunity to invite Professor Kyle Hogarth to kindly address the gathering and tell us about the experience that he's been having on this conference.
I think it goes without saying that in order to put on a conference this large, in order to see the growth in interventional pulmonary that we've seen in India, it takes leadership at multiple levels. And so I think the highest compliment needs to go to the team that leads things at Yashoda, to take the time and money to invest in the vision that Hari and others have, that have brought all of us together to such a prestigious and amazing conference. You don't get things like this just from being a good doctor. It requires a vision and leadership and people willing to put the effort behind it. So it's a hats off to the organizers to see the vision that we've all had, those of us that do all this, to be able to get us all together, to lead everyone into the future so that we continue to have growth in the field that we love and our better ability to take care of patients. So my hat's off to the organizers. More importantly, I think my hat's off to leadership within Yashoda, and then ultimately to all where we are today and where we're headed. So thank you so much.
Thank you very much, Professor Hogarth. Now I'd like to invite upon our director, Dr. Pawan, to kindly address regarding the scientific aspects of the conference and how Yashoda has actually taken pulmonology to a different level in our country. Thank you.
Yeah, Dr. Vishnu, I think maybe I finished my quota, but one more time. So first at the outset, our health minister was supposed to hear, but he personally called and apologized, like he had an emergency meeting with CM Garu, so he could not make it, but he wanted to convey his wishes for this great conference. So this is the fourth edition of BRONCHUS, and each time better than the other. So because of Harikishan, like even Chaumala Palace, I'm seeing first time, even though being a Hyderabadi, the other night I've gone there and because of that. But we thank all the delegates, international particularly, who have come from all over the world with a red eye and all, and they're mostly in and out. I think hardly anybody is having any vacation. But here in India, we are lucky to have the legends of pulmonary and this year thoracic too. So we don't have an opportunity to meet so many people in person commonly. So it's a great honor for all of you to be coming here, and same for national faculty from all over the country. So sometimes politicians throughout the world may or may not get along with each other, US, China, Russia, Japan, Iran, Iraq and all, but in pulmonary though, we have representation from almost every country, every district of every state of India too. So I think we are showing to the world, not only in the pulmonary but other things, that we can do great things together. So I think I'm especially proud for all this. And we have like a special thanks to Harikishan and all. When he was in medical school and all, I met so many people. Nobody would think, wow, Harikishan, I never would have imagined you are become a consultant and do all these kind of things. But here you're on stage, you're doing the biggest conference here and getting all these people. And you're doing all high quality things in the country, including cone beam, guided, CT guided bronchoscopy, navigational and all. So it's becoming little more expensive for us. So as long as you have no more requests till next year, or you have to justify that revenue based on the things, so we'll not buy any more equipment till we get the revenue. No, just kidding. But we are really pushing the boundaries in everything. Recently we had a lung transplant after 73 days on ECMO and 73 days on ventilator and 45 days on ECMO. So it was more than 115 days or something. After that lung transplant, patient went home without even oxygen, and he was especially grateful. Just recently, before coming in here, I did meet him, and so we are really pushing the boundaries, and we are doing great work here, all because of your inspirations. So before you go, all of you can have a good networking session, which each of them are more than willing to share their experiences. And for the press and electronic media, thank you for your patience. To start at 10:45, I think, but we are maintaining Indian standard timings. I think it became a little later. We apologize, but thank you for covering this message. And once again, we wish you all the rest of the great BRONCHUS and safe flight back home. And again, next year we'll have an even bigger and better one too. Thank you. Yeah.
Thank you very much, Dr. Pawan. I think what Dr. Pawan was telling about the investment is a huge investment in bronchus, in pulmonology, and we have seen it happen in the last 5 years or 6 years, and now we are really recognized for our pulmonology services across the country and the world. I would take this opportunity to invite our Managing Director, Dr. J.S. Rao sir, to kindly address the gathering.
Good afternoon. All the dignitaries and professors on the dais, and all the dignitaries of the dais, Dr. Pawan, Dr. Harikishan, HOD, Pulmonology, Yashoda Hospital, Hyderabad, all the distinguished guests, esteemed colleagues and friends. It's an absolute honor to stand before you at the BRONCHUS 2025, one of the most influential interventional pulmonology congress. This platform brings together the brightest minds in the field of pulmonology. I am proud that Yashoda Hospital, Hyderabad, headed by Dr. Harikishan and team, is hosting this landmark event. 25 theme. Harikishan did a very good thing of bringing the minimally invasive interventional pulmonologist with a minimally invasive thoracic surgeon, collaborating, cooperating, bringing inventions, innovations for the patient care. I am sure everybody knows that minimally invasive will bring faster recovery and better outcomes. This is the theme of this 2025. Our journey in pulmonology was started from almost from the bottom to today, exceptional respiratory care. That's what is we are feeling. From asthma, tuberculosis, COPD, chronic lung diseases, we have come into a pioneering system called interventional pulmonology and its techniques. Today, we stand at the center of excellence because of four core points. One, passionate, hard-working pulmonologists. That is the number one. Advanced infrastructure. You name it, we have it. And multidisciplinary collaboration. I don't know, you have seen, the pulmonologists are engaged with the critical care people, radiation, and pathology, surgeries, all other specialties. That gives a better patient cooperation and care. Yeah, I think sound is angry against me because I have to leave it fast. I'll do it. One commitment to our excellent, this thing is groundbreaking ceremonies. We have guided biopsies. I think he did long back, he told more than 100, I am sure. I don't know now how many he has done. You have all the equipment, vapor ablation, what is called bronchothermoplasties. And I want to tell you one more thing. With the team of Dr. Bala Subramaniam, our lung transplant surgery is going on very well. And I am also happy about the results what Dr. Bala is giving us. Thank you, Bala, for that. And definitely, this is pushed by our pulmonology team. Department of Pulmonology under the guidance of Hari and their team built a strong research wing. They have published a lot of papers. Department of Pulmonology won the best image content at WABIP for the 5th consecutive year, 2001, 2002, 2003, 2004. I also congratulate Dr. Preeti for winning the best research poster abstract recently, WABIP 2024. Today, with all the hard work of all pulmonologists, all the administrators, we stand as one of the best in pulmonology in India and abroad. Especially, COVID taught us a lot of lessons. We had 109 air ambulances dumping from different parts of our country with a lot of critical cases with ECMOs and complex interventions. We could raise to the occasion and treat them because we have 4 or 5 hospitals in this city. So a lot of hard work has went into that. And I really congratulate Dr. Pavan for the organizing all such things. I am confident that in the future also we will do exceptionally good care in pulmonology sector. I conclude my address. Let us come together, define the future of this respiratory care. I thank you for giving this opportunity. I also thank all the organizers for organizing, along with Hari, such a good conference. I also thank pharma and medical device industry for taking part in this program. Thank you very much. Thank you a lot.
Thank you very much, Dr. J.S. Rao sir, our Managing Director, for his kind words. And this comes to the end of the inaugural ceremony. I would like to thank each one of you present here, the national, international faculty, and all the delegates without whom there's no conference. I would like to thank the industry, and especially the print and the electronic media who are going to take this forward and, to the society. What we are doing here, unless until the people at large are aware of what is happening, I don't think it is possible. And I would definitely like to thank the venue, the Novotel Hotel, for arranging such a fantastic venue, and our digital team for making this a really beautiful experience. Thank you very much. And I think I'll hand over the mic proceedings to Dr. Tahemi to continue with the scientific session. Thank you.
Thank you, sir. After that wonderful inauguration, let's continue with the scientific session as said before. The next session is going to be bronchoscopy for obstructive airway diseases. The next talk will be Dr. Pallav Shah, and he'll be presenting on endobronchial valves for COPD. Dr. Shah, the stage is yours.
Ladies and gentlemen, namaste. This is your captain, Dr. Hari Kishan, welcoming you aboard BRONCHUS 2025 with Yashoda Hospitals. A warm thank you for choosing to embark on this bronchoscopy journey with us here in the heart of Hyderabad, the city of pearls. Before we begin, a quick update on the weather. Conditions are clear with a pleasant temperature of 26 degrees Celsius. Perfect weather for learning and exploration with no turbulence expected on this educational flight. In case of an emergency, please call 105910 for immediate assistance. We are set for a journey lasting a total of 36 hours, where we'll explore the highs and lows of current day bronchoscopy practices. Your lead instructor, Dr. Preeti Vidyasagar, along with some of the finest minds in the interventional pulmonology from across the country, will guide you through customized sessions designed to meet the needs of modern-day practice. I have on board the legendary Professor Kyle Hogarth, who will join forces with Dr. Pallav for an exciting debate on robotic bronchoscopy. Expect a bit of intellectual turbulence during this lecture, but rest assured, we'll navigate it smoothly. Now let's walk through the key highlights of our journey. The itinerary is split into didactic lectures and hands-on interactive training modules to offer a rich learning experience. On your left-hand side, we have the Exhibition Center, showcasing cutting-edge technologies and futuristic advancements in bronchoscopy. Don't forget to explore it during your free time. And for a taste of innovation, make sure to attend Lorenzo Corbetta's session on augmented and virtual reality in bronchoscopy education. We will also keep you active to reduce the risk of DVT. We encourage all passengers to participate in the 2K run on Sunday morning at 6 a.m. For your in-flight entertainment, we've arranged performances by the talented band with 3 of us and her, and the band group. Hungry? Don't miss out on the authentic Islamic cuisine, including the famous Hyderabad biryani, Irani chai, and Karachi biscuits. As we cruise through the skies, you'll get glimpses of the largest healthcare system in Hyderabad, our very own Yashoda Hospitals. Spread across the city's 4 corners with 4 units. When you hear me announce Yashoda, look out the windows, and no matter where you're seated, you'll spot excellence in healthcare. Lastly, while you're on the ground time in Hyderabad, take a moment to explore the city's rich heritage. Visit Charminar, marvel at the Golconda Fort, those iconic bangles and pearls that give the city of pearls its name. As we prepare for takeoff, may I request all participants to kindly fasten their seatbelts and stay seated during the lecture sessions. Movement is only permitted during scheduled breaks announced by myself or the instructors during tea or lunch breaks. Once again, on behalf of BRONCHUS 2025, I thank you for joining us on this journey of knowledge in this country. Sit back, relax, and get ready to experience bronchoscopy like never before.
Just a small announcement, the other ITMs and the thoracic session will be starting in the other halls. So whoever faculty or delegates who is assigned to ITM or in the thorax hall, kindly assemble in the thorax and other ITMs for starting the further session. Thank you.
Great, thank you very much. It's been an enthralling morning and 2 days already. Thank you, Harry and Yashoda Hospital for inviting me and all my friends to this wonderful location. It's a great privilege of mine to start really with bronchoscopic lung volume reduction with endobronchial valves. And I know that India is very soon going to have access to this technology, and it's a great opportunity for us to look at this work. These are my conflicts of interest. And basically, this journey of endobronchial valves started over the last 5 years. One of my colleagues, Tudor Toma, myself, and Duncan Geddes, we started the initial work in London, and then this work has been transformed internationally with 7 randomized clinical trials, and now it's a kind of gold standard. It's established therapy in the COPD Gold Guidelines, which are recognized for COPD all over the world. So I'm not going to go through each individual trial in immense detail, but really wanted to show you this journey where we have, in interventional bronchoscopy, done very systematic, careful evaluations to really make sure that, firstly, we understand the technology. Secondly, we know what patients to treat. We know what's the complications of this therapy, and we know its advantages and its competition. The first randomized controlled study was the WEN study, where a lot of the people in the audience took part in. And when we looked at the initial data for this study, it was quite disappointing, because although it was statistically significant, was it clinically meaningful? A 7% difference in FEV1, patients walking by 12 meters more, and a change in SGRQ scores, which is very similar to most inhalers. But actually, when we looked at, if you perform the procedure correctly and you chose the right patients, then you're getting clinically meaningful response in these patients who are actually very desperate. And you're seeing 8-point changes in quality of life, 24% improvements in lung function, and people walking significantly more than before. That we did was actually a sham-controlled study in London at the Brompton. We randomized 25 patients to the sham arm, 25 patients to the endobronchial arm, and you can see that in the sham arm, you're getting results which are very similar to some of the inhalers which have $1 billion industry. So with the FEV1, you can see in the treatment arm, there's almost 25% improvement in FEV1, considering one of the definitions for COPD is irreversible airflow obstruction. And you're seeing, once again, meaningful improvements in quality of life and 6-minute walk tests. And what we also learned in this trial, that actually if you excluded patients who were collateral ventilation positive, then those improvements were even greater. My friends in the Netherlands did a very similar study. It was an open-label randomized study. And once again, you're seeing very similar improvements. You're seeing improvements in FEV1 of more than 150 mils. You're seeing 6-minute walk tests almost improved by 60 meters, which is absolutely unheard of. Then we had the IMPACT study, and in this study we treated patients who had homogeneous disease. So up until now, it was felt that patients only with heterogeneous disease were suitable for treatment for lung volume reduction. But this study shows that if you, once again, if you choose the right patient population and treat them appropriately, you are getting significant improvements in quality of life, lung function, and exercise capacity. And one of the themes you'll start to see, which I'll put together then, every single sequential trial is expanding the horizons of who we can treat, but yet the outcomes are the same. All of these patients are seeing improvements in lung function. All of the studies are showing improvements in quality of life and improvements in exercise capacity. So all the signals are going in the same direction. So this is very real. The Transform study was a very important study because it took several centers through Europe. Majority of the centers that were involved were there for the first time, so they weren't the expert centers, they weren't the Felix Hertz or the Stefano Gasparinis of the world. They were actually straight off into interventional pulmonology, and they reproduced data which was identical to the Yodas like Felix, which is again really quite satisfying because it shows that you can spread this technology very easily in multiple hands and yet get very consistent results. And you can see again, you're seeing improvements in FEV1, reductions in lung volume, and yet over that treatment period, the control arm were actually deteriorating. Then, I always use this slide to tease my friend Kyle Hogarth. I said the real test of this study was to take the European work and involve our friends from America and see if we can reproduce the data. Now, this was actually still a very clever study in the sense that it looked at outcomes to 12 months. So none of the studies thus far had chosen such a longer-term outcome. The other interesting design in this study was at day 45, we had to look at our data, and if you did not achieve correct valve placement and the patient had been randomized to valves, you got a second chance to get it right, and therefore optimize valve placement and then look at the outcomes. And you can see in this Liberate study that at 12 months, almost 50% of patients had an improvement in FEV1 of greater than 15%. I personally think that this is quite a high bar to reach at 12 months. Similarly, you can see that all the other parameters, once again, are going in the same direction. Life-changing improvements in quality of life. So just to put this into context, if you take someone who's been suffering for quite a while and is housebound, you treat them with endobronchial valves, and now you give them back their dignity. They can go out to the shops, they can go and buy a pint of milk, they can go and buy their newspaper, and it really makes them independent compared to what they were doing before. The secondary endpoints again meet all the parameters that I've already shown you, but just to put into context, what is the main complication? Well, the main complication for endobronchial valves is pneumothoraces. And fortunately, most of these seem to occur in the first 3 or 4 days of treatment. So the main message here was, initially when I started doing endobronchial valves, we would put the valves in the morning, the patients would go home in the afternoon, but we lost a few over this period, and we very quickly realized that the main issue was pneumothoraces. So if you keep these patients in hospital for at least 3 to 4 days, you are there and you can respond to the pneumothoraces, treat them with a chest drain, and mitigate the main risk of technique. The other complications which we see are those which we would get with any therapy where we're bronchoscoping these patients, which is COPD exacerbations, pneumonia. When we first started, we felt that one of the main concerns would be lobar pneumonia, where the valve would be obstructing the secretions, causing problems. But thankfully, this hasn't really been a problem, and very, very few patients had to have the valves removed for obstructive pneumonia. And then there are other small things like airway kinking, expectoration of the valves, but that should also be less of a complication since the valves have undergone some refinements, and we now have some low-profile valves which fit the airway more snugly and therefore less likely to be expectorated. Now, one of the other things we saw was that actually very early on that there was possibly a signal on mortality. Up until now in COPD, only oxygen therapy and transplantation has been shown to have a survival benefit. But what we saw, that patients we had treated initially with endobronchial valves and had developed atelectasis were more likely to have a longer survival compared to those who did not receive atelectasis. And then my friend from Heidelberg managed to replicate the data with just the huge numbers of patients. And again, once again, you can see that patients with atelectasis had a much better survival than those who did not. So to put all these data together again, what you're seeing is very consistent improvements in FEV1. And if you put this in context with surgery, personal feeling is that surgical lung volume reduction is extremely successful. And if you look at the net data in the right way, you're looking at improvements in FEV1 of almost 27%. You're looking at improvements in exercise capacity of 42 meters and incredible improvements in SGRQ of almost 13 points. If you then look at the data for valves, you can see that they're almost matching the same outcomes. So what this tells me is that, number one, volume reduction by whatever means, providing you do actually achieve volume reduction, will lead to quite significant benefits in patients. And now, really, we have a non-invasive option of endobronchial valves. And the research thus far has shown that it's essentially unilateral occlusion that we aim for. We can treat both heterogeneous and homogeneous patients. The main caveats is that these patients have to have intact fissures and absence of collateral ventilation. But we've been pushing the boundaries a bit more, and if you look at patients with a fissure that's partly disrupted, i.e. by less than 15%, we can inject a sealant, so AeriSeal, into the area where there is the least fissure integrity, and then you can see following fissure sealant, if you then put the valves in, you basically get further volume reduction. And we've done a trial, and the preliminary data again shows that you are potentially able to convert 3/4 of these patients, thereby expanding the population that can be treated with endobronchial valves. The main complication of this therapy is a pneumonitis that occurs in a small proportion of these patients. So the new algorithms that we go for are, if they've got complete fissures, then we will proceed directly to valve treatment. If they've got incomplete fissures which are greater than 20% incomplete, then we will look for alternative therapies such as surgery. And in that borderline group, we can evaluate them further, and they may potentially have a sealant target, which may then allow us to treat them with endobronchial valves. And finally, I just wanted to mention the surgery versus valves trial that we conducted in London and the rest of the UK. And the main message here is equipoise, that these patients who are suitable for both therapies seem to have similar outcomes irrespective of what therapy you choose, both in terms of lung volume reduction, exercise capacity, but also mortality and complications. And basically, I'd like to stop there, and then I'd hand over to my colleagues who will expand this therapy to other areas. Thank you.
Thank you, Dr. Shah. We move on to the bronchoscopic treatment options for chronic bronchitis, and this session will be led by Dr. Constantina Contogiani.
So good morning. Thank you very much for the really kind invitation. This is an honor for me to be here and participating in this magnificent event. I'm going to be talking about the bronchoscopic treatment options that we have for chronic bronchitis. So this is not the emphysema patients which we had just heard with lung volume reduction valves. These are more this phenotype from COPD with chronic bronchitis and a lot of cough and sputum. My conflicts of interest. And we all know what chronic bronchitis is. It's chronic cough and sputum production for at least 3 months in 2 consecutive years. What we have a lot of goblet cells, much more increased, producing mucus. We have a lot of inflammation, activation of the vagus nerve, and of course the patients have a high risk of exacerbations, which make the quality of life worse, and of course the risk of mortality increases. Characteristic of these patients is that they have in CAT score, the first two questions, they score really high. So we have a lot of cough and a lot of mucus. You've seen this wonderful graphic of Hartmann in the publication for 21. The treatment options that we have. At 12 o'clock, we have the chronic bronchitis, epithelium. You see a lot of goblet cells. We have the balloon disobstruction as an option. A few publications, there are not really wide experience with the balloon disobstruction for chronic bronchitis. We have the bronchial rheoplasty and the cryospray, you see on the bottom. And we did have in the beginning the vagal nerve ablation, which started as a chronic bronchitis treatment, but then evolved to treatment of exacerbations in COPD. So I'm going to be talking about cryospray and rheoplasty here. Starting with the rheoplasty. What is rheoplasty? We have a catheter which delivers pulsed electrical fields. These are high-frequency fields, short duration, non-thermal electrical fields. What we deliver them directly on the epithelium, and our goal is to ablate the cells that produce mucus, and then cause non-necrotic epithelial and submucosal cell death. You see that we ablate from the epithelium and go deep to the cartilage with this method. Our ablating and disappearing of these cells allows the normal healthy epithelial regeneration to occur, and this happens a few days to weeks after the therapy, after the treatment. We have monopolar electrodes. This means that this treatment is not available for patients with implantable cardiac devices, and we have a CE mark since 2019 for this therapy. How does the procedure work? We need two different bronchoscopies. We start with one side, and approximately 1 month later, we treat the second side. And we start from the periphery, from the distal, from the small airways, and move slowly back to the central airways. We want to treat as much epithelium as possible. This means overlapping manner, and this translates to about an hour procedure, 40 to 70 activations per lung. The more activations, the better the results that we have. This is our equipment. We have the generator. We have the rheoplasty catheter with the electrode, which looks like a balloon, metal balloon. We have the heart monitor, rigid or flexible intubation. We need at least 2.8 working channel minimum so that the catheter passes through, and general anesthesia. This is, as I told you, about an hour, the whole procedure. This is how it looks like. We have on the left side, you see the catheter. We it on the bronchoscope, and you see on the bottom the balloon, which is not, you see the treatment maybe better now. You see in the bronchi, we expand the balloon, we want circumferential contact of the balloon, and then stay there and apply the energy for a few seconds. When it's finished, you have an auditory signal that the ablation is finished in this position. You move a little bit closer, approximately, and go to the next level, and continue like this until we have all visible bronchi and segments treated. This is a clinical program from RIOX, different studies all over the world. We have the first feasibility study, safety and feasibility study, and then continuing to the European registry, early feasibility studies for the US, and also the big randomized controlled trial, which completed its enrollment, but we don't have the result yet. So I don't want to go in very detail about each of them, but just give you the point of what comes out, because it's the same, actually the same or similar results for all of them. The first one, in 3 sites, Austria, Australia, and Chile, 30 patients. The inclusion criteria are important. Patients with chronic bronchitis, FEV1 between 30 and 100%. So it doesn't have to be a severe obstruction. Yeah? We have patients with at least 10 pack years. A little bit of smoking has to be there to have chronic bronchitis. And important, St. George, more than 25 points, and CAT score more than 10 points. And as I told you, in CAT score, the first 2 questions more than 7 points. Similar inclusion criteria for all other studies. As you see here in the first one, most of the patients were Gold 2, and a few 30% Gold 3, no Gold 4 patients, and a few with Gold 1. RV doesn't have to be increased. Here it's about 140%, but it's not the hyperinflation that we are interested in. And emphysema score really low, 8%, not severe emphysema patients. Safety comes first, and these are the severe adverse events in 30 patients for procedure-related severe adverse events, all of them resolving without sequelae. So in the beginning, it looks like a safe treatment. You see in the treatment recovery period, we have 3 of 4 severe adverse events happening in the first days after the procedure. And this makes sense because we irritate the bronchi. They have these patients, we irritate them with the energy, and then most of them have a severe COPD exacerbation, experience 1 after the treatment. Quality of life with St. George and CAT score, significant improvement through 6 and then 12 months for these patients. And also the goblet cell hyperplasia score after 3 months in the biopsies, having almost a 40% mean reduction. This was a significant result. This means this works, goblet cells disappear, and we have the normal, not at all, not that much anymore, goblet cells. Going to the European registry, we had like a little bit more, 53 patients here. Similar inclusion criteria. The only difference was that they were a little bit more hyperinflated, so RV 165%, plus minus 40. So you see criteria were similar with the first one. Safety, COPD exacerbation, again, in the recovery phase and then through the 6 months. Also pneumothorax, 2 cases, and thoracic pain. What we have to consider is that these patients with a lot of mucus and this obstruction through this mucus, they are exacerbating really oft. So I don't think this is a result that surprises us. Out of these 50 patients, 8 patients having a severe respiratory exacerbation, COPD exacerbation. Quality of life, the scores also here through the 6 months, the results really good. Improvement in St. George and CAT in both of them for the 6 months. Going to the USA study, the feasibility study, this has been a 5-year follow-up study. The 2 years results have already been published. We see here safety, primary outcome, secondary clinical benefit, the quality of life scores, and secondary outcome also the number of moderate and severe COPD exacerbations. So how can this treatment influence the severe exacerbation rate? And you see first the safety. We have 6 severe adverse events in 3 patients. Most of them happening in the first 12 months, 4 severe adverse events in 2 patients between first and second year. Most common, COPD exacerbation. So the similar results repeating. Looking at the CAT score and St. George, the first year in the red, you see significant improvement, losing a little bit the responder rate after the first year, between year 1 and 2. And this makes us ask, really, is this something, how long-term are the effects of the rheoplasty? Will be able to treat for the 3rd or 4th time in the future? We need the long-term data. We don't have them yet. And looking at the severe of the exacerbation, COPD exacerbation rate, you see baseline at about 1, moderate, and 0.1% severe the year before treatment, and looking 12 months after treatment at 0.7 and 0.05%, decreasing respectively, and also 12 months to 24 months, staying also much lower than the year before the treatment. So this is the important message. We can decrease the exacerbation rate with everything that comes with it. The last study, the randomized controlled study in 40 US centers and 10 centers in Canada and Europe, we are still waiting for these results. Really, 270 people, patients included. We are really exciting results coming. The last study, we know mucus causes also mucus plugging, of course, and this team of Kim investigated in the States, does this mucus plugging change after this treatment? And yes, it does, as expected. We had the mucus plugging score decreased by approximately 1 segment post-treatment in these patients. And of course, quality of life, CAT scores, and George all increased. The second treatment, the metered cryospray therapy for chronic bronchitis, completely method. So we had pulsed electrical fields with rheoplasty. Here we have small metered doses which cause flash freezing. We have minus 196 degrees in the mucosa, and we use liquid nitrogen to freeze the epithelium. Our goal, again, similar with rheoplasty, cryoablate the abnormal epithelium and then causing non-necrosing death of these cells, preserving the extracellular structure and giving the chance to normal, healthy goblet cells then to re-epithelize and repopulate and creating a normal epithelium. Reduce the chronic inflammation is a goal, and the associated, of course, airway obstruction. And you see we freeze here, but we don't go that deep. We don't go as deep as cartilage. We stay until the submucosa. And the re-epithelialization of the mucosa has been shown within 48 hours after the treatment, and also up to more than 3 months sustained. It's only under clinical investigation. It's not widely now abroad available. Here we have 3 treatments, like the thermoplasty for asthma patients. We have the right lower lobe first, then the second bronchoscopy for the left lower lobe, and the third one for both upper lobes. And we omit the middle lobe, exactly like in thermoplasty. And here is a nice video where you see the ice ring forming on the tip of the catheter, and it's the same principle. We want to cryoablate as much epithelium as possible, start from the periphery and move centrally up to the trachea. Ablate as much as possible, and you see thawing the ice ring, and then it's thawing, and then we move slowly proximately until we go back to the trachea. The studies that we have so far, the lobectomy safety and histology study, one in Europe and one in Canada, with the first one direct resection within 2 hours after treatment in the European study, and in Canada study 2 to 14 days after treatment. A total of 17 patients for both studies, and we have the multi-center prospective study in 35 patients. Looking at the results, 16 subjects, primary endpoint, the device-related severe adverse event, and then the post-procedure safety, of course, and secondary endpoint here, the histology, is the treat and resect study. And what we have the primary endpoints were met in this, and we do have the histological evidence of the cryoablation with non-scarring healed tissue in the late resection group. The prospective single-arm study from the UK, Netherlands, and Canada, we have 35 patients here, feasibility, efficacy, and safety study. And you see in all quality of life questionnaires, significant improvement 6 months and 12 months after the treatment, especially CAT score, as you see, the Leicester cough questionnaire, also up to 9 months, significant improvement. And looking to the safety, we had adverse events. All of the patients had experienced one adverse event in the most of them COPD exacerbations, and 70% of the patients had severe adverse event, all of them resolving without sequelae in these cases, no pneumothoraxes. So it looks like it's, again, safe procedure, efficient procedure, long-term results are pending. We have here the SAM control trial from UK, 1-to-1 randomized trial. We, again, looking at the quality of life, showing between the SAM arm and the treatment arm a significant improvement in all quality of life questionnaires, and the crossover treatment showing similar results after 6 months, a significant difference. The open questions, and this is the last slide, we need long-term data. So are we going to do this once and finish, or do we have to repeat the treatment? How long do we have a benefit from this treatment? Could we add it on to patients who we want eventually to treat with valves because they are also hyperinflated? Can we combine those two? These are the questions that we have to answer in the future. So thank you very much for your attention.
Thank you so much, Dr. Constantina. We now move towards the next lecture, Update of Airway Bypass Procedures by Dr. Felix Hirth. May I remind the audience that since it's 1 o'clock and all of us have worked up an appetite, there is a working lunch. Those of you who wish to proceed may grab your plates and come back to the hall, but the sessions will continue. Thank you.
Yeah, just sum up the morning, a new old, especially produced for my good friend Pallav Shah, because normally when he talks about lung volume reduction, he always came back with the same story. This is the best technique he ever have had in his hand. So airway bypass doesn't work. So my conflict doesn't change until yesterday. Nobody contacted me. Sorry for that. So this is what we have when you go to the exhibition halls. We have a lot of pharma therapy for our patients, but that's not really something new. So therefore, the decision came up that we need lung volume reduction procedures, especially for those emphysema patients who do not really have a good survival curve. When you compare that to the morning lectures about immunotherapy in lung cancer, the survival rate of such an emphysema patient is nowadays completely comparable to a lung cancer patients. Lung volume reduction came in, the surgeon started that, and then we have had the valves, the foam, the glue, the coils, and whatever technologies, but all those technologies have some limitations. For the fissure, for the valves, knowing that we have to look for the fissures, maybe we can glue them, we don't know that. The coils around since 2008, the patient criteria are still under debate. It isn't approved, it isn't reimbursed worldwide, and STEAM is limited to upper low predominant patients. So therefore, all the techniques we have access to have some limitations. But there have been publications in the early 2000s group that they demonstrated that when you created extra holes in the central airways, that you can get rid of the trapped air, and then they came up with the idea to create those extra airways somewhere in the central airways and get rid of the hyperinflation, make the lungs smaller again, and by making the lungs smaller again, you can improve the breathing mechanics and the patient can exercise more. There are nice movies, you can see them when you get access to the journal, how they really have used it in explanted lungs from lung transplanted patients, and when you in and expire them on the machine, and when you put the bypass system in, you really were able to see how the lung really is losing their volume by the extra airways. And that technology was then developed in the animal phase and then moved to the human phase, and this has been the airway bypass procedures trials have been done in the early 2000s. You went in with a Doppler, you looked for the vessels. When you have seen the vessel-free area, you stick in a TBNA needle followed by a balloon, and by the balloon dilatation, you inserted that little device which created the outflow of the patient. The technology was brought in by BRONCHUS at that time. They started after the first in human trials. They did a randomized control trial, 350 patients, and Palaf published the data after that, and he also published the problem. So all the patients which we have treated in that trial have shown dramatic effect directly after the procedure, but within 1 week the effect was gone because the device was covered by mucus, by secretion, and the body covered that hole and closed that hole quite quickly. This is why the patient only having had a very rapid response, but not a durable response. And this is the paper Palaf published in The Lancet in 2011. You see the peak directly after the procedure, but then latest at 1 month, the patient lost all the benefits and the technique disappeared. But at least the proof of principle was shown, and this was the reason why we tried to modify and change the device a little bit. So we developed a larger device, we changed the stent a little bit, and even the target site selection have been changed in the last 20 years because nowadays we have better access to quantitative CT analysis. So therefore we also changed a little bit the patient selections. And then we decided we have to go into the first in human trial again. It was a single center prospective trial. There we have safety endpoints as it is a first in human trial, as well we have the secondary endpoints where we measure the lung function, the quality of life of the patient, and the 6-minute walk test, and you see the key inclusion and the exclusion criteria, which and copy from more or less all other lung volume reduction trials. What we're really looking for, we looked for heterogeneous patients, and we really looked to patients who really have a lot of hyperinflation. So the residual volume minimum threshold was 225% predicted. This is higher like in most other trials. And we did the QCT. We use QCT, first of all, to decide where to put the device in, and secondly, to look for the larger vessels to avoid puncturing of bigger vessels. So again, these are data from these are the animal phase where we put the devices in, and have seen in the animal the patency is still there after a couple of months, and having those animals, then we move to the human data, and this is the procedure, how we're doing the procedure. We put in the site where we want to place the device, we're putting a safety balloon, then we're looking to the point of entry, we're doing a classical TBNA when there is no blood in the syringe when you suck on. We go in with a balloon, which we then putting into a hole, we doing the balloon dilatation, and you see the extra hole we created after that balloon dilatation, and then we inserting the device. In the trial we only inserted 1 device per patient, so we treated only 1 side because the issue was safety and patency of the device, not efficacy in the first in human device. So we lost one of our patients because the septic shock weeks after the implantation, and she denied to be transferred to a hospital. So the SAE committee decided it's not device related, and the efficacy and that's have been the only safety issue we have seen. In that trial, we have the data. These are the data, the 3 months data, the 6 months data be collecting at the moment. The last patient has the visit, just have had the visit, and we have to see the data. And what we were able to show that the residual volume went down by nearly 2 liters, persistent for at least 3 months, and 3 out of 4 have a persistent signal even after 6 months. CAT score went down by 8 points, and the 6-minute walk test went up by 150 meters of the patient. So it seems that the patient really have persistent outflow of that artificial created airways. And I just showed a video of the last patients where he got the surveillance bronchoscopy 6 months after the implantation, just taken last week. You see the device, it's placed in the upper lobe, and when you clean, you see the bubbling from the depths, and when you suck out the bubbling, then you see still the emphysematic tissue in the back, and you see still the device open, no mucus clotting, no granulation tissue, no scarring. So it seems that the bigger and stays open at least for 6 months. And now we collecting the money for the next phase of the trial, or we already have the money for the next phase of trial, and the protocols are already submitted to the ethics committees for a larger series of patients. So summarizing my talk about airway bypass, I think it was shown by Pallav and his group that it works, but unfortunately we haven't had a persistent signal. But with the new device, a little bit redesigned, a little bit other patient selection, it seems that at 3 months and hopefully also at 6 months, the device is still open. Now we need more patients and more data to really get an idea if we can trust on that technology. But the first signal is there that we will have airway bypass technology back and have an additional technology for our patient suffering on severe emphysema. Thanks a lot for your attention.
Thank you, Dr. Felix, for an excellent lecture. We now move on to our next session, that is on peripheral bronchoscopy. I would like to invite Dr. Joseph Cicina for his lecture on defining diagnostic yield in bronchoscopy. Welcome, sir.
That was a long walk. Hello. Not everybody's back from lunch yet, which is too bad because this is a good talk. It's one of my, thank you. It's one of my better ones. We'll see. I'll add a little flavor. So, I constantly argue with my friends who have Android phones. You know, like, why do you have an Android phone? You should have an iPhone. iPhones are the best phones. And then the Android phone people always argue with me. So there's always this argument over which phone is better. But if you really kind of lift up the hood and talk about the phones themselves, it's easy to compare some aspects of the phones, right? You could compare storage, because that's inherent to the phones. You could compare their cameras. You know, how many pixels does this have versus this have? What kind of imaging does this have? This is the other. But there are other things that are inherent to the phones there are other things that are not inherent to the phones that might make comparing them difficult. For instance, maybe one phone has a very good service provider who maybe provides LTE, whereas the other phone may have, 3G, and then they don't perform as well. So there's certain things about a technology that's inherent to technology that's easy to compare, but there's other things, confounders, that I think you have to be aware of. So when you're comparing two technologies, you're actually comparing two technologies. So when you're comparing things and you're using the data, which is what we do, to compare things, you always have to be skeptical of that data. Performance is only as good as the integrity of the data. You know, we have this term, garbage in, garbage out. When you interpret the data, you have integrity. How are the endpoints defined? Are there hidden confounders that are behind the scenes that you don't really see in the study that you should be looking for to try to pick up? And did the data reflect real-world conditions, you know, the conditions that you have in your own individual practice? Any procedure with diagnostic intent, right, is contingent on three things. The diagnostic test, the performance of that diagnostic test itself, the technology performance, and also the operator performance. So for instance, if you're talking about a robot, right, there's the robotic performance, but there's also the performance of the person doing the robot. And then after that robotic bronchoscopy, you have so many other things that come into play before you get to your procedural outcome. Now, unfortunately or fortunately, procedural outcome, for better or for worse, for us, is diagnostic yield. It's been diagnostic yield forever. So, taking these and applying it to diagnostic yield, I have a technology that I'm going to try to access a peripheral lung nodule with. That technology has its own performance. I have my own performance using that technology. I do the biopsy, and then many other things come into play before diagnostic yield comes out. So that diagnostic yield, right, is the number of results with the desired outcome over the total number of tested. But it's that desired outcome, that's the question mark. What do we define as that desired outcome? So when you're comparing outcomes, you want to make sure not to compare apples with oranges. You want to compare apples with apples. There are things that are very clear, right, when you look at a study. Biopsy tools, CT body divergence, you could see these things, they're listed, they're very obvious, but there's some things that are hidden behind the scenes that may not be reported. Not so obvious. The expertise of your pathologist, how you define the outcomes of that study, the prevalence of cancer in your cohort, and actually the expertise of the operator doing the procedure itself, right? If the operator isn't very experienced versus the operator being experienced, it's going to significantly affect your yield. So why define diagnostic yield? Why are we spending so much time on this lately? Well, multiple studies report many different types of outcomes. The most commonly used outcome being diagnostic accuracy or diagnostic yield. Like I said before, this is what we do. We compare studies by diagnostic yield in this space. Application of what qualifies, however, as a diagnostic yield is very variable across the studies, and I'm going to show you this in a little bit. These variable definitions of diagnostic yield influence the interpretation of the study results, and it really limits the ability to compare one study with another study. And these variable definitions primarily differ in their approach to categorization of cases that are negative, right? Positive's easy, negatives, how do we define those? And we'll talk about that. So this group got together, a group of the minds, the best minds of the best minds, and they decided this is what we feel diagnostic yield should be. And they listed their reasons for that, as all of the reasons we just stated, that a major issue in diagnostic bronch literature relates to the variable reporting of diagnostic yield, right? Everybody's using different definitions. And they made this statement to propose a research framework to standardize the evaluation of techniques for peripheral lung lesions and ultimately provide a level of evidence required for successful and rational integration of novel technologies in clinical practice. Basically saying, if you're going to publish a paper in our journals, these are the rules we are going to apply to you. These are the rules we want you to follow. And specifically, they proposed a very robust consensus definition of diagnostic yield, and they discussed potential study designs for evaluation of novel bronchoscopy technology, various stages of introduction. Again, they're trying to define diagnostic yield. However, the subtext here is there's a lot of new technology coming out, and we're going to tell you how to define diagnostic yield or define ways to compare those technologies, because we don't like the way you guys are doing it right now. So let's talk about handling definitions of yield, right? Diagnostic yield clearly is true positives versus true negatives over total cases. True positives, in our sense here, specifically with that definition, true positives always refer to a malignant diagnosis. The entire diagnostic yield is based around malignant disease. A diagnosed malignancy always considered a true positive. Negatives can be categorized in several different ways, and how you categorize these impacts the type of diagnostic yield definition. A specific benign diagnosis, a non-specific benign diagnosis, and a non-diagnostic result, and we'll go through this. How strict we are, again, with defining these negatives is going to define what type of yield you use. So 3 diagnostic categories were proposed: specific malignant diseases, which we already talked about, specific benign diseases, you could see the list here, and then non-diagnostic test results. You could see the examples that they gave on the 3rd column. This, very easy. This, specific benign diagnoses, obviously hamartomas, benign tumors, organizing pneumonia, fungal disease, where you actually have the fungus, mycobacterial disease, where it grows in culture, or you see the mycobacteria on the stain, and granulomatous inflammation. Non-diagnostic test results include these, and we'll talk about the specifics of these in just a second. So strict yield is our outcomes based on the results at the time of the index bronchoscopy. So you do the bronchoscopy, you get a result, and that's what contributes to the strict yield definition. Only procedures with specific benign diagnoses at index are considered true negatives. Obviously, if you find malignant disease, it's a true positive. Cases with a non-specific diagnosis or a non-diagnostic result are not considered true negatives, so therefore, in this case, diagnostic yields calculated as true positives, specific benign diagnoses divided by total procedures. Intermediate allows for inclusion of follow-up data for cases, but only those with a non-specific finding at bronchoscopy. Okay? So non-specific findings are assessed longitudinally, either with surgery or follow-up radiography. However, cases in which a definitive diagnosis is not established because of a lack of follow-up are considered non-diagnostic. So if you never did the follow-up, you're non-diagnostic. And here, diagnostic yield is calculated as true positives, specific benign disease, non-specific true negatives divided by total procedures. The liberal classification is exactly what it is. It allows for inclusion of all follow-up data on all cases that are negative for malignancy at index bronchoscopy. So that is any kind of specific benign, non-specific benign, or even non-diagnostic findings can be considered diagnostic if the following is true. That is, you have a biopsy that confirms non-malignant disease, or you have radiographic follow-up where the nodule shrinks. The problem with this is that you could completely miss the nodule during your procedure. Let's just say I'm doing a bronchoscopy on somebody with a histone that's in the right upper lobe, and for whatever reason, I biopsied the right middle lobe. It happens. Not to me, but it happens. And let's just say that nodule goes away over 6 months, because that's what histoplasmosis does. According to liberal diagnosis, you had a diagnostic yield, and that doesn't really make sense. So this is a summary of what we just said. And here's the important thing. In this statement, they went back and looked at the literature, at least back when they wrote this in 2022, and they said a recent systematic review of on the diagnostic performance of NAV-bronch in peripheral lung nodules include 95 studies. A quarter used strict definition, 32% in intermediate, and a quarter used a very liberal definition. In 16% of the cases, they didn't even list a definition of what their yield was. So this is a problem. It's a problem when you're trying to compare studies, especially now when you have all these new technologies coming out, all competing with each other, each saying that I'm as good as you, I'm better than you. This is how diagnostic yield could really get dicey. Okay? This is a hypothetical cohort where they included a bunch of malignant nodules, a bunch of specific benign nodules, a bunch of non-specifics and non-diagnostics. And you could see that depending on how you apply your definition of diagnostic yield, you could have a diagnostic yield as high as 89% and as low as 66%. A huge swing in diagnostic yield depending on the type of filter that you use. And here we are. Here's a perfect example. The navigation. One of the most historic trials in our space, right? Done on old superdimension. They reported a 12-month yield of 73%. It was a very liberal definition of yield. If you apply a conservative yield filter, their yield suddenly drops to 53%. Again, a coin flip. They spent $2,000 on a procedure that they could have easily handled with 1 penny. You have cancer. That one, think about it. Yeah, you laugh, but it's the coin flip, right? Okay, so let's just focus a little bit on specific, non-specific, non-diagnostic test results. Look at these atypical cells. Okay, I give you that, but acute inflammation. I mean, I think if I do a bronchoscopy on something that has acute inflammation, even if I didn't find a bug, I would kind of think that I'm lesional. Acute is something that doesn't belong there. Necrosis, again, something else that doesn't belong there. However, the authors decided to make these non-diagnostic because they say that you could still see this in malignant disease, therefore this could be misleading. We're going to consider it non-diagnostic. So again, some people feel that's overly strict, but this is why they did it. And they gave us a couple out clauses. They gave us suggestions. Thank you, authors, for giving us those suggestions. They said, first, you could do longitudinal follow-up studies, and that could be used to express diagnostic accuracy. Well, or you could do studies to determine the impact of these non-diagnostic test results, such as acute inflammation, to see if they ever have any impact down the road. Okay, well, thank you for that. Maybe we'll do that. This is a study that came out of Vanderbilt. And what they did is they looked at diagnostic yield on index procedure, okay? And then they had 2 years of follow-up, so diagnostic accuracy. And they wanted to see what the difference was between the yield and the accuracy. Was that, delta significant? And you could see the y-axis here, right, is the discrepancy between the yield and the accuracy. And you can see when they applied conservative yields, very strict yields, yield definitions, that the diagnostic accuracy didn't really change much. But again, once you start getting less and less strict with your diagnostic yields, your discrepancy is super, super high. Now, I think you might want to say, well, this is great, but I think this kind of creates more questions than answers. And for these reasons. First of all, a true positive comes from the point of view of only malignancy, right? I get asked to do biopsies for patients that are clearly not malignant, but I have patients who have rheumatologic lung disease on immunosuppressants. They develop a nodule where infection is part of this differential, a large part of the differential. If I do a biopsy, I don't find malignant cells. Does that mean I have a non-diagnostic yield? Okay, and is this really the only patient-centered outcome that we have? And we're going to talk about that a little bit later. The assumption that all nodules have the same malignant potential is inaccurate in many instances. And we talked a little bit about this during my talk yesterday. Size, cancer prevalence, geographic locations all play a very significant role. If you do a clinical trial in Cleveland, Ohio, where we have a lot of fungal disease, and try to compare that to a clinical trial done in New York City where they have no fungal disease, where their cancer prevalence is high, my cancer prevalence is relatively lower. How do you compare those two outcomes? We showed this yesterday. This is the impact of cancer prevalence on diagnostic. Use a very strict, that's the green line above, use a very strict definition. It doesn't impact it too much. But the more liberal you get, the more your cancer prevalence really impacts your diagnostic yield. Nodule size also really impacts your diagnostic yield. Because, look, if you have two sets of nodules, ones that are over 20 millimeters in size versus ones, say, under 15, very significant impacts on probability of malignant disease. Now, my Galaxy trial that we presented at CHEST, our average nodule size was 12 millimeters. The first Deckel ion trial by Deckel at Sloan Kettering, their average nodule size was around 20 millimeters. How do you compare those two diagnostic yields when the pretest probability of malignancy was so different in the two groups? I think that's a problem. Diagnostic yield is also compounded by factors unrelated to the technology. We call this Kyle coined this term, the Tiger Woods clubs paradox. So just because I use Tiger Woods golf clubs doesn't mean I'm going to shoot a 66, okay? I'm still going to shoot 110, maybe 120. So just because you have the best technology, if the operator who's using it is not very good and not very skilled, that technology is going to have a poor outcome. And we don't really assess for that, right, in clinical trials. Nobody says, hey, we did a clinical trial on 300 nodule patients, and the operator was somebody who's been doing this for 20 years. Nobody says that. Nobody says, hey, I've been doing this for 3, and I had a bunch of fellows doing it. So these are things that are never written in the clinical trial, but it could be quite impactful. And what do we do about this, right? What do we do about that 75% of studies that didn't use strict definitions in the past? Do we just throw them away? Do we go back and recalculate all their diagnostic yields and republish them? I mean, I think this is a big problem. So I think it was nice that they created these definitions of strict diagnostic yield and say this is how we're going to move forward, but they didn't give us any guidance on how we mitigate what happened in the past. So what are the alternatives? Well, certainly diagnostic accuracy is one way of looking at things, right? And the accuracy is the ability, measures the ability of a test to detect a condition, right? When it's present, to rule out a condition when it's absent, right? It's very basic. So the problem with diagnostic accuracy is that it could only be determined after a follow-up period, which could really delay reporting, especially on new devices. This really impacts what I was talking about yesterday with how do we get new devices to the market? Do we wait 3 years for diagnostic accuracy numbers to be published, right, or to be found? And I think there's less clinical utility. This is less patient-centric, right? A patient comes in for a procedure. They want to know, like, a week later, do I have cancer or not? Did you get a diagnosis? They don't want to necessarily wait 6 and 12 months. So again, when you report this, you have to kind of put it into the perspective of your clinical practice. What about tool and lesion? We talked a little bit about this in some of my other talks as well. I think tool and lesion is the best gauge of technology performance if you have the ability to measure it. It accurately reflects exactly what the technology was supposed to do. It got your scope or your catheter with a biopsy tool into your lesion. Everything else after that has nothing to do with your technology. But again, it's not exactly pragmatic information for the referring doc or the patient. Hey, Mrs. Jones, lesion, but I don't have a diagnosis. I mean, so I feel good that I did good, but she feels terrible because she still has no idea what's going on. Yield, we talked about yield, and it's a product of several factors in addition to the technology performance that is just, there's confounders here that we just can't measure. The tool performance, the strength of your cytologist, a huge issue in the United States right now is that 80% of people have lousy cytologists, if they have cytologists or pathologists at all. There's technologies being developed to substitute for them. The quality of the tissue that you get depending on the type of biopsy tool that you use. Are you doing cryobiopsies? Are you doing needles? Are you doing brushes? We already talked about the prevalence of cancer and benign disease. I think the tool and lesion is certainly the best gauge of diagnostic, of technology performance. It accurately reflects exactly what the technology is supposed to do. So look, if we're in the business of comparing technologies, if that's what the authors want to do, which is what they kind of hinted at, well then maybe they should use more relevant outcomes that are specific for the technology. Again, we talked about the cons of doing this just earlier. And look, this tool and lesion equal yield, and Mike Pritchard talked about this before. There's always this 10 to 20% difference between having a tool and lesion and actually having a diagnostic yield. Does that mean all of those cases were benign diseases that we wouldn't have been able to diagnose anyway? Or is that just because of all the confounders that exist? Nobody knows. So where do we go from here? So I think right now we're stuck with the strict definition of diagnostic yield. We're stuck because it's been dictated to us, at least for publications. But diagnostic yield, again, it struggles to compare technologies when so many of these others exist. All these things that we just can't control, and the only thing that we control is how we report. So what are the solutions? Well, I think we have an opportunity to be more pragmatic with assessments of diagnostic accuracy, but again, this takes time. Sometimes up to a year. It could really delay, our publications. Should we be looking more at tool and lesion, like I mentioned? But can tool and lesion actually be a predictor of outcome. So let's just say I give a radiographic proof that my tool, my biopsy tool, was in the lesion. I got lesional tissue. So what if I got a non-specific diagnosis? How often does that turn into cancer? Because that's what we really care about, right? We care about a false negative for cancer. So does tool and lesion actually have a very high negative predictive value? I think these studies are easy to do, and we should do them. So with that, I'll leave it there. I'll take any questions if you have it. Otherwise, we'll keep moving forward.
Thank you, sir. It was extremely fantastic talk. Thank you.
There's a question here if we want to take one now.
Just a second.
I don't know if Gus needs a microphone. There we go.
Yeah, it's just a really simple question, Joe. Thank you for a great presentation.
But I can't hear on the microphone. Come closer. Yeah, I can hear you now. Yeah, so the question was what I referred to earlier, especially in the U.S. right now. Maybe not so much here, but maybe here in the future. In the U.S. right now, everybody is concerned better. Everybody argues on our chat groups. My robot is better than your robot. My Monarch is better than your Ion. My Ion is better than, I mean, everything. Amir's going to come up and talk about thin scopes. He's going to say, you don't need robots, you just need my thin scope. How do we mitigate this, right? And I think that diagnostic yield is not a great way. I think that if you have imaging, and a lot of us do, I think what we're charged with that technology is to use that technology to get a biopsy tool at the lesion. And that's it, right? That's it. That's what radiologists do, by the way. They put a needle into somebody's chest under CT guidance, and they do a biopsy once they know it's in the nodule. And everybody's happy with that. So, Gus, I think the only way of doing it is to assess what the technology was intended to do, which is get you to a nodule and do a biopsy. After that, everything else is a confounder to me. Okay.
Thank you, sir. I'd now like to invite Dr. Amir Abrovich for his lecture on thin scopes and peripheral nodules. We welcome you, sir.
Okay, hello everybody, and thank you for inviting me. I'm going to talk about slim and ultra-slim scope for peripheral nodule diagnosis. This is my conflict of interest. So, what regarding scope? We are all used to the therapeutic 6 millimeter scope. We can get maybe up to the lobar and maybe segmental bronchi. We all know the diagnostic 5 millimeter scope. We can get out maybe to the 4, maybe to the 5th, 6th generation, but not further. And then came the thin scopes, the Olympus BFP 190, which has a 4 millimeter outer diameter and 2 millimeter working channel. And this scope can go up to maybe 7, 8 generation. And then the Olympus BFMP 190, which has a 3 millimeter outer diameter and 1.7 millimeter working channel. This scope can actually go all the way to the pleura or all the way to the peripheral nodule, as you will see next. Fuji also came with a 4 millimeter scope, quite comparable in specs to the Olympus BFP 190. I have no experience with this scope, but it should be the same. We had the XP 190 2.8 millimeter outer diameter scope for a while, but this scope has a 1.2 millimeter working channel, which is not enough for our working tools, and especially for the rebus with radial ultrasound that I think is a must for peripheral navigation. So now we have a new disposable kits on the block. I was waiting for those to come up since COVID and the explosion of disposable scopes, and the first one who came up was the Vitin IP. I have some experience with this scope. The specs of the scope are similar to the BFP 190. You can even lock the lever and spin the neck of the bronchoscope. So you have no fear of pushing tools through tight U-turns, because you can ruin the scope. You just throw it afterwards. You can lock the lever. But in my personal experience, this scope is not as good as the reusable scopes. If you have tight turns, especially in the upper lobes, it's maybe difficult to insert the scope into the relevant airway. It can fold upon itself. But in certain anatomic conditions, in certain anatomic locations, you can use that, and it's good to have in your toolbox. Recently, AMBO also came with a disposable scope with similar specs. I have no experience with this one. Now, if we compare thin scopes to robotic scopes, which are also used to navigate the periphery, the Auris distal scope and the Galaxy NOAA has the same specs as the Olympus BFP 190, which is its outer diameter around 4 millimeter and working channel around 2 millimeter. And then if we go to the thinner scopes, we have the Olympus BFP 190, which has a 3 millimeter outer diameter. And remember that the thinnest robotic scope that we have has an outer diameter of 3.5. But the difference between them is that with the Ion, you don't have peripheral vision. That, in my vision, is very important for navigation. If you want to put your tools inside the Ion, you have to pull your car. You lose distal vision. With the Olympus BFP 190, you have vision all along your bronchoscopy, distal vision. And what tools can we use with the thin scopes? We can use all the tools. We can use the PeriView 21 G needle. We can use the dedicated Olympus forceps, and of course we can use both cryoprobes with the 4 millimeter scope, and we can use the 1.1 with the 3 millimeter scope. Now, if we will compare the different platforms from other aspects regarding price. If you compare it to robotic scope and electromagnetic navigation like Illumisight, the price is very low regarding the other platforms. And even the disposable price, if you use a reusable thin scope, you just pay for your sampling tools. But in other platforms, the cost can get up to $2,000 per patient, which is a lot if you have a high volume, if you are a volume center. Tip flexion, very important. You can flex the tip of your scope in the periphery as you can do with the robots. If you use electromagnetic catheter-based navigation, you cannot control the tip of your catheter. Navigation, you have, of course, you don't have navigation in slim scopes. I will talk about it in a minute. You have it in all the other platforms. Peripheral vision, very important. You have no peripheral vision with catheter-based navigation. You have it with Monarch Galaxy alternating, but you have it all along the way with thin scopes. Bleeding control, even if you go after peripheral nodules, I think everyone who's done enough procedures like that encountered bleeding which is more than mild. So if you are in with a reusable slim scope, you can immediately try it and control it and wedge. With the other platforms, I guess you have to pull the scope out and put in another regular scope in, which takes time. Haptics, very important. You don't have it with the robotics and not with the catheter-based navigation, but you have it with the slim and ultra-slim scope. Regarding stability, stability is very important, and you can get that with slim scopes using various stabilization arms, like I use the Mediflex one, and it's very stable. So regarding the difference in reach between slim and ultra slim scope, there is a study from Oki et al., and he was comparing the reach of the ultra thin and thin scopes, and he found that the thin scopes can go to a median fifth versus median fourth. The ultra thin scopes can go to median fifth versus the fourth generation with the thin scopes. It means a difference of one airway generation, which is not a lot, but our experience is quite different. Our experience that you can go more than one airway generation. You can go two to three airway generation further. And this is because in this study of Oki, he was using conscious sedation. So I think part of the airway were collapsed. We use general anesthesia with a special navigation ventilation protocol for every navigation. So this is why probably we can go further. You can see here at the bottom the difference you can in reaching this right upper lobe nodule between the 4 mm scope on the right and the 3 mm scope, which can go much further and reach the nodule, and you can even see the nodule with your eyes and take a biopsy. Now, this study was actually comparing the reach of the Monarch robotic bronchoscope with the Olympus BFT 190, and the finding is, and they were trying to get into LB1, okay, in the upper lobes, and they found out that the robotic scope can go to a mean generation count of 8 versus 4.5 with the BFP 190. But if you just read this paper, the way they were pushing the BFP 190 is not by actual navigation or under vision. They were just pushing a stellate into the right upper lobe, and then on that stellate they were pushing the BFP 190 until they could not push it anymore. So they were not really navigating the airway under vision. And if you look at the upper right of the screen, the upper row is where where the BFP 190 could go, and the lower row is where the bronchoscope. You can see the difference, but if I will take my cases from thin and ultra-thin scopes to similar anatomic location, you can see that if you actually navigate the scope, you can get much further, and the images below are quite similar to the images of the Monarch. So this is for this you have to actually navigate under under vision, and this is an example of this. You can see that RB6 nodule on the right, and you can see the video when you are actually using the MP 190, and you can count the number of airways that you are passing. This is the main bronchi, bronchus intermedius, RB6, and you can count the number of airway that you can go, and you actually see, here you see it again, you can actually see the nodule and sample it. It turned to be adenocarcinoma. So a lot of what we used to call TBB under vision becomes endobronchial biopsies. And I'm sure that everyone will agree that it doesn't matter what platform you use. When you integrate it with advanced intraprocedural imaging and get augmented fluoroscopy and tool-in lesion imaging, you increase your yield by 10 to 20%, and this is the same with thin scopes. So we can integrate thin scopes with cone beam CT from my institute. So you can see here this Cheerios-like GGO. On the upper row, you can see the virtual image. This is the same workflow as you do with robot and quantum CT. And on the right, upper right, you can see tool and lesion. The same with the lesion on the lower row. And this is how it's done. I'm sure that you will all agree that this target here is a robotic target. Everyone probably will use in the US a robot to get there, but you can use cone-beam CT and thin scopes. This is the virtual nodule after marking it with cone-beam CT segmentation. Once you get there, you can confirm by turning the C-arm that you are not superimposed on the lesion, but you're actually in the lesion. And I think that even though we have that, radial ultrasound is essential because except CT to body divergence, you also have intraprocedural divergence, and this is because during the procedure the nodule position is changing all the time. So instead of just chasing the nodule, you can just confirm it with radial EBS that you are in place. This is a tool and lesion done with, this is not a robotic scope, this is a thin scope. And you can see the tool and lesion exactly like you would have with robotic bronchoscopy. Of course, not everyone gets access to cone-beam CT, so I use cone-beam CT as well in lung vision, and you can have the same products in lung vision. And this is an example of a lesion adjacent to an aortic arch. You have very tight turns there, and of course you don't want to sample the aortic arch or puncture it. So with lung vision, this is not a lecture about lung vision, but this is an example of what lung vision can do. I use lung vision exactly as I use cone-beam CT, the same workflow with thin scope. And here you can see how the thin scope's taking this tight turn. I think this is the MP130. And you can see the biopsy. This turned out to be adeno-CA. And you can see here the tool and lesion. I did that before lung vision had the AI tomo, so I don't have the axial view, but now you can have this in axial view exactly like in the cone-beam CT. And this is the sampling. How do I get there? You can use various virtual bronchoscopy platforms like LungPoint, or even now Lung Vision has a very good virtual bronchoscopy navigation, so you can use that. Or you can use the Kurimoto airway tracing. I think this is the next lecture, so you will hear about, from Dr. Ko about it a lot. What I use is mental navigation. So you have to train your brain by looking at the CT in MPR, multiplanar reconstruction, and high resolution slices of 1 millimeter, build a mental airway mapping, and this takes training. So I guess that if your first steps with a fellow, when you are a fellow in peripheral navigation, if they hand it, if you got the robot in your hand from the first steps, you probably will never develop it. But in other places, they train you to actually reconstruct the airway in 3 dimensions, and to actually vision what would be inside the airways by looking at the CT. And if you do this from the start of your fellowship, and then do a lot of navigation using mental navigation, then you will develop this way of doing things. So tips and tricks for peripheral reach: general anesthesia, navigation ventilation protocol. We use like 6 cc's per kilogram, PIP of 10 to 15. It depends if it's the upper or lower lung or lobes, or if the patient is obese. FiO2 lower than 50, and endotracheal tube of 8.5. You start navigation as soon as possible before atelectasis set in. And you can use lung recruitment maneuver. You can use both 3 and 4 millimeter scope. I always use both of them. If you have atelectasis, you can use gentle air injection to open the collapsed airway, like you see here in the two pictures on the right. And scope stiffness can be controlled inside the working channel. So you can actually move forward your scope on top of your tool to reach places that the scope will not go in itself. And this is my last few slides that shows the importance of peripheral navigation, of peripheral vision, because sometimes you can also see the etiology, not just the tumor itself. For example, this left upper lobe nodule on the left. Here you can see navigating with an MP using lung vision, augmented fluoroscopy. You can actually see the nodule and do an endobronchial biopsy. And on the example of the right, you can actually see no airway going to this tiny left upper lobe nodule, but when you get there with the MP scope, you can see multiple very tiny, maybe 1, maybe half millimeter airways. All of them are going to the same augmented nodule. But if you now use a radial ultrasound and stick it to, and push it to each one of them, only one of these holes produces the image that you see in the lower right of the picture. And then if you use your forceps to get into this same hole, then you get a diagnosis, and this was a squamous cell carcinoma. Another time, a nodule is not really a nodule, okay? Like this right lower lobe nodule, you get in, you find a space full of fluid. We could not guess it by CT by measuring the household unit. And once you get there and the fluids come out, then you lose your radial ultrasound. Repeat the CT, you see that this nodule actually disappears. And if you have peripheral navigation, peripheral vision, you know why. Another example of this right upper lobe PET positive nodule, when you get there, what you see is a very small carcinoid. This airway is maybe 3-4 millimeter in diameter, and this is a round carcinoid on a stalk. We took it out, and actually everything behind that was post-obstructive infection. So this is not really a nodule, although it's PET positive and very, very suspicious. And this is, I think, my last slide. This lady came to me with after with a lingular nodule, and she was about to be operated to get a lingulectomy, and she came for second opinion because they told her that this could not be navigated. So we navigated there with a thin scope, and we saw this nodule in our eyes, and we took a lot of cryobiopsies. Okay, this is an example that although you are using thin scopes, you can take a significant amount of material for all you want. This turned out to be an hamartoma, and we took, I think, all of it out. And of course, we didn't recommend any follow-up CT, but someone sent her to a follow-up CT, and you can see here that it disappeared completely. And this lady could easily gone through a VAT surgery for nothing. So this is my last slide. So to summary, slim and ultra slim scope is good option for peripheral pulmonary lesions sampling because of excellent peripheral reach, continuous vision, tip flexion and tool deflection correction, good selection of sampling tools, immediate bleeding management. It's relatively cheap and can be used with various navigation systems. It works great with advanced real-time imaging like digital tomography and cone beam CT, but it's not a plug and play. So you cannot just start doing navigation. You have to train yourself, and then you develop this capability of navigating to very small nodules in the periphery. Thank you, and thank you for inviting me.
Thank you, sir.
Any questions?
Any questions from the audience?
Thank you.
Thank you. We now move to our discussion on airway carcinoid tumors, and for this I would like to invite Dr. Spazio Popovic onto the stage. Thank you, sir.
First of all, I would like to thank Dr. Hari for inviting me in this conference. That's my second time in India, and every year it's getting better and better. First, carcinoid tumors are often subject to dispute between thoracic surgeons and interventional pulmonologists. So how can we, interventional pulmonologists, give our opinion, and how can our interventions help patients with carcinoid tumors? First of all, neuroendocrine tumors, as you know, are a very variable group of tumors, ranging from diffuse idiopathic neuroendocrine cell hyperplasia up to neuroendocrine small cell carcinoma. But in majority of cases, you can divide them into typical, atypical by histology, but that is not the only thing that is interesting about carcinoids. Clinical manifestations can also range from none to endoluminal obstruction symptoms and signs, and diagnosis may be delayed, as symptoms frequently mimic common respiratory diseases. Relapsing obstructive pneumonia with fever and chest pain, cough, hemoptysis, dyspnea, asthma-like manifestations, because these are in general very slow-growing tumors, and practically a lot of patients go unnoticed or asymptomatic, or they present with asthma-like symptoms. Asymptomatic lesions may be incidentally discovered by imaging procedures, which is above all CT, but CT is not really in all cases good for diagnosis of carcinoid tumors. Regarding other types of imaging, they are typically located in the large bronchi, most often in the right lung, middle lobe for some reasons. In about 30%, they have calcifications, isolated or diffuse calcifications, and in some cases, up to 40%, they can have peripheral position showing as round or oval homogeneous opacities. PET-CT, which we use to assess malignancy in other cases for carcinoids, is not really good, because it's due to low uptake of the fluorodeoxyglucose. So instead of that, gallium dotatate scan can show diagnostic accuracy more than 90%, and actually that scan can be used for non-invasive follow-up of patients after some intervention. Biopsy also has some considerations these tumors tend to bleed a lot, and if we do something during the biopsy, we can stop the bleeding or prevent it in some way. But really, in majority of cases, when you see that kind of intraluminal tumor, first urge is to recanalize the bronchus and to really to take the biopsy. And after all, patients, so the diagnostic procedure will be interventional at the same times. And one other thing, pathologists require a lot of tissue in diagnosis of carcinoids. So we usually put these two procedures into one. Endobronchial biopsy, some people use topical adrenaline to prevent bleeding, just pour. I prefer to use adrenaline via needle to inject it directly into the tumor. At the same time, you can take a core needle biopsy, or you can inject phenylephrine in the tumor and in some way prevent bleeding. EBUS-TBNA is another procedure that is mandatory in the case. Why? Because especially in cases of atypical carcinoid, you can never exclude lymph node involvement. Even on CT, lymph nodes cannot seem not to be enlarged. So the biopsy can be taken from these lymph nodes just to assess if are there any metastases or not. Radial probe is good, especially after the interventional pulmonology procedure, to assess the wall invasion. In this small study, actually, in 3 patients, while high-resolution CT only identified atelectasis, there was wall invasion. So we can use all the tools that we have to assess the lesion. What are the procedures for the therapy? For interventional pulmonology therapeutic procedures? Well, there are some factors we have to take into consideration. First, the tumor implantation, the base of the tumor, vascularization, the status of the airway beyond the tumor, localization of the tumor, and of course, the wall invasion. And in all cases, we have to practically mandatory to use combined approach. Combined approach means we can use rapid desobstruction techniques, hemoptysis control, and to treat the rest or the base of the tumor. Mechanical recanalization is the #1, but actually the best technique for resection is using loop or snare, prevents bleeding and removing the tumor at the same time. And with these procedures, we also have enough tissue for the diagnosis. Then the treatment of the rest or the base of the tumor, we can do either with argon plasma coagulation immediately to stop the bleeding or with cryotherapy. In long term, cryotherapy can be of use. You will see later why. In this case, we decided that after all careful consideration to do mechanical debulking of the tumor with rigid scope. And just a small reminder, these are do's and don'ts in rigid bronchoscopy, in mechanical debulking. So, appropriate size of the bronchoscope to confirm the location and extent of the obstruction, to assess the diameter of the base of the tumor, to use appropriate anesthesia, to use gentle and controlled soft maneuvers when using instruments to avoid damaging the airway, and of course to monitor patients' vital signs. Don'ts, #1 don't is do not attempt mechanical recanalization without proper training and experience in the procedure. If you and or your staff is not trained properly to do that, remember, these are slow-growing tumors. Our major consideration here is post-obstructive pneumonia and hemoptysis. If you can control that, good. If you don't try to debulk it, either debulk it or not. Then we proceeded with simply by freezing the tumor. This is cryoextraction and cryobiopsy practically at the same time. And we treated the base of the tumor with argon plasma coagulation. Post-procedure, looks better. It was typical carcinoid without lymph node involvement, which was checked by EBUS TBNA, and right upper lobectomy was performed in this patient. Sometimes, in a lot of cases, you can, especially if you are doing it in a palliative setting to prevent recurrence of the tumor, you can treat it with cryotherapy. These are the major things we have to consider during cryotherapy. Freeze-thaw cycles, but there is more to cryotherapy than just recanalization. Combining cryoablation with other cancer therapies actually may create a synergistic anti-cancer effect, greater than either monotherapy alone. Maybe it is not yet approved or tested on patients with carcinoid, but on other tumors it is. And another thing, it shows some immunomodulatory effect and potentiation also of combined immunotherapy and cryotherapy for tumors. So there is more with cryotherapy than just recanalization, than just controlling intraluminal tumor growth. Complications, of course, you have to take care. In 5% of the patients, don't do excessive cooling, hemoptysis. There is always tumor necrosis, and you have to always take into consideration that tumors will bleed after cryotherapy, not during. They will tend to bleed after cryotherapy, and after the intervention, mandatory are follow-up bronchoscopies with removal of necrotic debris. Okay, that is technical part. What about evidence? How good it is IP treatment of carcinoids? So, first of all, is it with curative intent? Is it with palliative intent? And or bridging to surgery? There are several studies on the fact, and I will just shortly analyze two major studies comparing surgery and interventional pulmonology procedure, but not directly, you will see. But one thing we have to think, there is one thing we have to always think about during IP treatment of carcinoids. It's so-called iceberg tip effect. Tip of the iceberg, that means that visible intraluminal part might just be a tiny fraction of tumor growing from deeper inside the tracheobronchial wall. So, prefer not to be so in the technical part, I can do it. Long term, how it's going to help the patient. And this study is all about that, about long-term follow-up after first bronchoscopic therapy in patients with bronchial carcinoids. So it showed that actually intrabronchial therapy is justifiable with excellent long-term outcome, made surgery unnecessary in 42% of the cases. We are now speaking about 150 cases. And iceberg phenomenon and metastatic potential in that group of patients were clinically insignificant. Another study from, actually, there were 125 patients and some predictors were analyzed. How good is actually, what are the independent predictors of the success of debulking? I mean, intraluminal therapy. Intraluminal disease and tumor diameter on CT scan were shown to be independent predictors for successful endobronchial treatment. And actually, patients with purely intraluminal carcinoid tumors with a diameter less than 20 millimeters on CT were good candidates for endobronchial treatment, regardless of histological grade, either typical or atypical carcinoids. So all patients in this study with a tumor diameter larger than 20 millimeters and or with nodal involvement Metastases were referred directly to surgery. And successful treatment was defined as absence of residual disease during the first 2-year follow-up with CT and bronchoscopy after endobronchial therapy. Complications, bleeding, bronchospasm, and really minor complications of the therapy. So, in short, what are the predictors of successful endobronchial therapy with curative intent in carcinoids? First, it has to be typical. Second, with exclusively endoluminal growth less than 2 centimeters in diameter, bronchoscopically visible distant margin of the tumor as in any interventional procedures, without involvement of the submucosa or extension to the surrounding parenchyma, absence of lymph node involvement, base attachment less than 1.2 square centimeters, volume less than 5 milliliters, and no suspected distant metastasis. What about follow-up? These patients, regardless of histology, has to be very closely followed. After 6 weeks bronchoscopy and contrast CT and that gallium scan I already mentioned, if it was not available prior to diagnosis, contrast CT and bronchoscopy after 6 months, annual follow-up chromogranin, mandatory as a biomarker for this tumor, and 10-year total follow-up with contrast CT, bronchoscopy, chromogranin, biomarker testing. What about atypical carcinoids? Atypical carcinoid, regardless, first, all these studies were much more about typical than atypical carcinoids. Endobronchial resection, I showed, was curative in 17% of atypical carcinoid compared to 51. In short, the surgical resection combined with systematic nodal dissection for patients with atypical carcinoid is a standard of care. Treatment based on the current evidence. So, but there are some biases, of course. In majority of studies, the local regional and distant recurrence rates were lower in endobronchial therapy-treated patients than in surgically treated patients. And this finding should be interpreted with caution because all patients with more extensive disease were automatically sent to surgery without endobronchial therapy, without interventional procedures. So, to surgery, typical carcinoid or a typical carcinoid larger than 20 millimeters, transbronchial invasion, metastatic disease, and unsuccessful endobronchial therapy. With palliative intent, much simpler. If endobronchial therapy cannot achieve radical management, it may offer, as we all know, benefits to the patient. Patients who are not candidates for surgery, to remove bronchial obstructions, patients with hemoptysis, with dyspnea, and due to their slow growing, it may take even years before a recurrence develops. So, and the other thing, after the resection, the things are more clear in the airway. Like precise definition of tumor borders, we can use NBI, we can use autofluorescence bronchoscopy, radial to assess the wall and lymph node status. It's, of course, easier to do in the airway, which is not obstructed by the tumor. And this is in short, the proposed algorithm of treatment of carcinoids. If it's typical and has all these characteristics, can be treated and closely followed up, and if it's a typical carcinoid, more than 2 centimeters in diameter, and if we do a lymph node assessment and lymph nodes are involved, patient can be referred and has to be referred for surgery. But I am for this always. We should always try first, not try, do first interventional procedure whenever possible and whenever we assess that it has benefit for the patient. I would like to invite you all to the European Congress of Bronchology and Interventional Pulmonology, which will take place in Lisbon from 8th to 10th of May. And thank you for your attention. Questions?
Thank you, sir. Next up, we move to a very intriguing lecture on cryobiopsy in the diagnosis of lymphoproliferative disorders, and it's my deep pleasure to announce Dr. Poletti to the stage.
Good very much to Ari and the organizer for this kind invitation. These are my conflict of interest. And this lecture is dedicated to Professor Santetura, who was the father of the modern hematology in Italy and one of my mentors. Lymphoproliferative disorders are complex, at least for two reasons. We have a very fast and significant advancement of knowledge as testified by two new WHO classification in a very short period of time, and because we are a sufficient quantity of biological material for sophisticated analysis is usually needed. The classification of lymphoproliferative disorders involving the lung is still complex, varying from benign hyperplastic disorders to atypical lymphoid hyperplasia, primary pulmonary lymphoid neoplasms, post-transplant, and secondary involvement by lymph node-based lymphoproliferative disorders. What we need to make a diagnosis of lymphoma or lymphoproliferative disease, we need, of course, morphologic evaluation, immunohistochemical study, but nowadays, a long list of other investigations, including cytogenetics, chromosomal microarray, FISH, NGS, PCR, and so on. We can acquire material in different ways, less invasive to more invasive approaches, starting from cytology to surgical lung biopsy. This is the new chapter, will be published soon in the third edition of ERS Handbook on Respiratory Medicine, and I thank Ari that provided with very interesting cases. And in this chapter you can have some idea about also the cytology of lymphoproliferative disorders in the lung, some rule of thumbs. An increase of polyclonal B-cell in BL fluid may suggest a diagnosis of follicular bronchiolitis or LIP. A CD4, significant CD4 cell lymphocytosis may be observed in high-grade B-cell lymphoma, so can mislead the diagnosis. Cytology, of course, may aid in the diagnosis, however, material may ultimately be insufficient for further investigations. This was a 39-year-old male with lung infiltrates and rapidly progressive respiratory failures, BL, had a huge lymphocytosis, mainly CD4 positive cells, but we will see later the diagnosis. This is a case of primary effusion lymphoma, pleural fluid. Of course, the cytology is very characteristic, but we need more information to have a final diagnosis. And this is a BL with atypical, but not so atypical lymphocytes, but with immune flow cytometry, you can document the monotypic expression of the final diagnosis could be, or could be suggested, final diagnosis of mold lymphoma. But let's start with atypical lymphoid hyperplasia, Castleman disease, and IgG4-related disease. Castleman disease is a complex entity or a group of entity, at least 4 disorders can share similar characteristic histopathological features, but have complete different pathogenetic mechanisms. We have the unifocal, monocentric, we have multisystemic Castleman disease, multicentric Castleman disease related to HHV infection, POEMS, or idiopathic TAFRO, or not otherwise specified. Unicentric Castleman disease is usually, nowadays, is considered a clonal neoplasm. So it's no longer a giant hyperplastic lymph node, usually is asymptomatic. And this was a case, a patient who had a big lymph node, PET positive. We performed EBUS-guided cryobiopsy. You can appreciate the lymph node parenchymal architecture, burnout germinal centers, follicular germinal centers, rich in follicular dendritic cells and with typical lollipop aspects. Multifocal Castleman disease is another entity, complete different entity. Its lung is perilymphatic, typically perilymphatic. This was a Nigerian 38-year-old male with fever of unknown origin, cough and nodules, centrilobular nodules, and the biopsy documented lymphocytic infiltrate and HHV positive cells, and the lymph nodes were positive for plasma cell variant of Castleman disease. Cryobiopsy, transbronchial cryobiopsy, has been reported to be useful in the final diagnosis of idiopathic multicentric Castleman disease. Here we have 4 cases compared to what was obtained by surgical lung biopsy by a Japanese group. And this disease can have some similarities with IgG4 related disease, more common. The lung involvement is more common, is a fibroinflammatory condition that can affect a variety of organs. It was identified as relapsing pancreatitis, but nowadays we can have also typical lung involvement. Lab test may be not characteristic. Interestingly, C-reactive protein is usually normal, and erythrocyte sedimentation rate is usually increased. We can have a peripheral eosinophilia, increased serum IgE levels, and also some flavor of autoimmunity in the serum. Pathological examination plays a key role in achieving a definite diagnosis. These are some cases with pleural involvement, pleural effusion, and this was a case with a mass in the lower left lobe and the lymphangitic distribution of the lesion. Cryobiopsy, the lesion is, we have nodules or we have involvement of perilymphatic structures. This inflammatory infiltrate is rich in plasma cells containing IgG4. So the final diagnosis was confirmed by cryobiopsy. And we have other data, other reports in the literature. Here one case also, IgG4 can involve mainly the tracheobronchial tree with PET positive thickening of the tracheal bronchial tree. You can have some differential diagnosis with amyloidosis, and cryobiopsy can be diagnostic. Move to the primary pulmonary lymphomas. The definition changed recently. Should be defined as primary pulmonary lymphoma and lymphoid neoplasm that become manifest first as respiratory diseases. Here's the list from low progressive disorders, low-grade malignancy disorder to very aggressive forms. Multiple lymphoma is the most frequent. Clinical profile is not typical. At least 30% of the cases can be asymptomatic. You can have a monoclonal spike in the serum. CT scan aspect can be suggestive. The differential diagnosis is mainly with ground glass entities or alveolar consolidation, so with adenocarcinoma is in the list of the differential diagnosis. And the disease is along the lymphatics in the lung and can coalesce in masses. We can have also ossification. It means that there is a combination of multiple lymphoma and amyloidosis, and we can have also cysts. This was a case with perilymphatic distribution of the lesion. Cryobiopsy was diagnostic because the lymphoid infiltrate is mainly around the bronchovascular sheath and beneath the pleura. Light chain monotypic expression can be easily demonstrated in lung tissue. Amyloidosis is another entity. We can have different clinical expression from diffuse alveolar septal amyloidosis, nodular amyloidosis, tracheobronchial amyloidosis, and now is considered, of course, a B-cell monoclonal entity. This is an involvement of the tracheobronchial tree, and this is a case of nodular amyloidosis, and you can have a diagnosis. Don't be afraid about bleeding, because if you read the textbooks, they say that amyloidosis can be a risk factor for major bleeding, but this is not our experience. Diffuse large B-cell lymphoma is the most common form of non-Hodgkin lymphoma in the lung. Nowadays, we have at least 10 of large B-cell lymphoma, so it's an easy diagnosis as a group. Is a difficult diagnosis if you want to subset the entity. These are the biopsy, and this was a case with a cavitated lesion, and in the cryobiopsy you can see the cavitation, that the wall of the cavity is infiltrated by B lymphocytes, and around we have normal parenchyma, and you can reach the lesion using also, of course, radial EBUS under direct visual control. Intravascular B-cell lymphoma is another interesting entity, can be confused with thromboembolism or cases of unknown fever. This was a patient with dyspnea, fatigue, recurrent fever, an increase of pulmonary arterial pressure, and this is a red flag, a significant increase of LDH. Another case with subtle parenchymal involvement, and cryobiopsy was absolutely diagnostic. So cryobiopsies can be done also in patients with an increase of pulmonary artery pressure. Lymphomatoid granulomatosis, this entity was identified long time ago by Ariel Lieboff and Anne-Louise Katzenstein. The clinical spectrum can be very, very wide. Usually, the patient have respiratory symptoms, but at least up to 30% of them could be or can be asymptomatic. Blood, you can have CD4 lymphopenia, and of course, serological evidence of ABV infection. In fact, nowadays it is considered an ABV-driven lymphoproliferation. We have different grades of malignancy, varying from grade 1 with few B cells infected by Epstein-Barr virus, and grade 3 that is a typical large B-cell lymphoma. Lymphomatoid granulomatosis in the lung can manifest with nodules, alveolar consolidation, cavitated nodules, and this was the 39-year-old male, non-smoker, that was admitted to our hospital for rapidly progressive respiratory failure, partially responsive to high-dose steroids. He had a CD4 lymphocytosis in BAL, and cryobiopsy was done even if he had respiratory failure, and we have now data that you can do in that way. The cryobiopsy was very typical. You see here we have angiocentric nodules, but in the lung we have only few B-positive atypical B cells. In the same examination, we performed EOS-guided needle aspiration of the adrenal gland, and in the lung we have lymphomatoid granulomatosis grade 1, and in the adrenal gland grade 3. T-cell lymphomas is even more complex compared to B-cell lymphomas. Lymphoma manifesting in the lung is the extranodal natural killer T-cell lymphoma, nasal type, can manifest with systemic symptoms, hemophagocytic syndrome, rapidly progressive respiratory failure, and involvement of other organs, mainly the skin, can appear soon after pulmonary symptoms. One of the typical manifestations of the disease is the so-called hemophagocytic lymphohistiocytosis, and that can be tricky because the diagnosis can be difficult. And also, the patient, because of the significant lymphopenia, patient can be confused with atypical infection. This was a 58-year-old male, acute respiratory failure, hemophagocytic syndrome, and in BL we had cytomegalovirus and aspergillus, but we have also nodules in the lung, and the biopsy was diagnostic. We have an angiocentric angiodestructive process consisting of granzyme positive cells, CD3 positive cells, and positive for Eber, so infected by Epstein-Barr virus. We can also have lymphoproliferative disorder in specific settings. Of course, post-transplant is one of that, but this was a 39 female under treatment with natalizumab, that is a monoclonal antibody targeting alpha-4 integrin, and she was treated for atypical multiple sclerosis. She presented with asthenia, shortness of breath, and cytopenia with a lot of nodules. Lung was infiltrated by CD3 and CD4 positive cells, but the T-cell receptor clonal rearrangement analysis documented clonality of the process. And we also documented the infection by Eber. So the final diagnosis was ABV-related peripheral T-cell lymphoma, not otherwise specified. This was our experience with cryobiopsy in lymphoproliferative disorders in the lung, published almost 5 years ago. And in this study, we had analysis made for pathologists, and we have also some data on mediastinal cryobiopsy in the diagnosis of lymphoproliferative disorders. And this meta-analysis suggests that cryobiopsy can be more valid in this approach. But we have problems. The clinical reasoning remains fundamental. An increasing number of sophisticated analyses are required for accurate diagnosis and precise therapeutical planning. Is the tissue obtained from cryobiopsy, particularly mediastinal cryobiopsy, sufficient? And we have new entity to consider, mainly the so-called mediastinal gray zone lymphoma. We don't have data comparing cryobiopsy with more invasive approaches, and the role of trained hemopathologists is of utmost relevance in maximizing the utility of the retrieved samples. And because the pathologic standard studies should include an analysis of concordance, discordance, and among hemopathologists. Regarding mediastinal gray zone lymphoma, this was a biopsy in this context. This is a new entity of at least 5-6 years, and there is a combination of Hodgkin, typical nodular sclerosis, Hodgkin aspect, and large B-cell lymphoma. But the treatment is completely different compared to classic Hodgkin lymphoma. So one of the needs we have to explore is that the bioptic strategy for cryobiopsy in lymphoproliferative disorders in the mediastinum has a role. We can have also some help from the rapid on-site assessment. We have one paper published with Ari Gonunguntle, and we have another with confocal laser microscope, and the other one is a study that the revision version is already submitted using another kind of microscope in order to have a rapid on-site assessment of cryobiopsy. Having said that, I want to thank all my co-workers, our cardiothoracic radiologist, Sarah Pichucchi, our pathologist, and all my group, and the fellows that we guest every day. Thank you very much for your attention.
Thank you. It was indeed an honor to have you here with us and lead this session. Apologies to the delegates. We have to let you know that because of a few scheduled flights and some delegates who had to leave, we had to pull up a few sessions ahead of time, which is why you must have noticed that a few sessions got off. But I'm happy to say that we are going to continue with the rest of the schedule as per original plan. We now move on to our next talk, which is going to be on achieving high diagnostic yield with non-robotic bronchoscopy, a session to be chaired by Dr. Ko Zhejiang. My pleasure to have you on stage, sir.
Hi, good afternoon, everyone. Sorry, I'm a bit out of time. So, thanks, Harry and team, for inviting us to talk about this topic, achieving high diagnostic yield with non-robotic bronchoscopy techniques. So these are my disclosure, but the biggest disclosure is that I'm just a sour grapes without his robotic. I'm not against robotic, just that we don't have access to it. Yeah, so we'll just share our experience on peripheral bronchoscopy. So I'll just talk briefly on the lung nodules problem in Southeast Asia, how we optimize our steps in lung nodule biopsy, and of course, to share our experience. So I think everyone knows solid nodule more than 8 millimeters, the risk of malignancy is high. And in the CHEST Asia guidelines, we favor less reliance on PET scan and also greater use of non-surgical biopsy because of higher prevalence of tuberculous nodule. So if we look at the TB prevalence from Southeast Asia radio EBA, we can see that from Thailand, Singapore, and Malaysia, it ranges around 17 to 24.7% of tuberculosis. In Japan, Korea, it's low, it's 4.8 to 0.8 to 4.1 kind of data. I think that some data from India as well showing around 11.5% of nodules were eventually tuberculous. So I always like to talk about guided bronchoscopy for PPL. It's just like delivering a package to someone. So first, we really need to know our target, what type of targets we're dealing with, how are we going to sample it and stuff. So what device are we going to steer? We have an ultratin, do we have robots, or we use guide shift, curette, etc. And then we need a map, how's our navigation system, are we going to do it manually, or we use some VBN system or something like that. And of course, when we reach there, we need to verify, we are reaching the correct person. We can use EBUS, fluoro, COMBEAM, lung vision, etc., etc. And then, of course, after that, we have to do the actual delivery, which is the biopsy, which you can use brush, needles, forceps, cryo, etc. And after that, we really need to audit the whole procedure to see how good and we are performing. So briefly, I'll go through navigation. We can do it through manual bronchial branch reading technique. We can do all the automated system through various VBN, but all this will require money, which a lot of us doesn't have. So I really like this study, it's the ATLAS study, which they look at the distance from the terminal end of the navigation pathway to the target PPL. You can know this is the earlier generation electromagnetic navigation, and this is the latest robotic navigation. And interestingly, there's always a gap around 9.4 millimeter, in the latest robotic system. That's still a significant gap that the computer automated algorithm could not generate that pathway. So this is a plan. So by just looking at the CT, we are able to map out all the airway that actually leads into the target. But if you put it on the navigation system, you can see there's actually 3 bifurcations that's missed. So if you're using a big scope and imagine you park your scope here, there's a lot of chance that we might actually miss the nodules, all right? So bronchial branch reading technique, I think we really have to say thank you to Prof. Noraki Kurimoto, who actually formed a very solid foundation for us to build, to do this navigation. So if this is his first book on bronchial branch tracing, if you translate directly to English, it basically means to translate CT images to bronchoscopic images, and then we just have to move like a ninja throughout, all the small airways. So this is our earlier work on in 2019, around 100 patients. These are using big scope, a 6.2 mm scope with guide shift and bidirectional guiding device. A big lesion, 2.67 cm. We can reach there by 98.9% of the time, but the yield is 88.8%. I'll have to say this cohort, we are using a very liberal kind of diagnostic yield. Those of you who know Prof. Kurimoto's method, mainly he's using axial CT for planning. So over the years, I think we have developed, we find that in certain reconstruction, it's better for us to get to certain views. So I'll just show you one of the cases. This is a 55-year-old gentleman with a colorectal CA with a RI-sac nodule. TV cultures, everything was, AFB was negative. So just by turning the CT in the appropriate location, you can see the arrow RB8, and it's split to A, B. So we just follow the B. It will split to like this, okay, 1 and 2. And then we follow the 1 to, this one, alpha and beta. If we follow the beta, it will go, again, it will split to X and Y. And then we follow through the X, you will see that it will split again. Somewhere there, YX again, and then that small airway will actually go to the site of the nodule, all right? So when we do the scope with an MP190F 3 mm scope, you can just follow the map that we have planned. So RB8, AB, 2, alpha beta, the beta XY. So now we are reaching the final destination, and there's only 2 bifurcations inside. You just put the radio probe in, and you get the solid radio E-bus image. And then we do a spin, we confirm that we are reached there, and then the cryobiopsy just confirms it's a METS colorectal CS, so patient can move on to the treatment. So I think using this ultra-thin scope, it really helps us to reach the nodule very, very well. So this retrospective data, 47 patients using MP190F 1.1 cryo, only based on bronchial branch tracing on the 1.91 cm median-sized lesion. We can reach there in 91.5% of the time. Index diagnostic yield, this is quite strict, it's 82.9. But if we allow some follow-up data, we can reach up to 91.5% of diagnostic yield. So next, we go to steering tools. I think this is very important when we consider. So either we are using a big scope, a diagnostic scope, a slim scope, or ultra-thin scope. Or you don't have this, you always can use a big scope with guide shift and curate. So curate is very important because it allows us to change direction. So if you see this photo in A, the radio probe will just follow this direction. But we are able to guide the guide shift into our desired airway, and then we can just biopsy. So it's very important when you're using big scope, you can use a guide shift to steer where you want to go. But again, we know if we can reach nearer to the lesion, it's better for us to biopsy because we give us a better angle, better distance and stuff. So of course, we love the ultra-thin bronchoscope. the MP190 from Olympus with a 1.7 channel really allow us to insert radio e-bus for verification and stuff. So I like this slide. If you look at the existing robotic system, this is the size of the catheter. So the ultra thin is really quite comparable with the size and the channel and the allowed vision almost all the time, like what Dr. Amer has mentioned in the earlier talks. So this is the scope. These are the scopes that we have. So every case, we will choose which scope to use to have a better reach. So how about the literature? I think this is a very nice review article from Dr. Oki from Nagoya. The U with radio e-bus is around 41 to 86%. Radio e-bus plus COMBIM around 85 to 87%. So the overall U is around 70% with ultra-thin scope, but we have to be mindful that these are all mostly using small forceps. So of course the U will be lower. So our experience is that if you are using forceps, it's around 84, which is consistent. Cryo, we can achieve around 94.1. Especially be useful in those non-concentric lesions. I think cryo will perform better than forceps. Yep. So using ultra-thin is also allow us to have direct visualization. This is a patient with a right upper lobe nodules. You can see we can go all the way into that segment and we can able to a lesion. So in the figure C, we get a complete blackout because this is melanoma. So when we touch our scope on the nodule, you know, that's no light at all, right? So this is a quite interesting case that we report a complete ultra-thin bronchoscopy blackout due to a melanoma. But the problem, I think, of ultra-thin scope is the lack of rigidity. So in this case, maybe the robotic shift is better. So in Japanese, they are calling this the Watanabe phenomenon. It's especially when it's very angulated to the upper lobe region. So when we have this downward force, this force is not transmitted to the end of the scope, but instead the scope moves paradoxical retraction. So this is something that we have to be very aware of because it's very fragile. If you keep doing this, eventually the fibers will break and then you have to send for repair. But the easiest way to do this is just put in some stiffer forceps or radial probe to stiffen up the scope so that the scope can continue to move to a more apical region. So next we talk about verification techniques. So we have probe-based and imaging-based method. Probe-based, the most common one with radio e-bus. OCT and confocal laser, it's there, but it's not commonly used in routine clinical application. Of course, we have fluoroscopy, tomosynthesis, and COMBIM CT as imaging-based kind of verification. So radio e-bus, I think we do not need to talk too much. It's, you know, the orientation is related to the airway that we have reached. But again, radio e-bus has a lot of issue. If it's a lot of problem, it's poor signal with ground glass nodules. If it's atelectasis, you can get some sort of solid lesion and stuff. And most importantly, you have to have contact. If there's no contact with the nodule, there will be no signal. So next one is about fluoroscopy, but we also know the limitation of fluoroscopy. For small target, we have very poor vision. Non-solid or ground glass lesion, very poor vision. And of course, in overlapping areas like the retrocardiac, diaphragm, paraspinal, we can't really see. But of course, we always use the fluoroscopy to mark our radio e-bus. So we know the proximal and distal end. So sort of like a manual augmented fluoroscopy to allow us to perform biopsy in that region. So recently also we start to use this virtual fluoroscopy. By just using normal DICOM software, you are able to plan how are you going to rotate your C-arm during procedure instead of just try and error during the actual procedure. So this is a case where the nodule is hidden behind the diaphragm. So I expected if you are using AP fluoro, you are not able to see this nodule. But if you're able to just rotate and pre-plan your fluoroscopy, at the RAO of 25, you are able to open up the angle, you can see the nodule nicely. So I think this is one way to optimize our fluoroscopy instead of just keeping at AP all the time. So we get the diagnosis of this case. So it's also important for those lesions that it's invisible on fluoroscopy, like this case of part solid nodule. So by doing this pre-planning, we're able to sort of localize where the lesion is. So during the actual procedure, we have a rough idea where's the target and where for us to put our tools. So virtual fluoroscopy is something that the Japanese use quite a lot, especially in Tokyo. The NCC Tokyo have published quite extensively on this topic, which has shown that for GGN invisible on fluoroscopy, this technique actually able to increase their diagnostic yield. So how about 3D intraprocedural imaging to help body vision? I have no experience. We have Combeam CT. This is a very nice image from Dr. Tajali. I really love it. It's small, very small GGN at apex. It's really just amazing. So I think meta-analyses have shown that Combeam CT is able to increase the diagnostic yield of our procedure, be it ultra-thin scope or in electron navigation bronchoscopy. So it's especially good in those lesions, I think, with GGN that is not visible on radio EBUS. So we have a case, part solid nodules in the right upper lobe. So we can navigate there. If you put in the radio EBUS, you will get some sort of blizzard, mixed blizzard kind of signal. It's not easy to identify, if you are just starting to do radio EBUS. So sometimes you don't feel confident to biopsy there, so it might be difficult. So if you have other imaging modality to help in this kind of situation, it might be helpful. So recently we have a case of pure GGN in the left upper lobe. So when we put in our radio EBUS, you can't get any signal as expected. It's not even, a specks of blizzard or something. There's nothing there. So fortunately now we have a mobile Combeam from the ZIM system. So when we do it, after navigate with bronchial branch tracing, you can see that the two go directly just next to the target. It might not be very clear, sorry. So on this view, we can see the, our probe is really just parking next to the ground glass nodule. So in this case, the Combeam actually able to convert a low confidence radio EBUS procedure into a high confidence localization. So when we do a cryobiopsy, it's proven to be a lapidic adeno-CA with positive EGFR. So patient is waiting for resection. So these are the things that we get from the cryobiopsy. The first pass actually, when we examine properly, you see some cartilage here, but it's normally just normal lung parenchyma. But in the second pass, we're able to get a lapidic kind of adeno-CA. So when we check our first spin, it actually just is not within the nodule. And the second spin, after adjustment, we can see now we are really just touching the nodule and get us the answer. So now we are start to do all this Combeam spin with our radio EBUS. So yeah, it's really quite interesting. But we are really interested to know which type of cases really we need for diagnostic indication, which we don't think we will need it for every case. So just now we talked about verification by probe-based, by imaging system, but I think the extreme miniaturization of tools allow us to do verification on direct vision. We have the zero scope from Vatin, which 2.2 mm allow us to go very deep in. We have the iris scope with 1.8 millimeter, and even the Japanese have described a 0.97 mm fiber, which they can really reach very, very distal part of the lung. So we're doing this with a Vatin zero scope. You can see how far we can reach, to the distal airway. It's really amazing. So we can really just reach the subpleural region, and this is the 2.2 mm scope. So if, we can develop a shift that's quite flexible, that we can drive, then it's going to be perfect. So next, briefly on biopsy. How are we going to do biopsy once we reach there? We can do lavage, brush, needle, forceps, or cryo. That's a lot of things for us to choose from. So we have a patient here with sigmoid colon CA, post-resection and chemo with a 0.7 mm nodule up there. Not sure this is TB, another cancer or metastatic or something like that. We're able to reach there, we get some signal. We just do lavage because I think the pretest diagnosis for this patient is, it's more towards TB. So as expected, we get gene expert positive and then cystatin granuloma on forceps biopsy. So as I mentioned in the first few slides, the TB prevalence is very high in our region. So we try to sort out what are the predictive factors. So like age, younger age, smaller size, upper lobe cavity with radial EBUS bronchogram, probably quite predictive of tuberculosis. But of course, this is in the context of our region, where we have 112 per 100,000 population TB incidents. So how about not lavage, how about using needle? I think it's useful in lesion without a bronchus sign. The problem is the stiffness of the needle and the cytology specimen that come with needles. So using a guide shift and needle, as you can see this case, our probe is just moving away from the nodules. There's no direct airway that go into the nodule. So with a needle, we are able to puncture in and put the guide shift in to allow us to do effective biopsy. So of course, the periview flex needle, which we can use with the ultra-thin scope, I heard it's going to be launched this afternoon in India. So this also allows us to make a direct puncture. You can see after puncture, puncture with the 21 gauge periview flex, we were able to get a hole on the airway, right? So we will just put in the radio EBUS probe into that hole, and then you get a very nice concentric image. Yeah, so then you can put forceps, cryo, whatever in to get a biopsy. Another version of bronchus, this is a second generation BRONCHUS BTPNA kit. It's a tapered end a shift with a needle tip that allow us to really just tunnel in, tunnel the shift into the nodule. So convert from a pure adjacent into a within orientation for biopsy. Yeah. So to know more, I think we can, I invite everyone to read this article from us, the technical aspect, how we plan it without other navigation system. So this is a very good needle from Olympus, the Smooth Shot Plus. This is a very flexible shift and just a needle tip. So this allows us to go into all your 4 mm scope and reach upper lobe to do all the puncturing. So how about cryobiopsy? I think this from Prof. Felix Herf and the Shanghai group have show us the diagnostic yield is 91% in a very large cohort of patients. Basically, it gives us very huge specimen intact architecture for pathological analysis. So we have also shown in 2019, I think, that the cryobiopsy actually have no difference if you get a concentric image, but if you get eccentric or adjacent image, it's actually increase the diagnostic yield significantly from around 50% to 75%. So bleeding is more common, so we would advise to use it not in every case, only in indicated cases. So most of us are using 1.1 mm for nodules. So how many pass, how long to freeze, I think there's no guidelines. But when we do a historical comparison of our cohort using 1.9 versus 1.9, we find that the freeze time around 6 seconds, with 3 passes, that usually to be adequate to have a comparable diagnostic yield with the historical 1.9 probe. So cryobiopsy techniques for PPL, you can do the standard on-block technique where you activate and you remove the whole scope with a balloon, or you can do the shift retrieval method. You just retrieve quickly the 1.1 mm probe through the guide shift or your scope. But we don't really like the shift retrieval methods. Our experience is that if you're using that for cryobiopsy, just using cryobiopsy alone, the yield is around 60%, but if you combine with forceps, it's around 85%. So the Tokyo group have shown very good data. They're using the 260F scope, which is the P190 scope, no shift. They'll just pull the cryoprobe from the working channel, and very good diagnostic yield of 82.3%, despite smaller specimen size compared to conventional methods. And they report there's no bronchoscope breakage. So those of you who have went to Tokyo before, you know their bronchoscopy rack at the back is full of scope. So I think it's okay to have one scope breakage, but not for us. So I'm not going to sacrifice my scope using this technique. So when we're doing cryobiopsy, I think have been shown multiple times in a lot of paper. The first cryobiopsy is the most important biopsy, because after that you will have issues, whether you are blocked by bleeding, you are blocked by whatever things. So why is that so? I just want to show you this very nice case. So it's an upper lobe nodule that we drive it with an ultra-thin scope. So we can see we are in the lesion, so we are very happy. So we do a spin, everything is okay. So radial probe is 2 in lesion. First pass at second, very good tissue obtained. Second pass at second, there's no tissue. Worried, is it because our navigation fails or something like that? So we put the cryoprop in and we do another spin. Now you can see after 8 seconds, you can really see a big hole in the nodules. So I think that's the reason, at least we think that's the reason, because now after cryobiopsy, you leave a very big hole, and we're using a 1.1 mm probe, so the contact might not be good. So fortunately, the first pass already gave us an answer, so we do not need to proceed further. So I think the Japanese also do a lot of this negative pressure expansion, especially when they are biopsying for ILD or biopsy for ground glass nodule. So this is what we usually do as well. We just put it into a syringe and then we apply around 10 to 20 cm water of suction just to expand it, then before we throw into the formalin. Yep. So I think the last part is how we audit ourselves. We cannot just keep doing and say we're very good. So this is our experience over 6 years. We divide our experience into 5 batches, around 100 patients per batch. So the overall diagnostic yield is around 78.8%, very high prevalence malignancy, 62.7%. Pneumothorax risk is 1.1%. So if there's a bronchus sign or concentric radial EBUS, it's a predictor for a conclusive procedure. So how about in the future? So if we're talking about integrating ultra-thin bronchoscope into our practice. So by this paper from ours is around 91.5%. So maybe it's get better. So now with COMBIM CT, is it getting better? We are not sure. So we are currently recruiting our patient into the COMBIM registry. And hopefully in 1 or 2 years, we're able to know which type of patient actually need COMBIM CT, or you can just use your bronchial bunch tracing and enough. So the take-home message from me is, I think radial EBUS without additional automation technology, at this moment is still relevant and an elegant tool for accessing lung nodules. We have to maximize the potential of our current tools, and then the development of technology in various aspects of guided bronchoscopy for lung nodules, in navigation, in robotic, in verification technique, biopsy technique, along with advancement in therapeutic ablation is highly promising and exciting. So don't compare ourselves to others, but always focus on getting better at our own performance. That's what we believe in. So lastly, I think just allow me to advertise. So in August 2025, we're going to have our EBUS and cryobiopsy workshop in Malaysia. I think Prof. Poleti will be there with us. And of course, our MABIB annual congress will be in the beautiful city of Malacca. So I hope everyone, if you are interested, please join us. So thank you from my small team in Sarawak, Malaysia. Thank you.
Thank you so much, sir, for that very informative talk. We now move towards the great debate, the role of robotic bronchoscopy. May I first call upon stage Dr. Kyle Hogarth, who will be talking about robotic bronchoscopy for all nodules. The counter will be presented by Dr. Pallav Shah, who will be debating the role of robotic bronchoscopy for selected nodules.
All right. We'll do this together.
David Goliath.
Okay, so I'm here to make the position, of course, that if there is a pulmonary nodule that you need to biopsy, that you should be doing this via robotics. And of course, I'm taking on a good friend, Pallav Shah, who already is going to lose, as you can tell from the picture, because who looks tougher? So, all right, I'm going to start with the predicate that our patients deserve the best outcomes. So as we talk about the ability to use bronchoscopes to get to the periphery, as you saw Dr. Koh just elegantly deliver, there are yields in the 80s, and that's fantastic. He's one of the best peripheral bronchoscopists in the world. Right before that, you had Amir Abramovich, one of the other best peripheral bronchoscopists in the world. Is that skill set able to be replicated around the world? One of the great equalizers is the application of additional technology. So our patients ultimately deserve the best, because why were these technologies developed? Because if we go back in time, this is how bad we all have been at this. These are the yields historically with the first, so I would call this 0 generation of bronchoscopy. Us just sort of looking at a CT scan, blindly pushing some instruments out. Basically, it was a coin toss. It's why traditionally bronchoscopy didn't play a major role in nodule diagnostics. We already heard earlier today as well a fantastic talk by Dr. Sesenia about how we're defining yield, also based on what's the cancer prevalence in your area, et cetera. So in the end, we need an answer, because we have a patient in front of us, and is it tuberculosis, or is it cancer, or is it something completely different? Well, why don't we just do a needle biopsy? Let's kick bronchoscopy out of it completely. I was at a fantastic conference with my good friend, Dr. Shaw, and at that conference, the chest radiology folks were busy talking about how great they are and how they don't need robots. And in fact, what they were talking about, how expensive bronchoscopy is compared to a needle biopsy. And look, they've got a decent sensitivity. Granted, there's a lot of publication biases here. They've got a not so great specificity, and they've got a pretty abysmal false negative rate. They also forget to mention their profoundly high pneumothorax rate, and their tumoral bleed rate, and their hemoptysis rate. And then what do you do when your patient's already had a lobectomy? Does anyone want to needle the only lung this guy has? I don't think so. So again, we need to make a diagnosis. We can try to do it with a scope, but there's a cost to that first failed bronchoscopy. There's a cost to that diagnostic yield that's still in the mid-70s. There's the money and time that's ultimately required for a second procedure when everyone talks about how expensive robotics are, and there's no debate, they are expensive. But there's also the cost of the missed diagnosis and the additional procedures. There's the cost that the delay until they get to that next procedure, the cancer is now spread. So the opportunity to have cured that patient goes down. Or that it was tuberculosis and now they've infected their entire family or their entire workplace. The public health issues that come with the delay in the appropriate diagnosis. And of course, you've got a patient who you said, I think you have cancer. We should do a bronchoscopy. And then you have to walk out and say, I failed. And now hang out for a while until I can get around to getting another procedure set up, one that has a higher complication rate, etc. So now I'm going to talk about robots. And I'm clearly very biased. But of course, that's the purpose of this debate. So I'm going to focus just specifically on these outcomes. This was Mike presented some of this stuff earlier. What I'm going to show you is talking about advanced imaging. Right up front, when you look at one of the first generation of robotics, the Ion, the yield when you add advanced imaging approaches the low 90s. It's pretty incredible. When you take a look at Taj's study, the Frontier study, the first study that came out from the second generation of robotics, you see a yield based on which definition you want to use, up to about 95%. I think the key thing that's often lost in this study, the Frontier study, was that this was the Australian group's first exposure to robotics. So when people ask about a learning curve, this is how well they do, having never used a robot before, though obviously being very accomplished endoscopists. When you look at the experience from the Cleveland Clinic, tool and lesion rate of 98%, strict definition of 90% diagnostic yield. Same with the data from Federbush out at Long Island Jewish. Look at their diagnostic yield ranging from 88 to 93. And then if you look at our own experience of a 95% yield, and notice what we're biopsying, majority of our lesions are less than 20 millimeters, a third are less than 10 millimeters, majority have no bronchus sign, majority are on the peripheral of the lung, some even on the visceral pleura of the lung. So the ability to get to places we've never been able to get to before with reliable, terrific accuracy. And then I'll just give you some case examples, because I'd be curious to know how we would all go to approach this one. Because here's the CT, and look where that's located. That's an extremely challenging location. But when you can see it with the built-in tomosynthesis, in this particular case, a Galaxy robot, you can target that lesion and then make sure no matter where you are in the lung that you can, even if you had to tunnel if there was no airway, put in your forceps or your needle or your cryoprobe right into it. And of course, this was a carcinoid. Or what about GGOs? 582 Hounsfield unit GGO. There's the reference CT, there's the tomo image, and then what you're going to see here, because the airways went around it, we're tunneling with the needle, making a nice hole in the airway. The hole, the aspiration was diagnostic. The hole we left behind, we were able to pass our forceps through, and I'll show you it here, and then I'll go back to that image. There's the airway we made. The ability to have that stability of the robot, optics that are always on that you get with the second generation of robotics to then pass any instrument you need to go through that. And what we were able to show is right up front, this was an adenocarcinoma. Not surprisingly, that's, by the way, just an image from the Van Gogh system that allows you to basically intraoperatively measure metabolic activity of the tissue you removed. So it's almost like a miniaturized PET scan. So that's what all the glowing yellow cells are. So I wanted to be short and brief because I want to allow time for my colleague to give his really horrible failed argument. But I think in the end, all kidding aside, what we're always up against, of course, is that at any institution, Joe's always made a great statement, which is the best system is the one you have, right? You can dream of having any system out there and any imaging system, but in the end, it's always dependent on cost, access, and availability. And we're all incentivized differently. Robots pay more in the United States than a standard bronchoscopy. So there's not even a rationale to use a standard bronchoscope for a nodule in the periphery because you get actually better remuneration if you use a robotic scope. And then, of course, in the end, because people have choice of where they want to go for their health care, robots bring in more patients. Right or wrong, there's the appeal of robotics. And again, welcome anyone if they're in the Chicago area, and there's my contact information. And now, feel free to go get some lunch or go to the bathroom, etc., because the next talk is a colossal waste of your time.
Thank you so much, Dr. Kyle, for that very, very formidable argument. May I now ask Dr. Pallav Shah to provide his end of the argument. Thank you, sir.
Well, thank you to my esteemed colleague who really didn't listen to the talk question. It was robots for all nodules. Well, my view is that there's a very important role for robots, but not for all nodules. Why? Because robots are virtual, aren't they? They're not real. So let's go from there. But before I say that, I've got a message for my Indian friends.
नमस्ते मेरे हैदराबाद के दोस्तों, शुभ संध्या। मैं पल्लव शाह हूँ और मैं जो कहना चाहता हूँ वह ये है कि मेरे दोस्त काइल होगार्ड से मत सुनिए जो शिकागो से हैं। वह चाहता है कि आप महंगे उपकरण खरीदें और आप जानते हैं रोबोट्स और विभिन्न प्रौद्योगिकियों पर लाखों पाउंड और डॉलर खर्च करें और मेरे पीछे की तरह एक अंतरिक्ष यान बनाएं। लेकिन मैं आपको अपनी व्याख्यान में दिखाऊंगा कि हम इसे कैसे सरलता और सस्ते में कर सकते हैं और भारतीय तरीका। धन्यवाद। नमस्ते मेरे हैदराबाद
Basically, to translate for you, Kyle, I said, don't listen to that big American guy. He's too expensive. I'll show you a cheaper Indian way. So basically, just like we said, we've got all this technology out there. And, you know, we've seen some superb bronchoscopies tell us that they can do a 4mm nodule using a piece of straw. The real answer is, can everyone do it? So how do we standardize it and still get results that are just as good? So what I really wanted to do is take this opportunity to remind everyone that there are established techniques there. It's just you have to use them wisely. Transthoracic ultrasound, you know, that's real-time imaging. And if the lesion is right against the chest wall, you basically just wave an ultrasound wand and under direct vision, take a biopsy. You've got linear EBUS. Don't forget, linear EBUS can get much further than you actually realize it can get to. And we've seen the amazing work that our colleagues do with slim scopes. And then obviously you've got surgery. Those are all real-time imaging. We all talked about cone beam CT scanning, but that's near-time imaging. And now we should put the robot where it needs to be. It is virtual. We're living in the imaginary world, and the robot relies on real-time imaging and near-time imaging to make it better. So let's just break that out a little bit more. So here's a case, large lesion, central chest. Do you need a robot? No. You just need an ultrasound, and you can easily get that lesion. Here's another one. Do we need a robot? Well, in Chicago, you need a robot. In London, you just get a CT-guided biopsy of that lesion. So basically, this is where the difference lies. And here you have a needle going straight into that lesion and a biopsy done. But you have to choose the target case wisely. And this is a case again, robot or no robot? Well, actually, this is a case for my friend Stefano Gasparini. Get the EBUS scope out, and you don't really need cone beam imaging for this, but I just used it for illustration purposes. And you can see with this lesion, which wasn't directly adjacent to the airway, you can push your EBUS scope towards the lesion and get real-time imaging. No robot in sight. Okay, this is a slightly more challenging one, I'd say. Here is a patient with a PET avid lesion, which you can barely see on the CT scan. So there's the PET avidity, but it's virtually impossible to see on the CT scan apart from this very subtle area of thickening. And in fact, this patient was referred to me for a robot case, but what am I going to biopsy? I couldn't even see it on the robot, so I actually opted for linear EBUS, real-time imaging, and we basically saw a thin sliver of tissue and biopsied it, and it came back as a metastasis from a prostate cancer. So yes, use a robot, but not for all nodules, only selected nodules. I think my distinguished colleagues have already illustrated this beautifully, but even an amateur bronchoscopist like me can see that this is straight into the lesion, and even I, with no peripheral bronchoscopy skills, can simply target this lesion and get a successful answer. So here, I'm just using some cases to illustrate that if you choose your subject wisely, you're going to bring your diagnostic yield to the 90% for whichever technique you use. So you want a toolbox. You can't just have one tool. If you just have a screwdriver in your toolbox, you cannot do everything you need. So you need a toolbox, and therefore you need more than a single robot. This is cone beam CT scanning, and like we saw earlier, you can use the mapping, tracing, and slim scopes in a variety of ways, but I'm not going to labor the point because my previous colleagues have demonstrated this elegantly. But where I will say the robot becomes invaluable is where you've got tricky lesions. Here, you're very close to the arch of the aorta, there's a bulla up there, so in that situation, I will bring out the robot. So for selected nodules, the robot has a very, very important role to play. And here you can see that with the combination of cone beam CT and robotics, you can very accurately get a lesion that's there. And in fact, what this will show you that actually even with a robot, I'm a little bit anterior to the lesion, and with cone beam CT, it elevates the practice because then you can make some fine precision movements where you move a little bit posterior, and then you will get in a much better location, and you then use a combination of real-time imaging, radial EBUS, confirm you're in the right spot, and then our favored cryobiopsy to get a diagnostic answer. Then there'll be lesions. Amir will probably go and target this with his scope, but I'm a bit more chicken, so we used obviously a little bit better control. So we used the robot here, navigate to right next to the heart, confirm on real-time imaging that we're in the right spot, and then we use our imaging to prove that we're in the right spot, and then we can take our biopsies. So basically what we're saying is use our multitude of technologies. I will concede that with ground glass lesions, I personally will opt for the robot because you can't really see it easily on radial ultrasound nor on fluoroscopy. And the advantage there is the cryobiopsies. And again, I'll stop short here because we've already talked about cryobiopsies, but just to highlight that for a ground glass lesion, my radiology colleagues are not as good as us because they get thin slivers of tissue, whereas we get huge, well-preserved architectural pieces of tissue. So where do we use the robot? We'll use it for bilateral nodules, multiple nodules. So this is one patient who had 3 different nodules. And in the old days, we would make the mistake of saying that they've got either metastatic disease But actually what we found was this first lesion was an adenocarcinoma, mixed pattern. The second lesion was an adenocarcinoma purely lipidic, and the third lesion was a granuloma. So you don't write off patients without diagnosing every single nodule. So if they've got multiple nodules, take the robot out. So putting all of this into words, you can see that the efficacy of the different imaging techniques is variable if you look at the literature. So what you want to do by using the right circumstance is to push the shifts towards the better diagnostic yield and equilibrate with the risk. So obviously linear EBUS, limb scope have very low risk, but if you use a lesion that's appropriate like I showed you, then the yield will be in the 90% with minimal. Under certain circumstances, electromagnetic navigation, cone beam CT might be more appropriate, intermediate risk, intermediate cost, and higher risk. And then finally, you've got the robots and CT-guided biopsy with great success, different costs and different risks. And you have to mentally balance all of this to make the right choice. Now, I had English translation, but I was going to skip that for you and basically say, thank you very much for listening to me, and I'll bring Carl back up so we can argue a bit more. Thank you. Now, this is where, with any good pro-con debate, we have to vote with our feet. So if you all think you should use a robot for every nodule, stand up.
You're standing.
And who thinks you should use a nodule selectively, a robot selectively? Stand up.
So one thing that was not brought up during your part of the talk was the lesion that you said you couldn't have seen with the robot because the robot you use requires you to remove your optics. So unlike a slim scope, you get to the periphery and you're now officially blind and you have to reuse $1 million cone beam system to make your $600,000 robot work better. Whereas my robotic system doesn't require all that additional technology. So there's one other weakness. The second weakness is how long does it take to get to the periphery? With you and I, when we use a robot, under a minute. You're there and you're ready to biopsy, like that. You were telling me earlier how long a bronchial branch tracing scope went. The number of cases I can get done per day is very important to me as well in my system, and you as well. So the argument against manipulating through a ton of airways is, again, not Amir and not Co, but the more average user.
Me.
And me. I mean, you don't want to watch me doing a thin scope to the periphery. I'll be there all day.
But the point is, David won. Goliath lost.
Any questions? I think the thing we both obviously completely agree upon.
Do we have a microphone for Stefano?
Is I think what you would agree as well. It's always going to be resource.
We have mic stations right at the back, sir.
Well, actually, it's always hard to hear with the microphones up here. Stefano, what's your question?
Well, thank you very much for your interesting presentation. The problem of peripheral nodule is that we need controlled randomized study. The data that you presented with the robotic bronchoscopy are all done with cone beam CT guidance.
Oh, no.
So, yes.
Not my data.
All cone beam CT. Well, so I would like to know if there is a study that compare robot and cone beam CT and cone beam CT and ultra-thin scope. Is there any comparative study? Because I think that the value, the add value, is the cone beam CT in these cases.
So the early robot studies didn't use cone beam CT. They just used robotic systems, and their results are between 83%. And adding in cone beam CT gives you that additional improvement, taking you into the 90s. But there is no pure cone beam CT that I know of.
No, so the original work that Mike did with cone beam, which was with blind catheters, had him yields in the high 80s. So you could make an argument that robotics didn't add a lot from the perspective of yield, at least in the hands of one very, very experienced cone beam user. But I will point out that the data I showed on the Galaxy, one of its key things is the built-in digital tomosynthesis, which I'm going to show later in my next talk. I did not have any cone beam. So Stefano, I did not use cone beam. Zero cone beam. I don't have cone beam. I have no access to cone beam. I use standard two-dimensional fluoroscopy with digital tomosynthesis. Very similar to body vision and lung vision, only it's built in and integrated into the robot. And so that also saves us a lot of time and radiation exposure and cost. Amir.
So I agree with Professor Gasparini that we tend to confuse between the hardware and the advanced imaging system. It doesn't matter if you call it cone beam CT. You want me to come there?
So I think Amir's based that a lot of the data out there is based on high volume centers in expert hands. What we really need is having the same data to be more generalized.
But what Amir was first asking was that without cone beam and or digital tomo, without advanced imaging, the diagnostic yield looking at robotic systems was low. It was in the mid-70s. The only study that had it in the 80s was going after 4-centimeter lesions. I don't think you need anything to hit that, right? But the other point he was bringing, what was a good one, was that there's how, we said, can you replicate thin scopes? Can we replicate the ability to get to the periphery the same way we've heard? When you look at robotic systems, it's frequently high volume centers. There's about 900 plus units of robotic systems across the 3 brands within the US. Do all 900 sites have the same yields, the same abilities? Because of course, I think we would all agree, bronchoscopy is also a repetition phenomenon. If you only do 30 cases a year total, unless you'll go after large things. Again, I think anyone can hit a 4-centimeter lesion, but can you go after challenging lesions?
So now that I won the pro-con debate, I will actually say that the huge advantage of robot systems is that the learning curve is very, very short.
Yeah.
Within 10 procedures, everyone is at the same level. Yeah. An old man like me can use the touchpads very easily and confidently do. And a newbies and our fellows get the same results. So it does close the gap in between varying practices.
I would agree. I agree with that statement.
I think the key message is that the different techniques have a huge variation. The robots bring that variation down. There's no doubt that robots are yet to come and they're going to become very important. We just need to use them wisely in the right setting, particularly in economies like we are in.
Right. Yeah, I would agree.
Thank you so much, sir, for the very, very entertaining debate. I'm sure we've learned a lot, have a lot of points as well, but then again, we leave it to the judgment of the audience. Moving on to the next lecture we have by Dr. A.B. Alrais. This is going to be on proning strategies for advanced bronchoscopy.
Hi, everyone. Thank you. So after this talks, what I'm presenting now will be a cases that you not only need the robot, or you need also the cone beam with it. And I have no disclosures for this talk. So First, why we need the proning, so I will highlight the role of forming of atelectasis in general for that reason, that where the robot even become not helpful, and how the proning preventing those atelectasis from forming, especially for the posterior medial basal lung nodules, as well as what the technical challenges that you might face with the proning cases, that even the not enough for these, and go over the scenarios. So always we should look for the full part of the cup, but when we do really robotic and proning, and for any atelectasis, we prefer to look at the full empty parts, because we want the air, not the water. That's what we are looking for. And we know that from Dr. Sagar and et al. From MD Anderson, that the forming of those atelectasis mainly at the lower part of the both lobes, and more than the apical. And that's where our yield always better in the upper lobes than the lower lobes. As well as from Dr. Pritchett's paper, and without implementing the anesthesia protocol, after 40 minutes, we know that where the atelectasis will form in the posterior lower part of the lungs as well. And adding on that, the divergence that happen, as you see on this paper as well, on the lower parts, really those factors all together put that challenge for us. And after having this program running, we experience the posterior lesions. And when we name posterior lesions, it's really where the lesion sitting on the lower part of the lung, in the lower lobe, below the level of the spinal bone. Patients who had BMI more than 32, and also when we have prolonged procedure, more than 40 minutes, or if the anesthesia also disregards the follow-up. This is an example that the patient really, the only thing that his BMI was higher, and this is even in the upper lobe, as you see in the left upper lobe, but a little bit posterior. So what happened is, this is even before we start, before the spin, before we start the driving, we did a spin and we allocated that lesion, as you see it. And still with that, after intubation, with rapid sequence and everything, we still having start atelectasis. But after 20 minutes of the case, now everything, even in the upper lobe, we notice that this is happening. Luckily, we're still getting the diagnosis of adenocarcinoma. So the reasoning that we were talking about proning. But not for that lesion, for lesions like this. Really supradiaphragmatic, medial basal, and posterior. Those three factors, it's not possible for IR to get it, and also there's selective cases that we need to do. This patient has esophageal lung cancer with a growing lung nodule that they need to rule out recurrence of the disease. As you see from mapping it even, it's sitting exactly in the crack where between the lesion, the diaphragm closing up with the pleura, sitting in that triangle, and that triangle is the first triangle in the lung that will be forming atelectasis. And even with mapping and extending the path and having that all support from the robot, and even if we have an airway that can lead to that area, we're still dealing, you can see where the lesion is sitting. So that made us, for such cases, we prone the patient. And based on that, those are the three things that make us go after it with those factors. So we have now a setup for those patients that the team knows exactly where we are preparing for it. They have special pillow that we allow the ET tube to come from where the entrance, that's coming from the robot side, either the right side or the left side of the mouth for the ET tube. and then also support all the pressure points. And really it takes like around 20, maximum 10 to 20 minutes to get the patient in position, not for mainly the position for proning, but for centralizing the lesion. As you see, the ECG cords also out of the zone where we are doing the lesion mapping. When we are connecting the AT tube to the robot, we come from the easiest, the closest, because there is a challenge always to run of that space with the length of the ET tube, because you are not starting from top. We have that curve that allow us also be challenging when we put that extra length that will take part of the scope. Also, we always make sure that the scope very well lubricated, because we're going on an angle that going inside the ET tube. That part very important for the procedure. So we start with the spin, because that helps. And for the cone beam we are using, really you can change the position so that exactly where the patient head is. So it gives you the same orientation as the as if you are doing it AP or lateral without changing that dimension. So this is when we get in with the ET tube inside. You can see that we start with the trachea upside down. And then when we start driving, we have already created the path not only on the robot by its navigation support, but also it's very important that we put those landmarks, the blue dots, that help us follow it, especially when we are reaching closer to the nodule. This is the video that's showing is expedited a bit because for the time, and you can see we're going through the airways to get to that area. But just notice how the airways, all of them, even to the farthest part in the lung, maintain to be open. And that's what, even with using the PEEP, if the patient was supine, you can see them collapsing. So after we reach there, we put the needle, and then this is the cases that we repeat an extra spin, because really we are sitting next to the pleura, next to the liver, and the spine as well from the other side. Segmenting the needle, confirming that we are in the lesion, as well the projection of the scope. And it's important to see in different dimensions to confirm that the tool and the target as you see it. Also, give us the safety area that you are not hitting the pleura. Of course, adding the factor that we can do now the needle, and now it's augmented on the fluoroscopy that allow you to see that the projection of the needle going through it, the nodule, without any issue. The flow really happened by doing the needle multiple times in the beginning, using the cryo or forceps after that, but usually that's helpful when you are closer in those areas to help getting the sample. We did a total of 10 cases. You can see in the beginning, use it for 15 millimeter. One patient has 2 lesions on the lower lobe that we went after. That the one that the time was longer, around 1.5 hours, but average of 1 hour for the diagnosis with the staging EBUS, because the patient after the proning, we return back in a normal position in the cart and continue with the staging. There was an incidence of 1 pneumothorax. In the beginning, I did not do a second spin, and I was doing forceps biopsy that led for pneumothorax, but the patient discharged next day. But the yield was really out of 10 cases, all of them came with diagnosis. 1 case, based on the definition of yield, we got, instead of just throwing inflammation, but repeating the CAT scan, showed improvement of the size of the nodule as well. So what the challenging that can be counted for this and keep in mind, of course, positioning time might take longer time than driving the patient in, put him on the table, start the case right away. So we have that 10, in the beginning was 20 minutes, and now it's cutting down. Every have now the protocol implemented. Centralizing the lesion, that another factor will show with the pictures, and I'll mention why, because now we are dealing with the height of the table with the limitation of the robot that allow you to go with the height that matching that table, especially with the iron robot. And the length of the catheter, because we are going really deep down in the lung, and we have in our way, we have that extension of the ET tube, and the depth of the lesion we're sitting really need to drive that far. Of course, patients who had a cardiac history, we don't select them because in case you need to do any cardiac compressions, anything like that, we don't want to do anything causing. So as I mentioned now, the average time for positioning around 10 to 15 minutes. Centralizing the lesion, that's the fact that you can see on the left upper picture that the arm of the robot almost touching the base of the robot itself, that there's no more farther area that I can go down more. At the same time, I would be limited by the height of the patient, because you know when we prone the patient and it's posterior lesion, it's in the upper part of the body, it's not in the lower part. So now we are trying to match those 2 points between the robot and arm plus the lesion itself. Because in this position, you can see that where if I keep bringing the table down, I might not get the anatomy with the airways, but I can see the nodule. But that's where important to have both of them reflecting. And that's the same idea, arm almost not be able to go down more with this platform. This is another patient that has really more obese, but has this lesion also sitting in the same area. Even with the proning, if you look at the cone beam pictures, you can still see that there was some haziness that formed. So if I start this case with normal position without proning, absolutely I will be able to lose that area with that type of lesion. And when I mentioned earlier the length of the catheter, because the driving that far, you will see always that accordion shape that allowed the catheter to go in, it will be limited with the 95 centimeters that can be eaten by the length. Some cases we don't spin one more time, especially if I get a good radial EPUS, like in this case. So we ended inside the lesion right away and the sample done without needing for extra spin, especially after doing multiple cases when we have the idea. This is the part that I was mentioning about the ET tube location and how much length come out from the patient, that you might need to add that extension to stabilize for the robot, that shortening the length of the catheter that we are using. And this is the same that you can see, all the cases we do, always we have more room for the catheter to go. In those cases, because we're going that far with that extension, really we hit the metal area there right away when we finish. So in summary, this really helped us a lot in practices, particularly for selective cases where you have the medial basal posterior supradiaphragmatic lesions. Of course, special selection of the patient should be considered. It's a teamwork, it's not one person, but that's why they have to have the same team using it every time. And utilizing prone positioning might also reduce the time of the navigation, but you have the time that you used for positioning. So it's very hard to judge that if this is the case that we will be implementing for multiple cases. So really it's very selective. And thank you so much for your time.
Thank you, sir. We would call on Dr. Gustav Cambo for his next talk on update on Monarch robotic bronchoscopy. Welcome, sir.
All right. Check 1, 2. Can you hear me from there? Good. Okay, 15 minutes. Is everybody tired yet? We have great presentations coming up, so I appreciate everybody's patience and willingness to grace us with your time. I think it's important to discuss that my conflicts of interest, particularly when we make statements regarding diagnostic yields and outcomes and quality. I am a consultant for GE and J&J Educational. And that said, what I'm going to do is I'm going to embark in the problem that you have. Asia has a huge problem with cancer. Lung cancer is very prevalent. Unfortunately, based on all the data that we read in, we see that oftentimes we diagnose cancer late. If you can see the developments of agents for lung cancer, there's an abundance of FDA approval in the US for late cancer and very few for early. So what we did in robotic-assisted bronchoscopy, at least in our perspective, is to capture patients and improve the diagnostics, leading to better treatment options and hopefully accelerated recovery. Then we do the best we can with the tools we have at hand. Definitely some of us robotic users believe in it, and some of the ones that have had great results, they don't feel the need to move forward in that direction. Unfortunately, the data that is out there has not been really convincing for us to continue performing bronchoscopy the way that we did 20, 30, and 40 years ago. Although I ask AI, I love AI. I think that that's the future of medicine in a lot of ways. And I said, can we really kind of figure it out? What is diagnostic yield? Is it appropriate? Do we have academic rigor and good criteria to say that a robot has a diagnostic yield? It sounds premature, it sounds hypothetical, but definitely there's a lot that goes into a diagnostic yield, and I appreciate Cecilia's lecture on diagnostic yield and our abundance of discussion. So thumbs up for maybe shining some lights on, we sometimes overshoot what do we think diagnostic yield and assign that to a piece of technology. So there's multiple factors that goes into diagnostic yield, and Cecilia's lecture on diagnostic yield cannot be improved, so I'm not going to go over that again. And definitely I appreciate, and I will borrow this from Kyle, when we diagnose lung cancer, the robot doesn't get you there. The robot doesn't tell you what somebody has. The robot gets you near your lesion. Whether it's tool in lesion, lesion in tool, or the final pathology, that's in and of itself the reason why we became pulmonologists or interventional pulmonologists, to tell somebody what they have. So in my opinion and in my perspective, it is not appropriate to assign a robotic platform with a diagnostic yield. It is not. Therefore, when we move forward and we discuss robotic, at least for the purposes of Monarch, and specifically talking about updates coming up in 2025, we made an abundance of updates that were just FDA approved, and you'll see a lot of very exciting changes coming into Monarch. So what we want from the robot is not to tell somebody has, that would be ideal, but to let me work in the space, get me there. So where are we? This is the Monarch for all of you that don't have the opportunity to have seen it firsthand. The Monarch has a couple of parts of it. It has a sheath, it has the scope, a couple of arms, a gaming controller to maneuver, and definitely it's a true bronchoscope in which there's an integrated working channel in which you can thread tools, a couple of LED lights, and an integrated camera. Therefore, we are able to exactly see what's going on at all times. So for those that are engineering inclined, definitely it's a piece of equipment that has been thought over many, many years. And for all of us that believe that this technology is the best in the market, we have leveraged all the options and features that it has to offer. Okay, probably if you're going to have one slide that you're going to remember is this one. I believe that Monarch is bringing a lot of heat to the robotic landscape and arena. We have updated algorithms. We continue leveraging uninterrupted vision, and by doing such, we can also target very specific areas that we're going to biopsy. It's going to be equipped with an NVIDIA chip, and we are going to have much more confidence on the mappings is the segmentation, the bronchial tree is going to be much more reliable, adding 10 to 20% to what we are right now. Integration with CONBEAM is coming, publications are on the way, and we're going to have a lot of upgrades when it comes to artificial intelligence in order to empower robotic bronchoscopy users in Monarch in order to get there reliably, accurately. Last but not least, it's a misnomer to talk about Monarch as an electromagnetic navigation platform. It has augmented navigation that relies on many other features, as in optical recognition, kinetic data, and more that is about to be announced by the company. And we're going to have a lot of gateway optimization, which is really software and databases in which we could extract as much procedure-related information as we want in order to benchmark against others and even extract video in order to do education. So some of the improvements as we talk: better segmentation, artificial intelligence, way faster procedure times, and chips in the robot that is going to make it much more reliable. The features of Monarch have been reach, vision, and control. I cannot emphasize enough how important it is for me to be able to get farther, be able to see throughout, and control exactly where I'm going to do the biopsies. There was a little bit of talk about how far can the robots go. We have published this many years ago about reaching. Are you going to get to the pleura in every case? Absolutely not. Does it reach more than conventional bronchoscopy? Yes. Do I like fiber optic bronchoscopy? Absolutely. I prefer doing cases with fiber optic and radial than doing robots. Most of our cases are decided by a tumor board, and I will be more than glad to point you to my papers in order to see my criteria for robotic bronchoscopy after 1,000 cases. You can see this was one of our first papers in which the reach of the Monarch is pretty far at the right costophrenic angle. So I challenge the principle that size matters. And again, AI. What is the size of an airway? Whenever you think about airways, they're very small. Whenever you get after the 5th generation, the diameter is 3, so there's no robotic bronchoscope that is going to get reliably, reproducibly after the 5th generation. And definitely there's a little bit of wiggle room that you have to leverage in order to throw the instrument. It's not that you have to be on the nodule. And if I learn something by leveraging CONBEAM in a lot of cases, is that I have to be a little farther from the nodule in order for the tool to do the work. So I like to see where I am. I like to see where the radial probe is giving me some sort of image. Whenever you have ultrasonographic images consistent with maybe an extrinsic lesion, I like to put the needle exactly in the area. If I don't see, I'm not confident that I am where I should be. And by controlling with micro adjustments of the Monarch, I'm able to biopsy different areas, and two things can be true at the same time. You can have granulomatous inflammation, you can have atypical cells, you can have granulomas, you can have infection. So I biopsy always in different areas within 1 millimeter of each other to abundantly sample anywhere from 4 to 6 aspirations per area that I'm going to biopsy. So this is a video of the Monarch. I heard before that it doesn't get past the 4th, 5th generation. You can see the video that shows you that with the sheath that is 6 millimeters, we can go probably 3 or 4 generations. Every case? No. More than 80% of the cases? Yes. And after we feel that the 6 millimeter is too big for the airway, remember these patients are all on positive pressure, intubated and paralyzed, we can unleash the bronchoscope, which is 4 millimeters, and park it pretty close to wherever we want to go. So does size matter? Yes. Does it matter to the point of choosing the robotic bronchoscopy platform? I challenge that. These are lesions that are not difficult to get with robotics. They are really not. And to get, that doesn't mean to diagnose. One of my papers is 100% Tulane lesion with a quote-unquote diagnostic yield of 70%. I think that Kyle feels my pain about fungal, and that doesn't mean that the robot didn't do the job. So I think it's adventurous to assign a robot with a diagnostic yield when there's so many confounders going into diagnostic yield. And we should not, among doctors, get into this conversation about which robot is better, because sometimes what we're talking about is how are we doing? Is it a sampling error? Is it a pathology problem? Is it endemic? So I love that we were talking about, is it easy to do? Yes. In my opinion, and I really hope that those that are going to consider robotic bronchoscopy have a little bit more trust that we expect you being better than us. We want you to train to be better than us. This was my initial experience in 2018, my first 20 cases. It really went well, And definitely this was part of a larger publication with 3 of the other robotic bronchoscopy users that started Monarch back in 2018. And I'm proud to say that it worked out really well, and to this date, we continue gathering data. So we think that it's effective, it's safe, and we are learning how to do it better and better and better. We should learn from every case that we do with robotic bronchoscopy. Now, proficiency, as others have said, 5 to 10 cases in order to reach basic competency. After, sure that we can go after most of the lesions, most nodules. I do not use Monarch to go after masses. And definitely, I think that is more important about where the nodule is as opposed to size or airway sign. I also heard that there was some talk about airway sign being associated with diagnostic yield. Again, let's talk about sampling, let's talk about etiologies, let's talk about operator experience, and the like. I have my data extracted independently. I don't have a publication bias since I don't have a say in what goes into databases. So 3 of the programs that we have the largest volume in the US, all our data was extracted independently, and we can see a little bit of how well does Monarch work in the real world. And again, this is talking about diagnostic yield with different definitions, and I don't think it has a lot of academic rigor to put a lot of things together and say this robot works better. I really don't. So these are our numbers when it comes down to our diagnostic yields and sensitivity for malignancy, and I invite you to read the paper. Monarch literature talks about diagnostic yields anywhere between 84 and 91s, and definitely there's others that are lower, and maybe others that are higher that are not publishing data. Remember that we have publication bias, and remember that some academic centers have different structures in order to report the outcomes. Very briefly, surgical inking, positioning, driving, getting next to the nodule or close to the nodule, and then marking the visceral pleura. It's important to know if we're lateral, anterior, or posterior. Again, the question is how far Monarch reaches. I think that a picture speaks 1,000 words, but definitely we developed a protocol, put a methylene blue right underneath the visceral pleura and indocyanide green to use the Firefly probably a few millimeters under in order to diversify the investment. And if we went too deep or too narrow, at least we have some sort of breadcrumbs for the surgeon to wedge with the diagnostic intent. We publish all this data, and definitely we have 100% tooling lesions if the lesion is what we ink, and accuracy where the surgeon in all the cases was able to have the specimen containing the area of concern. We did an initial publication, and we're coming up with a follow-up publication with 200 cases plus. This is very convenient. This is what they call the single event anesthesia, and definitely something that we encourage those that have the possibility of moving forward with robotic platforms to consider for their hospitals. CT integration, precision, accuracy, reliability, they're not interchangeable. Precision, it's really how consistent results are, and accurate is how accurate they are, how closer to the center. So discussing with some of my colleagues, we believe that tooling lesion is a better surrogate on how well a robot works, and we should refrain from assigning a robot with diagnostic yield. That is an aspect that is not pertinent to us as academicians. Previous publication in which convenes, if you are miss or off target, it may get you an off center, and if you're off center, you can do a center hit. Is it important to be in the center for diagnostic? Probably not. Is it important for therapeutics? Probably yes. ConBeam, not only the robot got you there, but now ConBeam is going to provide you with confirmation in real time. 3-5 years ago, I had pretty heated discussions with some colleagues in which they said I think that discussion may be over, although I welcome academic discussions. We have a lot of information about fixed systems and mobile systems. I have the 3 of them. I have a fixed ceiling mounted, I have a Siemens, and I have GE. We all have preferences, and this is not a forum in which I'm going to try to convince you that one is better than the other. I don't think that this is the reason why we take the podium. We're here to share our experience, and you make your own decisions. Definitely, there are some platforms, for example, the new OEC 3D from GE incorporated lung suite, where you have augmented fluoroscopy and segmentation, which is some of the features that Philips ceiling mounted with EMBO suite has developed a couple of years ago. So mobile system, I believe that they may be the future for some IP programs in the country. They have been innovating, GE, and mapping virtual segment of the airway in order for worldwide non-robotic could potentially have breadcrumbs, leveraging an OEC 3D to get from insertion in the trachea to the nodule. Is it necessary to have it to perform bronchoscopy? No, but for all of you that would like to have some breadcrumbs to get too close to the target, it is being developed for GE 3D. I love the differences between the different platforms. One of my preferences is based on the quality of the image. The smaller that the arm, the better quality. Those are physics, and you can see left and right, before and after. Definitely a left upper apical lesion. It's very easy to be achieved and reached and sampled. So to the left is a multi-slice, to the right cone beam, and definitely is my go-to for challenging cases. Some differences in the and definitely two of the cases that were diagnostic. So by all means, explore if you're looking forward to moving into a cone beam space. Therefore, we will be glad to discuss pros and cons of each. I don't think that this is the right forum to do that. And to wrap up, and hopefully I am under 15 minutes, the future direction is what we all hope for. To be able to diagnose, stage, and treat in one setting. Somebody goes to sleep with a nodule, wakes up cancer-free. Are we going to see it in a lifetime? I hope that the answer is yes, but definitely through education, we can hopefully reinforce the many benefits of the next generation, which is all of you, to maybe make it a reality for patients. Last but not least, I want to thank the organizing committee for this massive amount of work. It's very, very important what you're doing, which is empowering next generation through education. To Yashoda Hospitals for being able to provide us with all of this knowledge through friends that we are making in these meetings, specifically Harry, Radna, and Dr. Kumar. To the three of you, heartfelt thanks, and I look forward to the next meetings. Thank you. And for all of you that want to know how a migrated stent looks, and until we can announce the next one, I will be glad to show some advanced uninterrupted vision images. Thank you again.
Thank you so much, Dr. Gustavo. To wrap up this session on peripheral bronchoscopy, we now have a final lecture by Dr. Kyle Hogarth. This is going to be on update on the second generation robotic bronchoscopy.
Sorry, I'm back. You're stuck with me again. Start off by saying my conflict of interest, I am a consultant for the manufacturer of this device, Noah Galaxy. But anyway, with that, let's get launching. So when you look through the literature, the promise that the first generation of robotics had, that at the time had no integrated imaging, was that with stability and further reach, that we would all see an improvement in yields. And if you look through the papers, and the only one that gets brought up sometimes is the Ben paper there with an 86% yield, but again, that was on larger lesions and had cone beam with it. The yields just weren't there. And so, and you go back and with these two robotic platforms, and just focusing quickly on the ion data without advanced imaging, the yield's not there. So these were very expensive devices, and they weren't getting us what we needed. Now, when you add advanced imaging, and I think earlier during the debate, Stefano asked a very good question about whether or not, is it the imaging or is it the robot or is it both? And I don't think we definitively know that, but I guess it would be implied when you start to look at imaging-only platforms that are not robotic-based, whether that's a thin scope or whether that's even a blind catheter being just pushed, we start to see how much advanced imaging makes a difference. And this literature here would at least ascribe to that when you see a marked improvement in outcomes with this one particular platform with image addition to the robot. So the problem, of course, why does this happen? Why didn't we get where we needed to be? So I'm going to show you a perfect example of CT to body divergence. Before I start this video, what you're looking at, this was the last Monarch case that I performed, and the lesion actually happened to be in the, we all physically can see it there. It's right there in front of us. Now, of course, frequently it's on the other side of a wall, right? So I'm out fairly far, and you can see it, and yet the computer thinks I am nowhere near it. The target, they think, is off a little bit further to the side. Because remember, all of these, and this is across all the robotic platforms, and I'll show you again more later, where the target is supposed to be based off of preoperative CT, airways have moved. The lung has been distorted. It's being altered by our catheters. It's being altered by atelectasis. It's not just an electromagnetic thing and or an optics thing. Shape sensing was supposed to fix this, except it didn't. Here's a perfect example with the ion where that purple ball, you're right in front of the lesion, except under cone beam, you are nowhere near it. So you have to make massive adjustments. This is why the yields were not good. And it turns out that the CT to body divergence is very random. It's profound at times, 10 to 35 millimeters. Literally, you are biopsying nowhere near where the computer is telling you where it should be. So this, again, comes back to a strong argument of understanding your anatomy, that combining robotics, say with bronchial branch tracing, is an interesting idea, so that you can track exactly where you need to be. But even again, when the lesion in its exact relationship to the airway, especially when it's on the other side of the wall, has not always been easy to do. And why does this CT to body divergence occur? Again, remember, we've registered off of central static airways. We're developing atelectasis as soon as you've intubated that patient. There's tissue distortion from the catheter system in the scope. If you add any hemorrhage from a biopsy, for sure, not necessarily bleeding per se in the sense, but micro pleural effusions, changes in the anatomy, etc. Oh, and that CAT scan, of course, was done on a wide-awake patient at total lung capacity with their arms above their head. Now their arms are at their side, they're paralyzed, they're sedated, they're intubated. They're not remotely the same shape of chest and lung. You've altered too many things. So then, of course, everyone says, well, I'll just bring out my radial probe. That's real-time guidance. Rebus is only lateral looking. Images lack directionality. So, of course, unless you can see directly where it's touching, you don't know that that lesion's, quote, off to the side or not. A non-aerated lung, an atelectatic lung, and hemorrhage can produce a very similar pattern. And these false positive images can result in inappropriate confidence that you are where you think you are. So is that tumor? For both of these, the answer was no. This is atelectatic lung. Sure looks like tumor to me. Take your cryobiopsy and add to the blood, right? So there's the problem. So what do we get from this data in the past? The average diagnostic yield without advanced imaging, but when you add advanced imaging, you do fix a lot of the problems that were inherently built into the first two robots. Now, the second generation robot has the same problem. It too has CT to body divergence, but it's all about how do you overcome it. So I'm going to introduce you to the Galaxy system, and what's unique or different about this one, similar to the Monarch, it has always-on scope visualization. So at all times, you'll notice that every video you've watched of robotic systems with the ion, the video shuts off when it's time to take the biopsy. That's because you have to remove the optics. And so you are once again blind. Always on visualization, a very important tool, as Gus pointed out, with the ability to see your tool interact with the tissue. That integrated imaging, though, for tool and lesion confirmation with any fluoroscopic system that exists. Whatever you have, it will work with it. It was nice to hear that some of these other systems are integrating finally with specific systems. Wouldn't it be great if they integrated with all the systems? It's also a disposable scope. So you have no issues with cross-contamination. You have no issues with how much it costs to process and clean, as well as the amount of chemicals involved and the time involved and the staffing involved. And it has an extremely small footprint that doesn't take up much space in your lab. So this allows you to see tools penetrating walls while targeting. This allows you, I showed this video earlier, to see the holes that you made, to then pass additional instruments. I'll use this as an example because after we've made this diagnosis, let's assume that we're in the era where we're going to be definitively ablating this. I'm going to get my catheter right through that hole in the middle of that thing and then ablate it, theoretically. So how does this work? So in this example here, because the core to this robot is the tool and lesion technology called TILT. And it's an augmented fluoroscopy system. Now, this is a cadaver, and you can see the lesion. It's solid. It's a fake lesion. And obviously, you wouldn't need anything special to see that. We can all see it. But a majority of the time, of course, I think we would all agree that we see nothing on fluoroscopy. We do not see the lesion. So you do a 60-degree sweep with a standard C-arm. You then point where the scope is, and then after that, you highlight the lesion, and from then on out, you get a blue circle around the lesion. And of course, again, we can all see the lesion, but if that lesion was fluoroscopically not visible, you know exactly where it is now at all times. And of course, the ability to see from the side, difference. No, this is not mom eating her baby. It's just that you looked at it from another angle. And so here's a perfect example. This is a standard AP view on the left. We're in the lesion. That's tool and lesion. Oh, look at it from the side. No, it's not. And one of the things the robot does is also quantify for you just how bad you are, that you're almost 20 millimeters from the lesion, anterior to it. So it allows you to obviously make your immediate adjustments. Now, in real world, what does that look like? So this was a larger lesion, but I'll show it to you. This is the standard CT view. This is the tomosynthesis view using a standard two-dimensional C-arm. You can mark your lesion, and after you've done that, it's going to allow you to update it. And then you can do it again with your tools out. So if you have any debate, did I biopsy the correct lesion? Am I dead center? Yeah, you're beyond dead center. In fact, I'm exactly 0 millimeters away from where I wanted to biopsy. So this idea, again, there's the lesion, there's your tool crossing dead center through the middle of the lesion. I presented this earlier, but this is the data from Taj and the group out of Australia, the first in-human evaluation of the Galaxy, because I want to get into data now. And you see, obviously, the diagnostic yield as reported, as well as, obviously, the data from Sesania and Federbush as well, highlighting, again, smaller nodules, peripheral nodules with high diagnostic yields, achieving what we'd all hoped to achieve by allowing us to image integrate with any platform with the robotic systems. Well, let's break down the Sesania study a little bit more. So it was 116 nodules in 100 patients, and one ultimately was removed from the analysis due to being, it was just for a fiducial mark. It's not really. Joe's group, the average nodule size was 13 millimeters. So I think one of the most exciting things that's been part of everything happening in this space, regardless of platform, has been the steady move towards smaller and smaller lesions. And 77% of the nodules were less than 20 millimeters. 10% were less than, or that's a typo, were less than 10 millimeters. And then 12% were GGOs, 26 were part solid, and then the lobe distributions all over the place, I think important, very real world. And the key thing, 78% of the data we're talking about is in the outer third of the lung, arguably one of the more challenging regions we need to get to. Because obviously in the inner and middle third, that's where we've seen a lot of great discussions on using, linear EBIS, for example. You don't need a robot to get the middle third, per se. There will obviously be individual scenarios, and sure enough, Joe's group, majority of the samples have been in the outer third, including 15% on the pleura. And as much as everyone's talked about, and Pallav talked about using needle biopsies with radiology, the biggest flaw that we see with that approach in the United States is that no one then stages the patient. PET scan is notorious for understaging patients. And our thoracic surgeons will not resect someone until the lymph nodes have all been sampled. So when a needle biopsy occurs and proves cancer, that doesn't tell me anything until the lymph nodes are sampled. So the value of the robotic systems, all of them, is the ability to make a biopsy and then stage all in one setting. I think the other thing, of course, is that there was a low radiation time and low dose using a standard C-arm. And they did 2 sweeps per nodule. They did a tool and lesion. You don't even have to always do that, so you can actually usually get a much lower sweep. So using a strict definition, as Joe pointed out, 90% diagnostic yield with a malignancy rate of 77%, the remaining histoplasmosis endemic in that part of the United States, with a high diagnostic accuracy and tool and lesion in 98%. Of the 12 non-diagnostics, 8 had follow-up. 1 was a false negative for cancer, okay? All the chronic inflammation, that is, you missed, all of them showed stability or regression. And I think one of the key things that Joe has talked about earlier as well, I think we all have this, is what is your clinical negative predictive value? Forget all the papers you're trying to publish. I need to know I was in the lesion, I made a biopsy, I got a patient I got to advise. It's easy when you find cancer. It's easy if you find tuberculosis. But what if it's non-specific? What do you do? How do you advise that patient in front of you? You need to tell them what you need to do. And what Joe and others, and myself included, have been able to show people is that using this system, we've been able to prove that we're in the lesion, and if we don't see cancer, obviously there's one, that there was a follow-up on cancer, that you have the ability to comfortably tell the patient to watch and wait. Now, when you look at this compared to other robotic bronchoscopy using strict definition criteria with no image guidance, you see the various yields, and even when you start adding in fixed cone beams and mobile cone beams. And again, some of this has a lot to do also with radiation exposure, but also cost and accessibility. Remember, for all those cool studies you see with everyone's cone beam systems, most bronchoscopists don't have access to their cone beam system 5 days a week. But we have access to our bronch suite 5 days a week, and we have access to our C-arm 5 days a week. And that's the power of digital tomosynthesis. Obviously, benefit to targeting and tool and lesion. We've seen this with others. This matters. You need to be able to prove you're in there. And then nodule size, I think the real key thing that Joe showed is that there's no dropout for nodules. Their yield, majority of what they were sampling, were small. Now, one of the other strengths of this data out, because this comes up, is this reproducible. The Cleveland Clinic data is 4 separate operators. So it's not just Joe, right? It's multiple people at the Cleveland Clinic. Although very experienced, that's definitely arguably one of the weaker points. It's not that all of them were novices, but there's 4 excellent endoscopists. There was consecutive procedures, so none of this cherry picking, none of I chose the next 10 easy cases. It was what came through the front door. And it is a large cohort. And the average nodule size was smaller compared to all prior studies that we've seen. And diagnostic yield was not impacted by this. A lot of prior trials with robotics demonstrated a drop-off once you started to get too small of a lesion. Now, what about GGOs? So here's a case example of a -511. I showed you one earlier. There's a bunch more of different Houndfields units. 565. You can all see this with simple 2-dimensional C-arm tomosynthesis. So what about cone beam versus tilt? So ANOVA, where Bobby Mahajan works, already had cone beam. So there's the great view you get with the $1.1 million Philips Azurion cone beam CT spin, tool and lesion. Here, the GE 9900 that Bobby's hospital already owned for the last decade, there's a tool and lesion. So after you've dropped $600,000 to buy your robot, the idea that you have to then go drop another $1.1 million to make it work is as offensive as it sounds. So let me show you our first day of cases. This is, at the time, our interventional fellow, Nakul Ravikumar. He's out in Western Massachusetts. So I got asked to do an easy case for my first case, so instead I chose a 9mm lesion on the diaphragm. And this woman had infectious risks and cancer risks. And from the PET scan, they couldn't tell if the nodule lit up because there was so much liver background noise. So there we are at the stage of doing our tomo, and that is just a simple C-arm. I'm the one actually spinning it because the fluorotech didn't show up. So there's me, the fluorotech. And then, oops, hold on. All right. So now it's time to pick the lesion. There's the CT. And then we're going to adjust the brightness and contrast. Oop, there's our lesion. Now, I want to draw your attention to the fact that my scope isn't actually even pointing at it, despite the fact that I drove my scope to the target. We know how bad CT to body divergence can be, especially in the lower lobes. This was great work that Mike had done in the past, showing up to 18 millimeters of CT to body divergence. That's going to be the big difference in biopsying a 9mm lesion. Plus, I really don't want to find liver cells on my biopsy. So we're able to mark it. And what that does then, I'm going to draw your attention to the video. And sorry, this was just taken with my iPhone. So we're off target right now. Turn off the fluoro. And there you can see my instrument going out. There's my always on scope. Then what we're going to do is spend time with fluoro off still, moving the target to dead center, and then we're going to turn on fluoro, and you're going to see that my instrumentation's right in the middle of the blue ball. And unfortunately, this was metastatic breast cancer. I'm going to show you one more for the whole highlight of really knowing that you have tool and lesion. This was a 12-minute case, 9mm lesion right next to the SVC. I'm targeting, I turn on tomo, or turn on fluoro, and I'm in the circle. It could be behind it. So I'm going to look at another angle. Nope, still in the blue circle. Look at another angle, still in the blue circle. And one final angle, still in the blue circle. If I'm in the circle in all three planes and I mark that lesion, it's the first time ever that I know exactly where the thing is, and of course was cancer. And then lastly, I want to show you one of the cool things about having optics while you take a biopsy. So we have a technique where we put our needle out, especially if we're in the periphery, and we move up and down and dissect away the airway. And so what you see there, and we're out where this is located, we're in the right upper lobe, and we're essentially where the fissure and the pleura meet. I know the fissure is pleura too, but right in that corner. And there's the lesion. Literally the lung cancer staring right at me. You see some vasculature cutting across the front. You also see a couple areas of necrosis. So I want to take some biopsies, and I'd like to actually be precise about it. Because robotics should be precise. The beauty of it is and the elegance is the precision of the movements. I want to use my eyes, and I'm going to put my needle exactly where it belongs. Because if I get necrosis, that's not an answer. In fact, as Joe already highlighted in his study on yield, it's considered non-diagnostic to get necrosis. And see the white cheesy stuff? That was my first biopsy, which was necrosis. So I move my needle with the precision that one would want to know exactly where you need to put that instrument. And I can watch that it actually penetrates into the lesion. So our internal data, this has not been published, so feel free to not believe it. Our diagnostic yield is currently at 94%. Our case times range broadly because we have fellows. So when I'm by myself, 40-minute cases. When I'm letting my fellow drive the whole time, they're 40-minute cases. But we're biopsying things that are mostly less than 20 millimeters, similar to Joe. 34% of our lesions are less than 10 millimeters. Most don't have a bronchus sign, and as highlighted, a majority of them are actually in the outer third of the lung and even on the pleura. And then here's what's happening in the next generation. So the tomosynthesis has already been updated 3 times. So this is a nice slide from Chris Badra. And so when I hear always that I have to have cone beam, and this is not, Chris has cone beam, this is only a 60-degree sweep. I want to draw everyone's attention to what you can see and what you can do, and why tomosynthesis, and the computing power to take simple 2-dimensional C-arms and give you definitive 3-dimensional proof that you're in the middle of the lesion. So I'll end with that, because that's the future. And I'm not even sure I was supposed to show those, but the company's not here, so I'm going to show it. And end with my slide with my information. So thank you so much for your kind attention. I appreciate it. I'm happy to talk or answer questions. All right. Thank you, everybody.
Thank you, sir. We now move on to the next lecture, that is the Management of Tubercular Tracheobronchial Stenosis by Dr. Jamsak Sheneuka.
So we will shift the topics out of the lungs to the bronchus. First, I would like to thank the organizing committee, especially Harry, for inviting me to this great conference. So my task is to talk about tracheobronchial tuberculosis. Have no conflict of interest. First, we have to start with the definition. Tracheobronchial tuberculosis, you can make a diagnosis from the histologist examinations of the bronchoscopic, obtain specimens showing granulomatous inflammation or the positive acid-fast bacillized by cultures. The prevalence is around 10 to 40% of pulmonary tuberculosis. But the cause of the disease is highly variable. This is the examples of the biopsy specimens. So pathogenesis, it's supposed to first direct spread of the tuberculosis bacilli from parenchymal tuberculosis or cavitary lesions which contain abundant tuberculosis. All disseminations of tubercle bacilli from bronchial lymphatic channels, draining pulmonary tuberculosis, or spreadings from contiguous mediastinal lymph nodes to the bronchial mucosas. Lastly, it can directly implantations of inhaled Mycobacterium tuberculosis into the bronchial wall mucosas. Patients can come in with two forms. Firstly, he has or they have active disease, which is the active caseating material oscillations of generations tissue formations with histology finding of caseous necrosis and positive tuberculosis bacilli. Or they may come in with the fibrosis seen on bronchoscopic view or biopsy confirmed without positive acid-fast bacilli. We all know that left main bronchus has most frequent involved because of the anatomical compressed by the aortic arch, or it's made longer, and the left pedestal lymph node infected faster than the right side. In terms of the diagnosis, if the patients came in with a female, younger, came in with a cough, weight loss, and hemoptysis, chest pain, and dyspnea, so we consider they might have endobronchial tuberculosis. And the common coincidence with parenchymal disease, usually it's young girls. They can be misdiagnosis for asthma with the yeast. The sputum FV positive is around 13 to 50%. The skin test is positive around 60%. If the interferon gamma release assay was done, the sensitivity is only 64%. The upper airway needs to be narrower than 8 millimeters before the symptoms happen. So in that, the peak flow will decrease to 40% with airway resistance increased. And FEV1 still at 75% predicted. So the PFT can make us diagnosis late. Also, the chest X-ray can be normal in 10%, but mostly you can find pulmonary infiltrations. In found 60% of the parenchymal infiltrations with 24% lost volumes. You can find post-obstructive pneumonia and also atelectasis. CT scan can show you a lot of information in terms of the extent, length of the airway involvement, and parenchymal distal to the involved bronchus. You have to differentiate the active from fibrotic stage, in which CT scan can guide you, like you see the airway wall. If you can appreciate the airway wall, if it's thick, it can be the active disease. Also, the parenchymal lesions, if it's more peripheral infiltrate, it should be guide you to the active disease. If the wall thin, you can say that it might be the fibrotic stage. This is CT scan features that predict the outcome of the interventions. If the patients have parenchymal calcifications or bronchiectasis, it will lead to the failure. It means that it looks like if you have damage of the parenchyma, also the longer infected before, it leads to the failures of the treatments. Like in these patients, you can see the thickening of the left main that was collapsed, and also the collapse of the left lungs. And by pay attention to the lesions that you see. This is not a bronchiectasis. It is just mucus in the bronchi. So in these lesions, when they put the stent in, the left lung can completely ventilate it. In this case, you can see the calcifications and also the atelectasis of the left lungs, and even they can demonstrate the losing of the left mains, and after they collect it with a stent, the lung doesn't have good re-expansions. This is a famous articles from Chung from Korea that demonstrate to us the different morphologies of the endobronchial tuberculosis, which you can appreciate that there are many groups, and you cannot make a diagnosis only from the visualized from endoscopically. The outcome predicted of these pictures, this involvement is changing over time during the treatment. So the lesions will be fixed in 3 months after you started the treatment. This is look like a tumor, and this is a fibrostenotic type, and this is also the fibrostenotic type. This is also the granulation type, and which you can see the parenchymal involvement. This is also the stenotic type, and the tumorous type, which cause the stenosis of the lower lobes. Also, as I mentioned, the lesions change over time. So you can hardly predict it, which patients before 3 months, whether they will go to the airway stenosis or not. In terms of the management, first you have to eradicate tuberculous bacilli and prevent the stenosis. The old studies, they found persistent bronchostenosis after treatment in 41%, especially in patients who had age more than 45, has pure or combined fibrostenotic subtypes at the beginnings, and durations of the symptoms to starting anti-tuberculous drugs more than 90 days. In these studies of Chung's, he found that if you see the lesions in endobronchially showing active caseating edematous hyperemic fibrostenotic tumors, it guides you that patients will develop bronchostenosis in 50%. But if the lesions show granular ulcerative non-specific bronchitis, only 10% develop bronchostenosis. If patients come in with the active stage, you have to control infections and prevent stenosis. In this particular patients, steroid doesn't have any benefit. If patients come in with fibrotic stage, it has no benefits. You have to give the patients anti-tuberculous chemotherapies for more than 3 months before you evaluated the real stenotic areas. So if you want to do the patients came in with symptoms, you want to do surveillance, if you found stenosis, you can do a balloon dilatations first, and then evaluate whether you have to put a stent in or not. With the other things that you can do, whether it's a lasers, argon plasma correction, cryotherapy, or ultrasounds to evaluate the cartilaginous structures, depends on the case. Iwamoto, in 20 years ago, he followed 30 patients and find out that 5 in 11 patients success by repeated balloon dilatations. So balloon dilatations alone is sufficient in 30 to 40% of the patients. If you can do radial EBUS and found out that the cartilage is also involved, so it means that you might have to put a stent to the patients. And the recommendations of the stent is silicone because you can move it afterwards. In this big series of 80 patients followed up for 4 years, he found that the trachea size average around 9.5 millimeters, with the bronchus size average around 5 millimeters. They put silicone stents in most of the patients, 94%, and the stenting removal can be success in 54 cases, 72% in 14 months, with the stable of the lesions in 36 months, and 5 require re-stentings. And with the follow-up of 41 months, only 3 patients go for surgical resections. And this is just what we have said. So the case that need prolonged stent placements usually have lower baseline FEV1s, need more interventions, coming with the generations tissues and restenosis. Only 10% has major complications such as massive bleeding, pneumothorax with no mortality. This is a small series with 7 patients, also show that mostly patients can end up with dilatations and also stents with no mortalities. They can find good durations for stent placements, but the attempt of remove stents occur in 8 to 16 months. This is studies from China demonstrate what is the appropriate sessions for only balloon dilatations, and this is the case, and they around 4 to 5 times of balloon dilatations will give you the maximal response, around 81 to 88%. And this is examples. You can come in with total collapse, and after treatments, the lungs slowly expanded with the stent placed into the left main bronchus. This is articles from Korea, from Professor Ho Chong Kim. He has studies the case that he put the stent in and wants to remove the stent. He has 226 stable patients. 285 cases with the first attempts, and 59 has to be put back the stent in, and he can find factors that relate to successful stent removals. In his articles, the age, if you have older age, older, they are more successful. If you are male, you have more successful. If you have parenchymal calcifications, segmental consolidations with bronchiolith, so you have less likely to be successful as previous studies. Also, if the lesions is in the bronchi, okay, you have more successful. If the lesions is in the trachea, you have less successful for removal of the stent. And the timing that you have a much successful removal of the stents is around 1 to 2 years. This study can tell you that numbers. Bronchial tuberculosis in children is very rare, and I can find only these articles which retrospectively studies only 45 cases and 13 cases that have endobronchial involvement, which age around 3.9 years. And only one case, which is a 7.7%, has bronchial stenosis that need balloon dilatations. Others' involvement can be healed and less likely need some interventions. So it's quite rare. And this is the examples of the endobronchial tuberculosis in children, in which they can just remove the clot that and do one case that was done balloon dilatations and successfully. So in conclusions, endobronchial tuberculosis is very difficult to diagnose. You can't make guess in patients who come in with unproportional cough. If you see the small lesions in the lungs, but the patient still cough after treatment, or starting to have dyspnea bronchitis from physical examinations. If the patients come in active phase and no symptoms, even you know that they have endobronchial tuberculosis, conservative management is preferred. You do a lung function after complete treatment and bronchoscopy if indicated. If patients come in with symptoms and active phase, you can do a bronchoscopy, evaluate the lesions, you can biopsy to make sure that it's still active, or if the lesions is severe enough, you can do a balloon dilatation even in an active phase. If patients come in with fibrotic phase and no symptoms, but has lung function impairments, whether you want to do interventions, it depends on the discussions to the patients. If patients come in with symptoms, you do a bronchoscopy, you make sure that it's a fibrotic phase, and then you do interventions, management. If you see no lumens at all, I suggest to consult for the surgeons to do a surgical corrections. If the lesions is simple, mean it's less than 1 centimeter involvement and only one side, especially if it's the web size stenosis. So bronchoscopic interventions is indicated, but in some places you can talk to your surgeons whether they can. But if the patients come in with multiple lesions or lesions longer than 1 centimeter, you can do a bronchoscopic interventions with dilatations and balloons as needed. Thank you.
Thank you, sir. We now move on to the next set of lectures that will be focused on lung transplant. For the next lecture, may I call upon Dr. Shaf Keshavji to give us an overview of 30 years of lung transplant, a surgical journey.
My slides up, please. Thanks. Great. Well, thank you for the opportunity to speak to you. I was asked to speak about 30 years of lung transplantation, and it's actually been 40 years since we did the first successful lung transplant in the world at Toronto General. I do have a number of disclosures related to companies that I've spun out of the technologies and science that we've done in our lab for ex vivo perfusion that I will be speaking about. And also we've had a number of industry partners over the years that have helped us to carry out the trials and the work we've done. So the gentleman on the left was the first successful lung transplant in the world, performed in 1983 at Toronto General Hospital. In the middle was the lady who got the first double lung transplant in the world, and on the right, the first successful lung transplant for bronchiectatic lung disease. The fellow in the middle received a bilateral lung transplant in 1988 for cystic fibrosis. And since then, we've done a fair number of transplants. We're actually almost at 3,500 lung transplants in Toronto. 96% of these are first-time transplants, and 4% are retransplants, whether that's a first or second or third time transplant accounts for about 4% of our activity. When you look at the total experience in Toronto, you can see the vast majority are bilateral lung transplants at about 85%, 15% single lung transplant, 1% heart lung transplants, and then a few lung liver and lung liver pancreas and lung kidney as well. So when you look at our annual activity, we now do over 200 lung transplants a year, and you can see the majority are in bilateral lung transplants, some single lungs, and 1 or 2 heart lungs every year. If you look at our overall experience in lung transplantation, you can see that about 45% are interstitial lung disease, 30% are obstructive lung disease, and 15% were cystic fibrosis. But when you look at the trends over time, you can see we used to do 25% lung transplants for cystic fibrosis, and currently we have no one waiting on the list, and lung transplant is not an indication for cystic fibrosis pretty much. The number of patients requiring lung transplant for interstitial lung disease continues to grow around the world, and it accounts for about 60 or 65% of the transplants we perform each year now. The single lung transplants have increased over the years. Primarily, the indications for single lung has been IPFs, and it tends to be the older people with IPFs that get the single lung transplant. Again, in the pediatric group, we've done about 80 kids. About 40% of them were cystic fibrosis. But again, if you look at the trends over the years, there are very few transplants needing to be done for cystic fibrosis now, and the majority are pulmonary vascular diseases. I think this is a pretty important slide in that we've continued to push the boundaries to increase the number of transplants we can perform, even though the number of organ donors has been fairly static. But we have decreased the operative mortality from the true operative mortality that it was in the 80s to now less than 1.5% operative mortality. We have a less than 2% incidence of airway complications needing a dilatation or a greater, and we do over 200 lung transplants per year at Toronto General Hospital now. The survival for lung transplant clusters around the same outcomes, except you'll see that if you're going to meet a patient 30 years or so after a lung transplant, it's more likely that they're a pulmonary cystic fibrosis or a pulmonary hypertension patient. And the lung transplants for cancer have about 50% of the survival at each time point that you'd look at it. Looking at the older people or transplant by age, again, they tend to cluster. The young adults, 19 to 30, do best, and the patients over 70, while they do equally well coming out of the transplant because we select them very carefully, I think they do die of old age anyway over time. And here again you can see that the survival curve for the patients over the age of 70 certainly does start to drop off. I think one of the biggest parts about the journey of lung transplantation is the lung preservation concerns. And I think it's very important to take into consideration the lung was the last of the major organs to be transplanted, and it is very important to remember the donor considerations, the anatomical considerations of the lung, both the parenchyma and the bronchial circulation, whether to flush or not, what the optimal solution is, the temperature, whether to inflate the lung or not, how much, or what's the optimal FiO2, the storage temperature, and whether to use static or dynamic perfusion for the lungs during storage, and the preservation should be continued at the time of transplant. Surprisingly, the first successful lung transplants were performed, and at that time they were just using topical cooling, so they deflate the lung and pour ice slush into the chest to cool it topically, and that caused a fairly severe reperfusion injury, even though the ischemic times were very short and the recipient was across the hall from the donor at that time. It's important to understand that the lung is a very fragile organ, you all know that, and it has a dual blood supply, that is the pulmonary artery and the bronchial arterial circulation. But the lung also has an anatomical advantage that it can derive oxygen directly by diffusion from the alveoli. The anatomical risk of that operation is the bronchus at the midpoint, where you do our anastomosis, receives 50% of its blood flow from the bronchial circulation and 50% from the pulmonary arterial circulation. But after transplantation, it's 100% from the pulmonary artery circulation, and therefore parenchymal preservation for that retrograde blood flow is very important for anastomotic viability. And the lung is unique in that while all organs are ischemic and hypothermic while they're stored, the lung is actually aerobic and can take advantage of aerobic metabolism. So when you think about whether to flush or not and what the solution is, the timing and the temperature, we looked at it at the time and realized that the solutions that were used for the other organs like the kidney and the liver, like urocolin solution shown here, or UW solution, are quite injurious to the lung. High potassium concentrations cause significant endothelial injury. So we devised, as I was working in a model, this is a dog single lung transplant model at the time. Nowadays we do it in pigs. You do a left single lung transplant, and you can put a cuff around each pulmonary artery so you could study the transplanted lung independently from the native lung. And we showed that an extracellular type low potassium dextran solution was far superior for lung transplantation, which showed excellent immediate function and day 3 function of lungs after transplantation. And this solution ultimately got commercialized as Perfidex that you've heard about, and we showed that LPD provided significantly better lung preservation, and it became the standard worldwide after that. We also showed in the lab that the low potassium concentration and the dextran were particularly important components of that lung preservation solution, and that the lungs do actually metabolize glucose during the preservation period and produce ATP and produce lactate. So there is low-level aerobic preservation going on. It's very important to recruit the lung then, so when you recruit it, you get excellent recruitment of the vessels, so you get uniform flush preservation and access to oxygen during the storage period while the lung is sitting during the storage phase. At the donor operating room, the multi-organ donor is heparinized, and when everybody's ready, the cannula are put into the pulmonary artery, the aorta for the heart, and the aorta for the liver. A bolus of prostaglandin E1 is given, and then the aorta and cave are cross-clamped, and the lungs are flushed. It's important to continue flushing the lungs throughout the preservation flush period so that it distributes the ventilation well. And there's also no need to rush in donation after circulatory death donors because the lungs are being ventilated and they've been cooled and they're protected. It's really important for those of you that go on the donor retrievals to bronchoscope in the OR, clean out all the mucus plugs, and recruit the lungs so that by looking at them and optimizing them intraoperatively, you can make sure that the flush is optimized. We do an antegrade flush of LPD, about 3 liters, and a retrograde flush through the pulmonary veins of about 1 liter. The bag is no more than 30 centimeters above the donor so that it's a low pressure flush, and the lungs are stored in LPD, 2 liters of it, and it's very important not to put ice on the organ itself. It's very important to continue the protection of the lung during the operation. It's not just sewing in the lung, but protecting it, so we use VA ECMO very liberally to support the patient, allow you to maintain protective ventilation and perfusion of that newly reperfused lung with a target pulmonary artery pressure of about 10 to 15 millimeters of mercury. And again, we use ECMO very liberally in lung transplantation during the ex vivo lung perfusion to protect an injured lung and evaluate it, but also during the operation and sometimes even after the operation if you have severe primary graft dysfunction. So where is lung transplant going in the future? 4 degrees preservation on ice used to be the standard of preservation, and we did that because 4 degrees was very practical, easy to perform, and there certainly is no evidence, although some companies might have you believe that lungs should be stored normothermically and perfused. But what's the ideal storage temperature for lungs? We looked at this actually in 1989. We published showing that 10 degrees was better than 15 degrees and better than 4 degrees. And in fact, the lungs, in rabbit lungs at that time, perform much better when stored for a prolonged period at 10 degrees than at 4 degrees. But why did we not adopt 10 degrees clinically is we didn't know how to keep it at 10 degrees. There wasn't the technology for it at the time, and we had concerns about the margin of safety, that it would be 15 or 20 before you know it, and we also didn't understand the biology well enough to try hard enough to do it. Well, Adil Ali, one of our fellows who did his PhD with Marcelo Sipel in our lab, looked at lungs stored for 4 degrees versus 10 degrees in LPD for 36 hours and then performed a trial. And he, actually this was on EVLP, and he showed that 4-degree lungs were 10-degree lungs were significantly better than 4-degree lungs after 36 hours of preservation. He went on to show that it was because at 10 degrees you actually preserve mitochondrial function and mitochondrial energy production much better than at 4 degrees. Etienne Abdelnour also looked at preservation of pig lungs followed by a transplant when they'd been preserved for 12 hours after gastric aspiration injury, and in fact also showed that at 10 degrees the lungs with this severe aspiration injury actually recovered faster than lungs at 4 degrees. So at 10 degrees the lung has a lot of critical functions still working. We also recognized over time that human beings, first of all, don't like working in the middle of the night, and the results of transplantation are not as good. Many studies have shown that transplants done at night don't do as well as transplants done in the daytime. So we designed an experiment saying if any lung is brought back to Toronto and cross-clamped after 6 p.m., it would wait till the next morning before we implant it. And these are the x-rays of the 5 patients that were in the original pilot study. You can see all of the x-rays up to 72 hours post-op were quite clear. And the rate of primary graft dysfunction at 72 hours was 0. The important thing, if you focus on the red writing in the bottom of this slide, shows that the lung preservation times were 12 on average for the first lung, ranging from 7 to 17 hours, and 14 hours on average for the second lung, ranging from 8 to 20 hours. So, you know, the average in the United States registry is 5.8 hours. So this is really going well beyond what is clinically practiced by most lung transplant surgeons. And again, if you look at this, the 30-day survival in the 10-degree treatment arm was 100% versus 96% in the control. And the incidence of primary graft dysfunction, grade 3 at 72 hours, was 5.7% in the study group versus 9% in the control. We looked at the long-term follow-up of the lungs stored at 10 degrees and showed that these lungs performed equivalently, and there's currently a randomized trial going on in 17 countries around the world to randomize to 10 and 4 degrees to prove this. So 3 years ago, the 10-degree cooler with export became standard of care at Toronto General, and we hardly ever transplant lungs at night anymore. And I know you've started using the export cooler here in Hyderabad and in Delhi as well. So what is the role of ex vivo lung perfusion? Well, lung transplantation was successful, all organ transplantation, by using a cold flush. But with a cold flush, you really don't get to see how the organ is until you reperfuse it. And basically, it slows down death, but it doesn't allow you to improve the organ over time with regeneration or repair. So the idea is, can we actually make organs that are better than the way we found them in the lung for the transplant journey? So we built the Toronto ex vivo lung perfusion system, put the lungs on a chamber where you could ventilate them with an ICU-type ventilator, perfuse them with a centrifugal pump, but sweep it backwards so that you actually remove oxygen, add carbon dioxide, so you can measure the function of the lung. And this is what the thorax system is that looks like that we devised. You've got the lung sitting in the glass chamber on the side, and you can measure the function of the lung over time. Now, this is what it looks like for those of you that haven't seen it. These are human lungs put on the thorax system at Toronto General Hospital. You can ventilate, perfuse the lung, protect them. We're looking at experiments to take this for several days where we have lungs with dialysis and total parenteral nutrition as well. You can bronchoscope the lungs and you can deliver drugs or sample. Here we're delivering the IL-10 gene therapy, and you can monitor it over time to see when the lung is ready to be transplanted. We've done over 1,000 cases clinically at Toronto General Hospital of ex vivo lung perfusion. And I think it's very important to understand that all EVLP is not the same. There are several companies on the market producing devices that do different things. The important features of the Toronto system is low perfusate flow, so it's protective, non-injurious flow. The flow is in a centrifugal pump so that it backs off and doesn't cause high pressure in the fragile pulmonary vasculature. It's an acellular perfusate. The temperature is 37 degrees. It's with a positive atrial pressure, again, protective for the lung, low ventilation strategy, and provides CO2 on the circuit. Of all the lungs we transplant at TGH, about 30 to 40% go on EVLP. The others go directly to transplant, as we normally do. And as I said, we don't transplant marginal lungs anymore and worry about it. If the lung's good, you go straight to transplant. If you're not sure, you put it on EVLP and check it, and you know it's a good lung when you're going to transplant it. And that's a luxury we've never had in transplantation. So really, we've changed the paradigm. You've got a first cold ischemic time, then we've got normothermic EVLP, then you've got a second cold ischemic time. And the real issue is, where's the limit when you can go between 10 degrees and static preservation? And really, can we use this now to truly engineer and create lungs that are better than the ones we may have found, make a lung that'll last forever? We're studying all of these new therapies to try and see how we can improve lungs for transplantation. And a fascinating series of experiments that Adil also recently did was he took pig lungs and kept them out of the body for 3 days before doing the lung transplant. So 6 hours of cold, 18 hours at 10 degrees, then 4 hours of normothermic EVLP, 20 hours at 10 degrees, and so on, for a total of 72 hours outside the body, then performed a lung transplant. And on the far right, you see the PO2 of the transplanted lung on 100% with the contralateral lung clamped was over 400. And that's with the lung being out of the body for 3 days. So that really gives us a lot of opportunity to repair lungs and create engineered organs. So I think, a lot of people are still struggling with the outcomes of the surgery of lung transplantation, and I think a lot of that can be abrogated by good lung preservation and surgical technique. So I think, in the donor, recruiting the lungs and attention to preservation is important. Lung anatomy, you've got to keep that in mind, the dual circulation, flushing with low potassium dextran solution, antegrade and retrograde, storing inflated with 50% oxygen in the flush solution. The storage temperature, 10 degrees, has become the standard in lungs and is quickly becoming the standard in kidneys and liver and heart as well. The role of ex vivo lung perfusion really is only just coming into its place to really create better organs and pre-prepare the organ before transplantation. And finally, the concepts of preservation must be continued during implantation and reperfusion in order to maximize it. I'd like to close by acknowledging the Latner Thoracic Labs. We have a lab of over 150 people working on lung research and lung transplant research at Toronto General Hospital, and our clinical lung transplant team that is very bold and courageous in looking after these very challenging patients, but also bringing a lot of our novel technologies to the bedside to improve the outcome of patients with end-stage lung disease. Thanks very much.
Thank you so much, sir. Apologies, we have a slight change in plan, but now we would like to move on to a lecture on the simultaneous use of dual scopes for PPN diagnosis by Dr. Sami on.
So, good afternoon. I already introduced myself yesterday, but I'll do it one more time. My name is Sami Onyansa. I'm from Germany. And today we're going to talk about a novel technique, well, somewhat novel, of using 2 bronchoscopes in one single intervention. So to start off, my conflicts of interest. There are key aspects to why you would want to use 2 bronchoscopes in one setting. Of course, there's the precision, there's the efficiency, and the safety. The original use of the double scope or the 2 simultaneous bronchoscopes was mainly for the hemostasis. And the key aspect I want to start talking about, I want to highlight before we go further on, is what I mean when I mean simultaneous and tandem. Tandem is basically one after the other, a consecutive use of bronchoscopes, and simultaneous is, as you'd know it, 2 at the exact same time. So to kind of give you an overview of what's out there, I made a little bit of a Russian roulette, so to speak. So we have different scenarios where we have either a single user, 2 users in tandem, 2 users simultaneously, and either single-use bronchoscope or reusable bronchoscope interchangeably in different scenarios. And the use cases are basically the ones that I've listed there. So cryobiopsy and hemostasis, radio EBUS and cryobiopsy, and a little bit of a surprise that's coming at the end. So the first scenario that you want to talk about, or that I want to talk about, is the single operator use of two reusable bronchoscopes for cryobiopsy and hemostasis. This has been published a while back from Aditya Chav, where they had a reusable bronchoscope go through the nose with a Fogarty balloon, and then another bronchoscope goes through the mouth to take the cryobiopsy so that they could achieve hemostasis whilst they're doing cryobiopsy. If anyone knows Aditya, he'd tell you he had actually a third bronchoscope which he used to take photos, but that's beside the point. So following this, a lot of different aspects were taken into consideration, and then the tandem approach came into play. So tandem would be using two reusable bronchoscopes for the exact same thing as the first paper showed, where you have one operator in charge of hemostasis and the other operator in charge of biopsy. This had the advantage that when the one takes the biopsy, he can concentrate on securing the biopsy, whilst the other one is dealing with the blood flow that happens. A disadvantage of this technique is, of course, that you need two towers. Two reusable bronchoscopy systems means two endoscopy towers and means a larger footprint. So beginning of last year, my colleague from Malaysia, Ko, and we had similar ideas but different approaches, where we kind of wanted to change the aspect of double bronchoscopy. So we thought, why not introduce a single-use bronchoscope to the mix? So Ko had this idea, and he actually wrote a paper about it, where he had a single operator using a reusable bronchoscope in combination with a single-use bronchoscope for transbronchial cryobiopsy. There's a short video to the paper as well. The paper is available on respirology case reports. So this is basically how Ko did it. So after navigating to the lesion, he takes the cryobiopsy with the reusable bronchoscope, and then he uses the single-use bronchoscope to immediately go into to perform hemostasis. Our approach was somewhat different. We thought of single-use bronchoscopy as an advantage, but we were like, do we really need the reusable bronchoscopy, the reusable bronchoscope for that? So we changed this approach and decided we're going to have two operators in tandem so that we separate the roles, but then we're going to implement two single-use bronchoscopes in order to have this split-screen mode where we can see what's happening whilst we're doing it. So as you can see, this is one of the first cases that we had in January of last year. So I'm with the large Ambu A-Scope 5.6 bronchoscope so that I can have a large working channel. And what I'm doing is we're trying to do a debulking of a patient. She was unfortunately on blood thinners, so there was a high bleeding risk, but she was crashing out, so we had to do the debulking as quickly as possible, and we didn't have availability of rigid. So you can see we're working on an 8.5 millimeter tube, so which doesn't give you a lot of leeway when it comes to Fogarty balloons and all that. But with the two-scope method, my colleague was doing the hemostasis with the 4.2 bronchoscope, which has a 2.2 working channel, which still allows you to have impeccable suction while still having a small outer diameter. So this is what happened, or what he saw basically, and this is the second biopsy. So knowing that my colleague was there, I had the confidence of taking my time, taking a larger biopsy at each go, because I know I don't have to be responsible for both securing the biopsy and of course for the hemostasis going on. And so this is the tandem biopsy that we did. If you notice, all I've talked about is cryobiopsy and hemostasis. What about the other stuff? So we kind of started rethinking the aspect of peripheral biopsy. The challenge that happens in peripheral pulmonary lesions, of course, you have the diagnostic dilemma, how are you going to get there? But then you also have the problem with the diagnostic inaccuracy, the sampling error that you have. I'm from a small hospital, so at the time when we had the idea, we didn't have cone beam CT, no robotics, no augmented fluoroscopy. So we kind of had to be a little bit innovative on how we could do a peripheral biopsy and still have tool in lesion. So that's why we decided we're going to change this technique that we're doing right now, and instead of tandem, we'll have a simultaneous bronchoscopy going on, And what we're going to do is we're going to combine the cryobiopsy with the radio-EBUS. A thing I've learned from the Italians, they have really cool ways of naming interventions or naming things that we do in endoscopy. So I think everyone knows ROSE. ROSE is actually immediate cytological analysis, but it doesn't sound sexy. They say it ROSE to make it romantic. So we decided to call our method the kissing probe technique. Kissing probe means the radio probe and the cryo probe are in contact before taking the biopsy. We highlighted this, or we showed this in the pulmonology and air event last year. I don't have the video from the event, but this is one of the many interventions that we're doing. So basically we have a large or subtherapeutic scope with a radio probe. It's already navigated to the lesion that we want to go. I'm there with my colleague coming with this 2.7 millimeter bronchoscope, the ultra thin one, next to the large one, so that I can manage to navigate along the radio probe towards the lesion. There you see that from the large image, from the large bronchoscope, the smaller ultra-thin bronchoscope going along the radio probe. So our goal was to visualize with the radio probe what we're seeing, or like where the lesion is, and in turn take cryobiopsies under this guidance. So here you see the radio-EBUS being turned on. And with the small outer diameter of the ultra-thin bronchoscope, you can keep going further and further into the periphery until reaching the tip or the distal tip of the radio probe, where we know that that's where the tumor is. So this is going to happen in about 5 seconds. And there we see the beginning of the distal end of the radio probe. So I know this is the region where the tumor is. This is where I can take my biopsy, and with the changes in the ultrasound image, I can have a somewhat tool in lesion confirmation. So an important thing whilst doing this is, of course, securing your radio probe. So we're just pushing in the cryo probe now with the radio probe turned on, so that the ultrasound changes tells us that we have contact between the radio probe and the cryo probe. We pull back the radio probe just to secure it and not have any damage to it. So that's what my colleague is doing. Again, like I said, we're doing advanced bronchoscopy, voice-activated bronchoscopy, so not robotics. I tell her what to do and she does it. And then, of course, I take the cryobiopsy with the second bronchoscope still in place to help me have a tamponade when I take a biopsy, so I don't have to deal with hemostasis. So the second bronchoscope is not only for the navigation, it's also for the complication management that happens. And the ones who are very eagle-eyed saw there was a question mark in the end. But I'll get to that in a second. The advantage to the double scope technique that I wanted to mention before I get to the next step is, of course, we have a real-time visualization where we're taking the biopsy. We have a higher diagnostic yield or a higher diagnostic accuracy because we know where the lesion is because the radio-EBUS is in place. And what I started teasing at the beginning is what's next. So we have had 2 patients. We've done it in rigid. So a critique that we got was rigid bronchoscopy is not possible outside Germany, and having 2 operators in one sitting is not possible in the climate that we have. So I took the challenge on and said, why not change it? Why not have 1 operator use 2 bronchoscopes at the exact same time? And this is a video of a patient, one of the first patients where we did it at. It was a patient with a middle lobe lesion. It had a vessel sign, so the vessel next to it. So he's intubated with an endotracheal tube with some spontaneous breathing. And as you can see, we're using the virtual bronchoscopy from Archimedes to kind of guide us to the way. So what I do is I have the virtual bronchoscopy set up, and I slowly follow the virtual bronchoscopy towards where the lesion is at. So it's guiding me to go into the right middle lobe. And as soon as I'm satisfied with where I'm at, the first step is, of course, to get the radio probe out so that we can confirm where the lesion is. This lesion was interesting in that it didn't have a concentric lesion. It was more of an eccentric lesion, which proves to be a challenge because with the eccentric lesions, you have to be at the exact same spot where the eccentric signal is in order to get the changes when you're putting in the cryobiopsy. This is what we like to call anchoring. In order to create space for the second bronchoscope, we hold the radio probe in position, we push it forward, and pull back the bronchoscope. So the radio probe is still in position when not moving a little bit more distally, whilst the bronchoscope is being removed, kind of like how you do it with stents. So now I have the bronchoscope in the the main carina, and I adjust the radio probe image just to be sure that tumor, and we fix it on our microphone stand. Once we're satisfied, we take the second bronchoscope. Again, I'm doing this alone. Because it was an eccentric lesion, I decided to be sure and have the fluoroscopy on hand just to make sure that I don't miss the lesion. And again, the procedure is exactly the same like the first one. The radio probe is in position, and I'm navigating with the ultra-thin bronchoscope along the radio probe towards the tip, just so that I know I'm exactly at the point where the tumor is before I take the biopsy. So this is more of like you're combining a visual confirmation with an ultrasonography confirmation. And there you see that's the tip of the radio probe, and I know where the radio probe is. But as I mentioned, the signal is eccentric, so it's telling me towards the left of the image. That's where I should be. I'm going to show you what's going to happen when I start putting the cryoprobe, because the radio probe moves as well. So that's the cryoprobe coming in, doing the exact same navigation. And this is how I know I'm at the tumor. We see the eccentric lesion over there on the left side of your screen, sorry, on the right side of the screen, but to the left towards the bronchoscope. And notice how it changes as soon as the cryoprobe touches it. So it's not visible and it goes away. So that's how I know I have contact between the tip of the cryoprobe and the tip of the radio image. Adjust the radio probe, pull it back, freeze for about 3 seconds for the first biopsy. 1, 2, 3, and take the biopsy as normal. And the question is, this is bronchus. We have to push forward. So is there any more innovation that we can do other than that for a small clinic that doesn't have robotics? I think we can. And that's where this question mark comes into play. So biopsy, we've done hemostasis, we've done cryobiopsy under radio image confirmation, but what can we do more? So I want to show you never before seen footage of the first test that we did for the ariscope. We did the first documented simultaneous use of ariscope and radio EBUS in a patient. I had the pleasure of doing it this week. So this is the patient. Again, we have the navigation set up. We follow the navigation to know where the lesion is. The lesion should have been in the left lower lobe. We know the lower lobe is always a challenge. That's why this patient got administered, the bronchoscopy was done under rigid bronchoscopy. We have the twin stream ventilation, which allows us to have a frequency up to 1500, meaning there's lower movements of the diaphragm. So we have the MP that gave us the signal, and then I'm coming in with the single-use bronchoscope going towards where the lesion is at. As you can see, it's jet ventilation. That's why we have little movements. And that's the guide seat from the ariscope coming in. We wanted to see, is the ariscope as good as they say, and can the radio probe help us understand the usage of the ariscope? So if you have experience with the ariscope, that's a small microscope, so to speak, or a small camera that identifies changes in the mucosa, which will let you know this is tumorous, this is tumor infiltration, or this is normal mucosa. What you want to look for is white changes, so to speak. So this is me moving the ariscope, and as soon as I see this, I know I'm getting close to where the tumor is. The radio probe is still in position. I have the ariscope right next to the radio probe. Now I just try to figure out the best position to take the biopsy, because I forgot to mention, this was also a necrotic tumor. So once we see the changes that are indicative of tumor change, what we do is we'd fix the guide sheath. This is a much better image where we see the changes, the little white lines indicating mucosal changes. Once we have that, we are satisfied that we are at the best spot to take the biopsy. We would then fix the ariscope in position and then start taking our biopsy with a 1.4 millimeter forceps. Of course, the question is, why not cryo? Well, when we're talking about peripheral pulmonary lesions, less is more sometimes, because we're not talking about PDL-1s in this situation. We just want to get the biopsy that's in the right spot so that the patient can get operated on. And that's what we did. In the end, it was an adenocarcinoma, and the patient is up for operation. So the key takeaways in this double scope technique is that it's old, but it's also new. It's changing with the times. Of course, there's a question that everyone is going to ask, the cost efficiency. I think the most important part, the most expensive part of interventional pulmonology is not the cost of the equipment. The most expensive part is repeating a biopsy. A non-diagnostic biopsy is more expensive than any other thing that you'd have. So it's an investment question. Do you have advanced fluoroscopy? Do you have robotics? Do you have cone beam CT? Do you have anesthesia? If you don't, this is a consideration that you can take into hand when you're doing biopsies. And the question that I raise is, what are the possible future directions? Do we have a place for robotics? We saw concepts of two-armed robotics being showed in Israel from WEnterluminal. Can we use AI? Could we use this technique for therapeutical and diagnostic instances? I'm talking about ablation, where we have the radio probe in position whilst we're doing the ablation. With that, I'm at the end of my talk.
Thank you, Dr. Sami. We now move on to resuming our discussion on lung transplant. We'll go back to the 30 years of lung transplant, a medical journey. And to give this talk, I invite on stage Dr. Robin Voss.
So thank you for the invitation, and we'll share some insights on our journey in lung transplantation from the medical point of view. We already heard some important messages from the surgical point of view. I think this is really important, but also everything that happens after the surgery is important for our patients. So I have no real conflicts of interest related to this talk. So the first human lung transplantation actually occurred in 1962 in Mississippi by Hardy. And I'm not showing this picture for the fact that it was the first transplantation, but actually for the fact that the patient unfortunately did not survive long. He died after 18 days due to kidney failure. And this is important. It highlights that you have to be prepared after transplant surgery for everything that possibly can go wrong, and you have to be staffed and equipped for this. This is also an interesting case. It's actually the first long-term survivor, transplanted in 1968 from Belgium, the country where I work, in a young patient with silicosis. He was treated with azathioprine and prednisolone at that time. He had a very complicated post-transplant course, which was characterized by recurrent acute rejections and recurrent infections. Finally, the patient was discharged but readmitted because of a progressive obstructive pulmonary function decline. He died due to respiratory failure. And I show this slide because it's so many years after that day. It still highlights the problems we are facing today in our transplant patients. Exactly the same problems we see still after more than 30 years. It's also an interesting case, this patient, because it was actually the first case with documented chronic rejection after lung transplantation. And you can appreciate from the figure that there was a progressively obstructive pulmonary function. And on autopsy, it was evidence of narrowing of the bronchi and bronchioli and lymphocytic infiltration, which are the typical hallmarks that we would later call bronchiolitis obliterans syndrome. Again, something that we're still struggling with so many years after this procedure. Actually, it was only as of the 1980s, with the introduction of cyclosporin A, that the lung transplant programs really took off. And as an example, this is the first heart lung transplant procedure performed worldwide in '81. And this lady survived for 5 years, which was already at that time quite long. And as already pointed out by Dr. Keshafji, in the late 1980s, lung transplantation really took off with the expertise developed by the Toronto team, which really developed novel surgical techniques and pioneering investigation in transplantation. And now we at a very high rate of transplantations. I mean, we can appreciate the annual increase, and we see that every year about 4,500 to 5,000 lung transplant procedures are performed worldwide, with overall about 70,000 transplants being performed now. For the pediatric lung transplantations, you can see the same trend, albeit much lower numbers. So on an annual basis, worldwide, there are only performed around 100 lung transplantations in children on an annual basis. Something that is striking to see, on the other hand, is a decrease in heart lung transplant procedures, both for the adults as well as for the children. And this is due to the better medical treatment and surgical treatment we have nowadays for these patients who are mainly suffering from pulmonary hypertension. This is just to give you an idea on the lung transplant numbers in Eurotransplant. Eurotransplant is a collaborative society which exists of 8 countries, and you can see that around 1,200 individual lungs were transplanted in 2023, which is a quite high number. In Europe, in Eurotransplant, there are around 800 patients on the lung transplant waiting list, and annually about 600 lung transplants are performed. Unfortunately, still 10% of patients die on the waiting list while awaiting a lung transplantation. In my center in Leuven in Belgium, the first lung transplantation was performed in 1991, was right single-site lung transplant for emphysema, and the patient managed to survive almost 1.5 years after transplantation. Our program really had a good start, and you can appreciate from the first 4 patients that they quite good, with the second patient still alive more than 33 years after her heart-lung transplantation. Now, point out that the 4th patient also lived for more than 20 years after his transplantation. And this is our experience over the past decade. So you can see that the first 10 years really was about building experience and getting to know how to handle the most common problems. Later, logistical growth and the use of extended criteria donors led to a steep increase in the numbers of transplantations. And nowadays, last year, we performed 75 transplants on average, and we surpassed the threshold or the milestone of 1,500 lung transplantations in our center. So there is a cumulative number of transplant procedures, but also a cumulative number of patients alive, and you can see that currently we are taking care of more than 740 lung transplant recipients in our center. And so our center really is the largest transplant center in Belgium, in which about 2 out of 3 transplantations of all Belgian people are performed. If you compare this to Europe, you can see that we are not the only big center in Europe. There are several larger centers in Europe. The largest one is Vienna, followed by Hanover, and then our center and some centers in Spain, which are also have increased in the last years in numbers. So, quite a lot of bigger transplant centers in Europe. Over the course of these more than 30 years and all these milestones, you can see that there were several firsts in our center. First pediatric transplantation, first redo transplantation. What you get in an evolving program that you are pushing the boundaries, and so having new milestones. But I must say, even with experience of taking care of more than 1,000 lung transplant patients, I can say that every successful transplantation is still a new milestone that we like to celebrate. Just an overview of our transplant patients. So you see that the majority is bilateral lung transplants. There are some combined organ transplants. We did do some children, not much. It's a rare indication. And so the thing that is really striking to see is in the past decades, there has been a steadily increase of the donor age. We last year also transplanted a 94-year-old donor, and the patient did actually well post-transplant. Same trend is seen for the age of the recipients, steadily increasing, now touching up to 60 years as a median age in our cohort. Also, there has been a notable change in the type of transplant procedures. So nowadays, bilateral transplantation has become the standard approach in almost every patient. And this is also seen in international registries. where you can see an increase in the number of double lung transplant procedures being performed. And this is due to the decreased surgical risks of lung transplant procedure, and also the fact that these patients with a double lung transplantation have a better long-term outcome compared to those with a single lung transplantation. Who are we transplanting? Well, there are some general indications. We are transplanting patients with chronic end-stage lung disease for whom there is no are very likely to die within the next 2 years. But we also have to think on the long term, and so we have to select these patients who have a very high likelihood to survive up to or longer than 5 years after transplantation. So we really need to be very selective in who we will transplant, and there are now international recommendations for lung transplant candidate selection, which I would recommend you to read. So it's all about actually weighing risks, and you can have a patient who has very few minor risk factors, which is an acceptable candidate, and you can have a patient who has an absolute contraindication who you would defer transplantation from. So it's the garbage in, garbage out principle. I mean, if problems are there pre-transplant, they will only get worse post-transplant, so this is to be avoided. Lung transplant indications have changed a bit over the past decades. You can see that overall 2/3 of patients are being transplanted either for emphysema, cystic fibrosis, or interstitial lung disease. For children, this is cystic fibrosis or pulmonary hypertension. But nowadays, in the most recent era, you can see that there is a significant increase in the patients transplanted for interstitial lung disease, and worldwide this is now the most important indication for transplantation in most centers. This is just an overview of the indications in our center. Of the 1,500 patients transplanted, you can see that the majority actually was transplanted for obstructive disorders, emphysema the most common, but 1 out of 4 has been transplanted for interstitial lung disease. For children, you can see that worldwide the most important indication is cystic fibrosis, also in our center. But again, this will change in the near future and is already changing because of the new CFTR modulator drugs. Are now almost no, or let's say no. We also have no patients with cystic fibrosis anymore referred or on our waiting list. And this is true for many other centers in the world. So I think this is really changing the referrals we get for pediatric transplantation. Also important that the patient knows what he should expect or should hope for. We, as doctors, try to save the patient's life or make him live longer. The patient comes sometimes with other expectations, but this is not the primary goal of why we do transplantation. Because this is an illustrative slide. We always aim to make the patient better with the transplant procedure, but you have to also take into account that sometimes the patient may be worse after transplant procedure, which is of course undesirable, but the patient needs to be aware of this fact that this may be unfortunately an opportunity. And if you look at the functional status of the patient surviving a transplant procedure, you can actually see that about 30% functions at the suboptimal level for the adults, and for the children this is about 20%. And this is mainly due to the fact that many patients will be re-hospitalized after transplantation. This is one of the reasons why you need a good medical team to take care of these patients. About 30 to 50% of adults will be re-hospitalized due to infections or rejection, and in children this is about half of the transplanted children. So really, life after transplantation for many patients is one of continued lifelong care and close medical follow-up, and so you should have a medical team which enables this, and it's really important to have regular checkups in these patients to detect comorbidity, intervene if there are suspicion of infection or rejection. This requires a multidisciplinary team, a holistic approach, and a lifelong follow-up of these patients. Basically, what we nowadays do after transplantation is taking care of or preventing comorbidities, and you can see some of the most frequent comorbidities here on this slide. And so we're not just lung doctors, we're also endocrinologists, cancer oncologists, cardiovascular doctors, and this is something we need to take into account. This is mainly due to the use of the calcineurin inhibitors, as you know, which have many undesired side effects, unfortunately. And one of those is, for instance, the development of cancer, and you can see that there's a pretty high prevalence of post-transplant cancer, which again highlights the importance of thorough pre- and post-transplant screening and follow-up in these patients. Here's just an illustrative picture of the leading causes of death after transplantation, and you can see even after so many years that infections and cancer, amongst others, are really important to prevent action. So what can we expect? What can we tell our patients on the long term? This is evidence from ISHLT registry again. Best long-term survival is in the youngest patients, which are mostly CF patients. The worst long-term survival is in the elderly patients. Survival of the first year is really key. If your patient survives the first year, he has a very good prospect of living several years. And you can see this ranges up to between 5 and 9 years in this registry. If we look at our own data, we can see that we have a median survival of more than 11 years, which is be able to say to your patients who are referred for transplantation, we think we can make you live another at least 10 years longer. We have a 90% 1-year survival, and we should actually aim for higher, aim for a 100% survival at 1 year, which should be the future. These are pediatric survival rates, and you can see that also for children we have very good outcomes up to median survival of 13 years. So if you add everything up, you have X number of patients who live X number of years post-transplant. You actually come to an impressive number of more than 10,000 added life years, which we achieved with the transplantation. And you can also appreciate that 1 out of 4 of our patients in our center lives more than 10 years after transplantation. And our oldest living patient is 82 years. He's now more than 20 years post single lung transplantation. So many medical advances in the past decades have led to better outcomes. I'm not going to go over these in detail, but you can read them. Improved immunosuppressive therapy for sure is a really important advancement that led to better outcomes, but also advancements in diagnostics, infection control, and clot management have led to reasonably good or good outcomes nowadays. There are still some remaining important problems, and these will be there for sure for another several years. We have still patients dying on the wait list, or patients dying post-transplant because of graft failure, and you can see the reasons listed on the slide for this. And I think many of the things that were discussed at this Congress, AI, big data analysis, bioengineering, will be really relevant for lung transplantation the next decade to further improve the outcomes of our patients. Particularly for chronic lung allograft dysfunction, which is still a very frequent condition. You can see that about half of our patients will develop this potentially lethal condition 5 years after transplantation. This will be important. Maybe we can use AI for the outcome analysis of various parameters to predict which patients will develop clot and maybe intervene earlier in these patients. Just to give you an idea of our own clot prevalence, which is a bit lower compared to the international, and there were more slides, international registry data. So I'm not sure what's causing the problem with the slides. Okay. While we wait the slides, I can maybe talk further. Okay, there they are again. So chronic rejection is also one of the most important reasons why we need to retransplant sometimes patients, although this only occurs in a low proportion of our patients. So we really should go for one organ for the rest of their life with better outcome analysis. So to push the boundaries after lung transplantation, you for sure need a skilled cardiothoracic surgical team. You also need, except from a dedicated patient, you also need a dedicated family and multidisciplinary care teams, which are experienced in taking care of many medical problems after transplantation. And also probably you need a research group like who looks into the factors associated with outcomes, and we do actively do research on all these topics to try to improve our patients' outcomes. This is done by several clinical trials, and here are just two examples of these, and also by translational research, in which we use mouse models, ex vivo models, to better understand the mechanisms of disease, to detect novel biomarkers, and to identify personalized treatments for our patients. And this will for sure help us to further push the boundaries for the benefit of our patients. I just want to point out on the right lower end of the slide, you see the lady with the dog. This is our longest living lung transplant patient. And then just above her, you can see one of our patients who has delivered her daughter 2 years ago. So, bringing me to my conclusion, I think lung transplantation is now an accepted treatment option because of many medical advancements, not only surgical advancements, also medical advancements. Post-transplant outcome is improving, but still limited due to CLAT, and I think ongoing research is absolutely needed to further optimize our future post-transplant outcomes. And with this, I would like to thank our team and also you for your attention.
Thank you, Dr. Robin. We would like for you to stick around till the end of today's session, after which we will be announcing the winners for the picture and video competitions. Meanwhile, we move on to the next session. This is going to be the management of airway fistulas. May I call upon stage Dr. Gustavo Comunaceli to take over the session. Thank you, sir.
Okay. We're going to make this one interactive. I know that we're all tired and we appreciate you sticking around. Definitely, I'll take less than 15 minutes. Hopefully we can all agree on some of these principles, way less controversial. And I'm going to start by asking 4 questions. And we're going to do a show of hands. Pulmonologists, thoracic surgeons, hand up in training or board certified or some sort of, okay. If it's a no, lower your hand. Have you been consulted for an airway fistula ever? Yeah, okay. Did you treat that or did you refer somewhere? Yeah. And the question is, are you pleased with your results? No. I don't think that the treatment or the understanding we have of airway fistula is optimal, and I think that there's a lot of wiggle room for us to do it much better. So here we go. Definitions. Most of the talk is about airway fistulas. We're going to have a word about alveolar fistulas, especially for the fellows that are training, and it's important to be able to call conditions by their name. So it's important to differentiate a bronchopleural fistula, which is somewhere in the airway visible to the scope, than an alveolar fistula, which is in the surface of the lung. And we're going to have a little bit of conversation regarding tracheoesophageal and bronchoesophageal. Definition also, it's important for all of us to understand that a prolonged air leak is any leak that you see in your canister or your atriums beyond 5 days. Here we go. Patient shows up in the emergency department, urgent care, x-ray, lung is down, maybe an EGD performed a couple of days prior, breath, maybe hypoxemic, and we as consultants get called and say, now what? So as they're getting ready to put a chest to set, we need to consult on this, the sooner the better, since this patient is not doing very well. We're going to be kicking in gear for all our training in pulmonology and ICU, and we're going to say, okay, let's get this patient stable. That's important. Let's not think about stents or surgical referrals. Let's get the patient stable, ABCs. Sometimes patient is losing their entire tidal, and we need to mechanically ventilate this patient. As we're stabilizing, part of the stabilization is to get chest tubes and get ready to place them, whether you do percutaneous, whether you do dissection, whether you believe in an approach being better than the others. As we're getting all of these things, we're getting the patient somewhat in the work for getting admitted, and depending on where you are, there are some other doctors that may be made aware to approach this in a multidisciplinary fashion. We are all hoping for the best and preparing for the worst. We have backup plans. and immediately we start thinking short, medium, and long term about this patient, which we still haven't done a bronchoscopy, but we'll get there eventually. So how are we going to move forward? One of the reasons that we have to spend a little bit of time on the phone with whoever is calling us is just get an idea of what's going on with the patient. Is this the patient that has a parenchymal problem? Is it the patient that has had cancer before? Is it the patient that was radiated? Is it the patient that just had a car accident and he was brought here? Definitely is somebody that underwent surgery a few days ago and was discharged. And if we're getting called from a peripheral hospital that the patient has been in the ventilator, we need to figure out really what's going on and for how long, and if they have been seeing this kind of brewing or is a sudden change. Initially, we need to think about three aspects. Is it going to be a conservative approach? Are we going to bronchoscopically, or are we going to do a surgical approach? And sometimes it's sequential. Part of the conservative treatment is draining the pleura, start thinking if there's going to be antibiotics or antifungals or whatever is it that you have to give. If the patient is malnourished, especially if he's been in the ventilator for 3 weeks, is the patient able to heal from what's going on and now he has a hole somewhere or protein depleted and this is never going to heal in any way. Importantly, especially for the ones that practice intensive care unit, we in the US, our training for the most part is dual pulmonary and critical care. So if the patient is ventilated, then there's some considerations that definitely I invite you to read. This is, everything has to do with shunting, VQ mismatching, correcting acidosis, management of the PEEP, and definitely management of possible pleural or mediastinal spaces infection, and everything that has to do with protecting lungs or airways from further damage. This is a very complex topic that I don't believe that 15 minutes is enough. Definitely there are some salvage approaches on ventilators that I invite you to read one of the many, many sources of truth, which is expert opinions and maybe some case series in which there's salvage approaches that can definitely save a life. And this could be either putting the patient on ECMO, whether it's a single lung ventilation, and back from H1N1 and different type of pandemics that affected the lung, we learned a lot about oscillators. So nobody likes to hear that piston, but we have seen that some alveolar fistulas heal faster on oscillator. So one of the cornerstones of addressing fistulas, especially alveolar fistulas, is try to make the patient from positive to negative pressure as soon as possible, as to prevent this gradient that will perpetuate the fistula from healing. And definitely if we're on the quest of finding where the alveolar fistula may be, we have in the US, and I'm sure that some others have, jetting oxygen to try to exacerbate that leak that we see in our canisters. So the size of the chest tube matters. I hope that all of you are well versed in putting small chest tubes, pigtails in order to drain, and we're not necessarily cracking it open and dissecting in a surgical fashion. Definitely more dramatic, and maybe that's all you have. But definitely for this type of problems, trying to do the smaller appropriate size, especially directed to where the problem could be, is preferred over a surgical chest tube. Let's manage some of the symptoms. Daily x-rays and see if the lung is collapsing, and does the x-ray correlate with how the patient is progressing? And if the pleura is not having good apposition, visceral and parietal, why is that? Is it a trapped lung or not effective suctioning? Are there pockets in there? So all of those are questions that we have to ask ourselves. I promise we're going to get to the stenting in a second. And every time that you have a fistula, we favor, especially interventional pulmonologists in the US, to have the least amount of suction possible in order to stabilize or improve, and definitely water seal over suction. Depending on where you are, you're going to have immediate management with some sort of drainage system where it's digital, in which you can dial up and down with click, click, enter the negative pressure, or you're going to do it the old-fashioned style with the atrium. Both of them will provide you with an idea of the leak, which is important. This is where definitions matter. This is where we have to speak the same language. For alveolar fistulas, which matters in a way that we need to know for how long the alveolar fistula has been in there. Anything less than 7 days, we have some degree of hope that it's going to heal. Anything more than 10 to 14 days is very unlikely to heal on its own. How much is it leaking? Volume. There's grading systems I'm going to show you in a second. And the trend, is it getting a little bit better every day? Is it getting a little bit worse every day? Or is it stable? When it comes down to the bronchopleural fistulas, then leaking, even though the leak is going to be there, it should be fairly constant. Usually bronchopleural fistulas take way longer to heal than alveolar pleural fistulas. And that's where bronchopleural fistulas, the size, location, and overall characteristics of that fistula matter in order for us to figure out how we're going to treat these patients. Whenever I'm training my fellows, and one of the questions that I have before they present me the patient in the morning is, how is the leak? Is it better? Is it worse? I really don't mind any scoring system for as long as they go and they physically take a look at the reservoir, at the atrium, and they can tell me if it's better or worse. And I'm going to push a little bit. I'm going to say, okay, what grading system you may use, and is this a grade 1? Is it a grade 4? And obviously, whenever you're in training, all of those things are something that you may punt for the future, but training is the time that you have to get good at this. So whether you use any classification, we have to document in the chart how is the fistula progressing. Are we doing okay so far? Good. We talked about short, medium, and long term. In the short term, we all put patients either on suction or low volume suction. Hopefully, we're going to move to water seal, and eventually, we may be able to clamp those patients to get the chest tube out, particularly or whenever we heal the bronchopleural fistula. These devices are more when we started de-escalating, since it doesn't require necessarily any suction. To the left, you have a Heimlich valve. I humbly suggest that you take a look at this if you have them and understand very well how this works. We have seen some disasters happen when the Heimlich valve is put in line with the chest tube into the atrium, and by the fact that it's backwards, the patient has a tension pneumo. So please, know your devices before you put them on a patient, and if you think you know it, just look at it again, especially if you're in training. To the right, we have different type of versions. You have a pneumostat, a mini atrium express. All of these are devices to the right that the patient can go home with, but they will only be able to go home if they are off suction. So there are some devices that can be used in order to get the patient home and maybe give them a couple of more weeks to see how they do. There's some alveolar pleural fistulas that can take longer to heal, and maybe some patients don't have enough lung for us to take offline by putting endobronchial valves, which is what we're going to be talking in a second. Okay, we're all here, we all love bronchoscopy, and we feel that we can heal and we can help patients bronchoscopically. Therefore, the basic approach of this is, first of all, let's localize where the problem is. Is it right? Is it left? Is it upper lobe? Is it lower lobes? Where there is a visual inspection for tracheobronchial pleural fistulas, or whenever we do balloon occlusions in alveolar pleural fistulas, and to say that you located and isolated the fistula, you need to make sure that the leak that you observe in your atriums or in your canisters or reservoirs decrease by 50%. So if you have bubbles every 1 second, now the bubbles are every 2 seconds or 3 seconds. You don't have to fix the leak. And this is a little bit of a problem that we all have to be mindful that isolation fistulas may not be possible. Maybe you are in the right upper lobe, and that's where the alveolar pleural fistula is, and there's not enough fissures. And for those that have the possibility of performing charties to see if there's collateral ventilation, that will play a significant role. Maybe you are not very aware of exactly what I'm talking about, but charties is a pressure gauge system in which you balloon occlude and you sense distal pressure. And if there's collateral ventilation, it doesn't matter if you block an upper lobe. If there's collateral ventilation, the right lower lobe and the right middle lobe may feed that area that is diseased, and you're not going to see any decrease of the leak. Sometimes we have used methylene blue to just score methylene blue. This is not permanent. This is not something that is going to last forever. And you can see the methylene blue coming out of the chest tube, and that may have been used by some of you. And if you don't, just keep it in your back pocket. Okay, so let's talk about therapeutics. The therapeutics for alveolar pleural fistula and bronchopleural fistula are completely different. We do not have enough time in 15 minutes to go in detail. I invite you to take a look and read. The bottom line is the treatment of airway fistulas is usually local, or for the most part local, where the alveolar pleural fistulas are more along the lines of endobronchial valves or surgical. There's a lot of case reports. we all have experiences that we did one-off and we publish it, but I invite you to read the literature and see really what's the standard of care and what are your options before you give a patient what you have. Maybe there's something better somewhere else, and the patient will definitely appreciate you referring the same way that you will appreciate if they refer to you when there's something that it would be preferred. Okay, we're going to talk about devices, and we're going to take 10 seconds per. Unplatzer devices, especially in big fistula, they have very few options. Some smaller surgical fistulas in the airway, application of silver nitrate, that works really well. We do not have enough time in the entire day to talk about how to stent somebody, but definitely stenting has been a preferred mechanism of occluding the fistula in order to either permanently exclude that area that is a concern, or temporary until you figure out what the next step will be. We don't have this in the US. Watanabe, Spigots, these have been used with really good success. I've read anecdotal reports in which some patients have had valves and they have put bone or they have put surgical foams in order to create a plug. Definitely a multidisciplinary approach and discussing with experienced doctors may be really, really important for you to know how to plug a hole. Coils have been used. I don't have experience in coils, and that's the way that they look. So if you have an experience on coils, definitely an option in order to close off a bronchopleural fistula that otherwise is not going to heal on its own. For alveolar pleural fistulas, we have both Zephyr and aspiration valves, and they come in different sizes. We have used both for isolation. One school of thought is that you just occlude the segment that is affected. Some are more aggressive, like myself, that we like to occlude a lobe for as long as the patient allows for that. And then just to wrap up this and get into the interesting part of the how do we do some plumbing on these diseased airways is we need to know where the fistula is. To have it in the mid-trachea or have it in the carina or have it in a subsegmental area is not the same, and treatment options are going to significantly vary. Whenever we take a look at the congenital and pediatric population of esophageal atresia, you can see that developmentally there can be connections between esophagus, stomach, or and bronchi. So it's very important that we do a very good bronchoscopic exam and see where the hole is. And definitely whenever you start taking a look at all of this, you can see that we all have seen holes that are either leaking bile or are bubbling, or you see the esophagus, and we know that immediately we need to start thinking, how are we going to palliate this? This is not sustainable. To the left is what you don't want to see, that you put whatever stent you have in your shelf, and then the stent is doing nothing, and you can see the esophageal stent popping in there. I am very well aware of the school of thoughts that for bronchoesophageal fistula, some doctors prefer to stent the esophagus and the bronchus. In my experience and having done hundreds of these cases, I always approach this as what is the least amount of stenting that we can do in order to get a good outcome. So have we done double stenting? Yes. Do I prefer to have GI to do an esophageal stent, and hopefully that occludes enough of the esophagus in order not to leak into the airway? Yes. So all options are on the table in order to secure an outcome with the least amount of invasiveness. You can see how there can be a little bit of pressure in that poor mucosa in between the bronchial area and the esophageal whenever you have radial force that is expanding, and that's going to cause a little bit of ischemia in that area as a byproduct of pressure. So a little bit of a history of gastric barium and seeing how the left mainstem starts getting a little bit of a contrast in there. We don't want to see this. In wrap-up, there's two ways to go about this if you're thinking that stenting is the way to go. You can do rigid bronchoscopy or fiber optica. If you're going to do rigid, please make sure that you know what you're doing. There's an operator in to put a stent. Maybe you want to put a silicone stent, and that may not be a good outcome. So there has to be reasons for you to do rigid. One of the reasons that I can think of is going to be if you have silicone stents only and you have a situation that you cannot refer the patient to have some sort of a different approach, obviously you're committed to rigid. In the US, we're very fortunate to have self-expandable Y stents, especially for those carinal areas or very proximal main stem that you know if you put a straight self-expandable metal stent or a silicone stent, it may migrate or it may not occlude. Even though they are significantly more expensive, this can be deployed with a fiber optic bronchoscopy, with an endotracheal tube and do everything under fluoroscopy. I have a video of one of my colleagues in the US that placed a rigid in order to deploy under visual inspection. My approach to put self-expandable wide stent is to do it with a large endotracheal tube and do it everything under fluoroscopy. Surgical approaches, unfortunately we're running out of time and there's a lot of speakers that have great things to share with you. Definitely involve your surgeon early on before we start doing a lot of this, and then make a consensus decision that the best way would be either temporize leading to surgery or maybe directly going to surgery and not instrumentalize an area that is already diseased. Last but not least, pleurodesis, especially in some cases, is necessary. Therefore, whatever pleurodesis you're aware of the chemical or maybe blood patches, it's important to consider pleurodesis as to prevent problems in the future. Definitely the effectiveness in alveolar pleural fistulas that recurred after the second or third episode, we're pretty committed to at least entertain and discuss with the patient. Last slide, prevention and follow-up. Whatever environmental factor is making the lung continue to be diseased, in any way, whenever you put a stent, this patient has to be followed. Whenever you have a Heimlich valve, the patient has to be followed. Have surveillance protocols. The patient gets discharged, cannot go home forever. They have to come back for you to either take valves out or take the stent out or refer to surgery. We do not like patients with devices that we place not following up either with us or somebody that will own them. And the precautions of somebody that has devices of, for example, recurrent pneumothoraces and air travel after procedures. Last but not least, thank you for you to endure a long day of lectures. Thumbs up for the organizers and our docs that work in Yashida hospitals. And if you have any questions, that is my contact email, and I hope to see you on the next Bronchus. Thank you for your attention.
Thank you, sir. Moving on to the next session on advanced imaging and bronchoscopy, may I call upon Dr. Joseph Cesenia to lead the session on AI tomography with augmented fluoroscopy.
Okay, good. There's still people here. Thank you, everybody. So this is a talk that I gave at two of the breakout sessions, and so if you were there, this will be the same one. If not, this will be new to you. So you heard a lot about imaging during the course of the last 2 days. You heard a lot about imaging earlier during the pro-con debate with Drs. Hogarth and Shah. So you hear a little bit about the science behind the imaging right now. So the current challenges that we have in diagnostic bronchoscopy, you already heard this many times over the course of the weekend, is CT body divergence, right? And that's where the nodule is on the planning CT is a different location than where the nodule is during the procedure. And we saw this very frequently, although we couldn't really measure it until we started doing bronchoscopy in the cone beam lab. Right? So when you're doing cone beam CT, you could actually see the location. You could compare it to where the location is supposed to be, and you see this divergence. And that's important because you want to aim at the right target. You want to get your tool in the right target. Dr. Pritchett did a very elegant study several years ago, looking at where the nodule was supposed to be, which is the red, and then comparing it to where the nodule actually was using cone beam CT, which is the blue, and then he measured the distance between the two. And he found that almost a third of the nodules didn't even overlap. 2/3 of them only had minimal overlap. So it just illustrates how much CT body divergence actually happens. On average, it's about, say, 10 to 15 millimeters in the upper lobes, could be 20 to 25 millimeters in the lower lobes, which is pretty significant when you think about it. It doesn't matter if it's electromagnetic navigation or shape sensing, right? There's two different robots on the market right now. One uses electromagnetic guidance, two use electromagnetic guidance, one uses shape sensing. This is a study that shows shape sensing robots. The ION has just as much CT body divergence as electromagnetic navigation. So what's the solution? Well, the solution we should learn from our interventional radiology friends. They put a needle in a nodule, and then they use a CT scan to confirm that it's there. So why couldn't we apply the same bronchoscopy? Just using imaging, let's see if we could prove that our needle is in the nodule before doing the biopsy, or our tool's in the nodule before doing the biopsy. So let's just talk a little bit about what cone beam CT is and digital tomography is. This is your standard CT. This is the CT scan that you use on your patients that you do normal when you want to send for a diagnostic CT. This is the CT scanner that they use. It uses a fan beam, which is a very thin beam of radiation. It comes out like a fan, and it spins around the patient in a spiral fashion. We used to call it spiral CT in the US, but this is just your standard CT. This is not a cone beam CT. Cone beam CT is a completely different principle than this. A cone beam CT uses a cone beam emitter. Okay? It comes out like a cone instead of a thin slice. And as the cone beam emitter emits radiation, it spins around the patient with the emitter and the gantry in the same plane. If it's a wide angle spin, say over 180 degrees, then that's called cone beam CT. If it's a narrow angle rotation, say around 60 to 100 degrees, it's called digital tomosynthesis. So cone beam CT is really digital tomosynthesis. It's just a wide angle digital tomosynthesis. Digital tomosynthesis was first used in breast imaging and breast biopsies. It was more convenient than doing this under cone beam CT. So really all it is a series of images. The images get reconstructed into 3 dimensions, and then you have your image on the right. So why can't we just do this for bronchoscopy? And this is the basis of digital tomography. This is the basis of advanced imaging that we all talked about over the past couple days here. The main difference between beam CT and digital tomography is the depth of focus. Because you have so much more data, because it's a wider angle spin, you have a much deeper depth of focus in cone beam CT than you would in digital tomography. In digital tomography, the only thing that's clear is the center of that spin, which we call the isocenter. So you don't get depth, you only get shallow. So it becomes very, very important to make sure that when you do these spins, you're at isocenter. Here's a perfect example. There's the nodule. As you spin this from 30 to 30, if the nodule is in the isocenter, it will show up on the same exact area on each of those films. So when they're put together by the software, everything looks stacked on top of each other. You get a nice clear image. These are the factors that affect image quality in cone beam CT. The detector obviously is important, right? So the more pixels you have, the more clear the image is going to be. The algorithm that puts all these images together is also important, and obviously the sweep angle, which we already talked about. Isocentering the nodule is super important. This is how lung vision does it. You actually see where the main carina is. You mark the main carina. You compare it to the main carina on the CT scan, and then the software will tell you where to move your C-arm so you get isocenter of the lesion. Galaxy is another technology you saw earlier today. Kyle presented that also uses digital tomography. They use the tip of the scope after a navigation to approximate where isocenter is. These are the images that you get. Look at they're beautiful images. These are images done with just a standard C-arm fluoroscope, not a cone beam CT, a fluoroscope. And these are pretty good high quality images. In addition to the high just get from the digital tomography, there could be post-image processing that could be done to make these nodules look more clear. You could see the same nodule on the left. It's image enhanced on the right to become more dense, solid, and clear for you to see. Here's just representative images over a series of 3 different C-arms. one side is the actual CAT scan image. The other side of this is the reconstructed image that we get off the DT. And you can see the pre-op CT on the left, the SIOS-spin reconstruction on the right. This is the GE 9900. This is the C-arm that I use, a very old C-arm, but a very standard C-arm. You can see the image quality that you get is very, very, very good. How about subcentimeter nodules and subsolid nodules? And again, you could see that on the left of you could see the subsolid nodule, the subcentimeter nodule on the left, beautiful reconstructions we get, and even subsolid nodules at GGO, excellent reconstructions that we get after just a 60-degree spin. So what can we do with this image integration? Well, the first thing you could do is target location updating, right? So you're targeting at the right, you're targeting the right nodule, the right space where the nodule is. You could take that that information, use more algorithm, and do augmented fluoroscopy, which you saw several times already this weekend as well. And then if you really have a supercomputer working with you, you could have targeting functions. And targeting functions work best with robotic scopes that have sensing catheters at the end of them. So it's almost like you're playing a video game. We've seen these videos already this weekend. This is using augmented fluoroscopy to access this. Again, the yellow ball is exactly where this and you could use it both to access and then also to biopsy. And I think we've seen these again already this weekend. Imaging angles are very important. Okay, we've seen several examples of this over the weekend. Remember, just because you're seeing something with augmented fluoro in a coronal view or the AP view, that only tells you where you are in that one view. You could still be in front or behind of the nodule, and you'll never know. So when you use the technologies like lung vision, you have to become adept in looking at oblique views. And for instance, with lung vision, that yellow ball will move with you wherever you go within that scanning range. Okay? So it's a very simple concept. If this is the blue ball and the person there is the nodule, the arrow is your needle, and when you do an AP view, it'll look like the needle is in the nodule. However, when you do a spin, if your needle is not centered, if it's anterior to the nodule, it'll move away. So we have these little conventions that we do. So for instance, if the nodule is in the right upper lobe, you spin to the right, and then the needle moves to the right with it. That means you're anterior to the nodule. We used to have this taped to our C-arm, but it's all embedded in our brain now from doing so many. But you could very easily, using augmented fluoroscopy, understand where your orientation is with your needle in regards to your nodule. And here's a perfect example of that. This is the AP view. You could see where the tip of the catheter is in relation to the nodule. When you spin it to the right, it goes to the left, which means you're posterior to the lesion. The other cool thing that we could do here is targeting, and I'm not going to spend too much time on this, but again, a really nice tool to have because you could literally target right to the center. I find that augmented fluoro is really important. You look at this needle, the needle is going towards, but then diverts away. If you had augmented fluoro, I think Kyle showed this before, you could show your tool going directly into the augmented fluoro image. It goes exactly where you want it to go. The tool and lesion confirmation we've seen several times. The cone beam guys use this a lot, but this is imaging that's done off of a regular mobile C-arm, and you can get really great imaging. This is what I consider exactly what I intended to do during the procedure. Again, small nodule, great images. Small nodule, great images. Tool and lesion images is really what I consider a successful navigation. Lung vision has many other different ways you could look at these nodules and look at the approaches to the nodules. You could, this nice little 3D spin. Again, this is driven off of a 2D fluoroscopy. This is imaging that you would probably get off a cone beam CT. Kyle showed you these reconstructions before. These aren't ready to be here yet. They'll be here in about 6 months. But these are amazing reconstructions that you're getting just from 2D fluoroscopy that are reconstructed using very advanced algorithms, machine learning over tens of thousands of training sets. So how accurate is digital tomography compared to cone beam CT? Well, actually, it's very accurate, within 1 millimeter of each other. So even though you get a slightly lesser quality of image, the information you need to get from it is exactly what you want. Is there data to suggest this? We've seen this all throughout the weekend. Yeah, there is. And the data shows that when you add imaging to your procedure, you get a better diagnostic yield. So to summarize, although cone beam CT, and you've been seeing a lot of that over the weekend, gives you maybe superior images, digital still produce imaging with sufficient resolution to get you what you need, which is basically proper isocentering and tool and lesion type of biopsies. You want target location updating. You want to be able to get your tools into the lesion. It's best, I think, when utilized with augmented fluoro. I think we've proven that with our service in Cleveland, that as long as you learn how to use your augmented fluoro with oblique images, you become a really powerful bronchoscopist. DT could be used without targeting. Targeting will come. Targeting will come once you get your robots here, and you will get your robots here eventually. I think I'll end it at that. Thank you, everybody, for your patience. Thanks for sticking around as long as you have.
Joe, I have one question for you. Like when we use this body vision system,
is there a question?
Can you hear us?
Yep.
Yeah.
Oh, hi.
So when we use the body vision system, like we have the normal C-arms, right, which has a round arm and also flat panel. So the panel for some C-arms is round and some are flat. So what do you prefer, having a flat panel or a round panel for these?
It's hard for me to, we can't hear the questions up here. It doesn't.
Maybe I will come and discuss with you down.
Maybe you think you could come up here? Come up here. Sorry. The acoustics don't work. I can't hear the question. Am I making Harry walk all the way up here? Sorry, Harry. You could have texted it to me.
No, I mean, can you hear me now?
No, it's worse.
So when we use this the normal basic C-arm in the hospital, we have the round panel and the flat panel. Does it make a difference?
So what Harry was asking is, in addition to the augmented fluoro that we get, we also get an overlay of the airways. And we could use those airways to drive out. We could, we could plan a path from the trachea all the way out to the nodule. The path will appear pink and everything else will appear blue. And we could use that as a guide to steer either our catheter. I don't think you have the catheter approved here in India just yet, but you could certainly use a small scope. And you could take that scope and drive it through the airways using that airway tree overlay as a guide. And we do that, we do that pretty successfully too. If you have an idea of the airways, like a lot of you do, because you do a lot of this peripheral bronchoscopy, you could pretty much in your head plan out where you need to go. If you're more of a novice and you need help with, the airway overlay helps a great deal. I don't have the talk in front of me, but you might have seen in some of those in some of the images the airway overlay that we had. So I like using the lung vision. I even use it with my robotic scopes. When I do ion cases, I use it with lung vision. I don't use it with the SIOS integration. I like the airway overlays. I like the augmented fluoro. We use our lung vision by itself. We use our lung vision with our robotic scopes, and we use our lung vision with ultra thin scopes as well. So it's a pretty versatile tool. It could be used in a lot of cases. So if that helps. Okay. Thank you.
We move to the last discussion of the day. May I call upon Dr. Balaraju Tadikonda to address the gathering on airway interventions in pediatric populations.
Good evening all. First of all, I would like to thank Dr. Hari and Team Yashoda for giving an opportunity here. So this is the last talk of the conference, and thanks a lot for being here. So we're going to do in another 15 minutes time, we're going to be as brief as possible. So greetings from Visakhapatnam. This is a coast city in India. So this is what the agenda would be, starting with a brief introduction. We'll discuss about the flexible and rigid bronchoscopic instruments and accessories. We'll discuss a few foreign body case examples and very few case examples on airway tumor debulking. So we're going to start with this. Foreign body is a very, very rewarding procedure because usually it happens in children and the children is in respiratory distress. It's a curative procedure and it's not a diagnostic procedure. Majority of the times you can extract the foreign body and the outcomes are very good and can be discharged as early as possible. And this is the most rewarding procedure in pediatrics, especially in interventional pediatrics to have for. So we have two types of systems, flexible and rigid. So if you want to have the best possible outcome, choose two of the bronchoscopes, 4 mm, 2 mm, and 2.8 or 1.2 or a 3 and a 1.7. Either work will fine. So if you have these two bronchoscope in your armamentarium, to do most of the cases. So coming to the instruments, we have 4 different types. One is a basket, forceps, balloon, and a cryoprobe. If you have the first 3, basket, forceps, and balloon, I believe you can do 80% of all your foreign body cases. If you have a cryo, it's much more advantageous. You can also have specialized instruments like grasp it or a tri-prong forceps. I'm not going to add up much in retrieval. So this is how we use all different types of accessories, starting from basket, forceps, balloon, and a cryoprobe. So these are self-explanatory. We don't have to know further. So coming to the rigid bronchoscopic system, so this is the original system developed by Chevalier Jackson more than 100 years ago. You can see this is a conical tube. This is a conical cylindrical tube. The proximal part is wider and the distal part is narrower. So you need to visualize from the proximal part, then there is no telescopic vision at that point in time. So you'll have an end-on view, very narrow view. So if you think this is the challenging part, and believe me, you have to pass an instrument to hold the foreign body. And this is not so technically easy. So the current system where you can use a telescope to magnify everything and project it over the monitor, and you can use an optical forceps where you can combine the vision and the instrument in one way, is going to be a much advantage. Why I've shown you this slide is many of the times if I say rigid bronchoscopy in pediatric population, everybody is skeptical, should we do it or not? So if you look at the current system, it is very, very easy. So these are the different types of rigid bronchoscopes available. And different adapters. So we're not going to go and discuss about each and every part of it. So this is what we are focused on. In rigid bronchoscopy, the instrument we have is an optical forceps. I have told you we can combine the vision and the instrument. With one single hand, you can retrieve the foreign body. So these I call the simple distal foreign bodies where there is no much of granulation, no big obstruction, no big problem you have to manage. Either you can use a rigid system or a flexible system. Rigid with an optical forceps, flexible with a basket or a forceps, you can retrieve the foreign body. So this doesn't cause major problems. So if you have a challenging case, like this case of a distal airway foreign body, when there is no space around. So if you don't have any space around, all your instruments like basket, balloon are going to fail. So in this case, the basket has failed. So what we had to use a cryoprobe to disimpact the foreign body. So once you disimpact the foreign body and get it proximal, it is very, very easy to retrieve again with a basket or a forceps. So in this case, cryo was a major advantages where I could able to disimpact the foreign body proximally and extract it. Obviously, it has gone to the other side, but it is not a problem. We used a basket to extract it. So what if you have a foreign body with a proximal granulation? This is a 4-year-old child, chest X-ray, some consolidation. In the CT also you can see the consolidation there. So what was happening was, so when you do a bronchoscopy, you can see a polypoidal lesion just proximal to the foreign body. So used a snare to address the granulation first. So address the granulation. Once you address the granulation, if you remove the granulation, then you are able to see the foreign body deep inside. I'll agree there is some part of granulation which is left out. The challenge is to, once you remove the foreign body, believe me, you don't have to think about the granulation disappears. Here I used a balloon initially to proximally balloon failed, so I had to use a basket to retrieve it. So the idea I want to convey here is, so sometimes you will see foreign body with proximal granulation, and you need to address the granulation first, either with a hot therapy or a cold therapy. Either one should be fine. Yeah. So this is not my case, this is Hari's case. What if you have a distally impacted foreign body where visually you can't see with a bronchoscope? So there you can use a C-arm for your help to retrieve the sharp object with a forceps under the C-arm. So this is a challenging case, a 10-month-old baby presented with a foreign body of a LED bulb. So in the right side, I thought initially it is in the right main bronchus, but it is far deep inside. It is in the right lower lobe bronchus. So the CT shows the same thing. So initially did a rigid bronchoscopy. So we saw some secretions there. So once you clear the secretions, what you can see, so that's the lower lobe bronchus. You can see the middle lobe bronchus there. The foreign body is deeply impacted in the right lower lobe bronchus. So initially tried with an optical forceps, not able to reach the right lower lobe bronchus with an optical forceps, had to rethink to do what next, change to a flexible bronchoscope through the rigid bronchoscope. So used a 1 mm biopsy forceps. So once you grasp the foreign body with an 1 mm biopsy forceps, and you can safely retrieve it proximally, and then you can extract with either with the same forceps or with an optical forceps. The point I wanted to make here is sometimes your rigid bronchoscopy can fail. So the reason because it is a distally impacted foreign body and it's a 10-month-old child, the optical forceps was too large to open there, whereas the 1 mm biopsy forceps was enough to open there and to get the foreign body proximally. So this is what I want to convey. So another challenging case, the bilateral airway foreign body, you can see the endotracheal tube there. The right upper lobe is consolidated. The endotracheal tube is mildly towards the right side. So once you see the endotracheal tube going off, and there is a foreign body there in the right intermediate bronchus, and another foreign body in the left lower lobe bronchus. So this is a bilateral airway foreign body. Baby is arrested in the ER, intubated, did a CT scan, and this is what the result was. So there was one foreign body in the right intermediate bronchus and another one the left main bronchus. And the only patent bronchus is the right upper lobe, and that also it's consolidated. It was a challenging case for us to do, and the initial diagnostic bronchoscopy shows the same thing. So we had a greater problem in ventilating this child. So while retrieving the right foreign body, I have inadvertently pushed it inside. It was a greater help for me. So once I pushed it inside, I was able to ventilate the child much better. So I was able to retrieve the right main intermediate bronchus foreign body with an optical forceps, and the left main bronchus foreign body I had to retrieve with an balloon. So just want to highlight the use of both systems. Neither is superior to other. So if one fails, other should be at help. So this is another interesting case. 4-year-old child presented to ER in the middle of the night. So he came whistling, saying that it's a subglottic whistle which is got stuck, impacted, and saturation drastically dropped to 80% in 15 liters, and PCO2 was 60, and baby was gasping. So initially tried retrieving with an optical forceps, not able to retrieve. So I had to push it down, catch hold it again, and try to retrieve. During this time, so when I was able to retrieve it, one of the jaw of the optical forceps has broken. So now I have created another foreign body inside the airway. So the other luckily I had a spare optical forceps at that point in time. First I was able to retrieve the foreign body, what I have done. So after that, what can we do? So we can do a tracheostomy to extract the foreign body, or you can do something else to extract the foreign body. That was serial dilatation of subglottis with increasing size of rigid bronchoscope. The problem is at the subglottis, it's not able to coming out because of the edema, and also of this, because of the edema is not able to come out. So we gently dilated the subglottis with increasing serial sizes of bronchoscope. We were able to retrieve the foreign body. So the idea was telling you is, so if you have a tight subglottis, in certain cases you can gently dilate it and use the best forceps available to retrieve it. Another case, foreign body presented with an obstructive hyperinflation and pneumothorax with subcutaneous emphysema. So you can see there, that's the carina, and that's the right main bronchus. There is a foreign body, and the right lower lobe bronchus is patent. So that's a foreign body in the right side. Basically, why this happens, this subcutaneous emphysema, initially you have a ball wall mechanism on the right side. You'll start developing pneumothorax, then it ruptures, and you'll have a subcutaneous emphysema. Luckily for this child, all the parts of the con are on the right side, so we're able to retrieve it, and believe me, the subcutaneous emphysema disappears. So this is another challenging case. This is a 2-year-old boy, again presented with similar condition. So we did a CT scan, it shows that there is something in the right main bronchus, and the right lower lobe bronchus is patent. Young boy, sudden onset of breathlessness, cough, diminished breath sounds on one side. Chest X-ray was showing an obstructive hyperinflation and some subcutaneous emphysema. Initially, we thought it was a foreign body. We did a diagnostic bronchoscopy. To our surprise, there was a large mass sitting in the right main bronchus. This is a 2-year-old child, and he was crashing. So we had to do something else. So that initially what we did was, we did probe cautery on the mass and extracted piecemeal. We did a debulking, piecemeal debulking, and we got a good airway patency, and it turned out to be a PNET tumor. And this is the X-ray day 2 post-op, good expansion of the lung. And still the baby is still good. Post-chemotherapy is still doing fine, is still in follow-up. So this is another case. A 7-year-old girl, again presented with collapse on one side. So if you can see the flexible bronchoscope, you can see a large mass sitting on the right main bronchus. So this girl rapidly deteriorated, requiring more oxygen and ventilation. So we had to do a debulking. So initially we talked to the family of placing a child on ECMO if the things go wrong. So but luckily we were able to retrieve it. And so this was in September 2019. In December 2019, when we did a repeat bronchoscopy, it was showing there was a few bumps on the mucosa, but nothing much. So this is after 4 years, in June 2023, and this time we didn't want to do any more. So we did a sleeve resection. To my good friend, Dr. Mohan has helped me in this. So still the baby is in follow-up. He did a sleeve resection and anastomosed the distal bronchus to the carina. And still the baby is doing fine. This is the last case I'm going to show you. An 8-year-old boy with a large tracheal mass presented with stridor and respiratory failure. As you can see in the diagnostic bronchoscopy, you can see a large mass moving in and out of trachea during respiration. That's the reason the baby has a significant stridor. You can see the amount of obstruction in the airway. So because it is a polypoidal mass, used a snare to extract it, and this didn't had major bleeding. We were ready with backup, and we were able to extract the mass. It turned out to be a benign glioma. To summarize, I feel each case of foreign body aspiration is unique. You should follow principle for safe removal. Rigid bronchoscopy is a time-tested system. I don't think physicians should be worried about whether should you do it or not. So for impending respiratory failure, rigid has a better control of ventilation than compared to a flexible. So if with rigid, you can be used as a conduit just to perform a flexible bronchoscope. And for rigid, for sharp foreign bodies, rigid is the best system. And for distal airway foreign bodies, rigid has a drawback and flexible is superior. And I believe there is no single best instrument for all the foreign body cases. Rigid or flexible, both are on par with each other. Either one can fail. Thanks for your patient listening. I finished in 15 minutes.
Thank you, sir. The last presentation for today is via Zoom. We have our Chinese colleagues connecting with us. Dr. Li Zhu will be presenting on the new Sigma-covered airway stents.
can present now. Hey, Kathy, are you ready?
Yes, share my screen.
Yes. Yeah.
Check. So I think Kathy's mic is off. So I'll present, this is Professor Lee. He'll be talking on, he'll be showing us a new metallic stent that he developed for treatment of benign and malignant airway disorders. So the advantage with this is it has got a metal and silicon embedded in the same stent. So you have less chance of migration and also less chances of granulation. So we have this stent on display today in this stall. So he will be presenting us the video on how to deploy these Sigma covered airway stents, what we call. Can you please play the video? No, let her. Yeah, she shows the treatment plan. The plan is to put the stent in this patient, and in this video demonstration, we see how Professor Lee implants this new Sigma covered airway stents. I think Professor Lee is doing a diagnostic check bronchoscopy to make the planning. You can see there is obstruction of the right main bronchus.
Now the assistant marks length or using the flexible bronchoscopy. Okay. What I understand from the video demonstration is patient is having a right main bronchial malignant area obstruction. And then professor is putting a guide wire. And they railroad the stent over the guide wire. It's interesting to understand how they manipulate the rigid loader at the cords, but he smoothly executed that. And then remove the guide sheath. What I see is like they don't use the fluoroscopy anymore. And then he completes the placement. And the loader is removed from the patient, and they perform a check bronchoscopy to see how the stent deployment looks well placed in the right main bronchus. It's a kind of hybrid stent which has metal and silicone embedded. And then you can see the perfect placement in the. We have the initial display of these Sigma covered airway stents for those who want to have a first-hand experience at the stalls named FTM. You can visit there and then see the how I can feel the radial force also. You can understand how much it helps. We have seen some cases being done in China with good results, especially in patients who have lung transplant related anastomotic stenosis. These stents are very useful because many times it becomes a challenge to place silicone stents in those areas of the anastomotic stenosis. So because you have silicone covering over this metal, you can just easily place them and then remove whenever you need that. So that completes the presentation of Sigma covered airway stents by Professor Lee, and we thank them for showcasing this case. Thanks for watching. So
So we come back here in 10 minutes, and then we have results of the Best Image Challenge for 2025. We take a short break for 10 minutes and then gather here for image contest. BRONCHUS Image Contest 2025 with some exciting prizes.